of Hormone India 2022 conference. This is our first conference and it is in virtual format. So in the Hall B, we are organizing the first session. So the topic is frequently encountered but infrequently discussed problems that we see in diabetes, people with diabetes. So we have 4 chairpersons and 4 speakers for this talk.
So let me take opportunity to first introduce Dr. Tony. He would be the rapporteur for this session. Let me reintroduce Dr. Tony. So we had a very good session since morning, from SMVGs to insulin pump to clinical examination to digital technology. All those young diabetes sessions and GDM session are yet to come in Hall A. And now we are starting with frequently encountered, infrequently discussed, those topics which are very relevant clinically but are not discussed among the doctors that much. So for that, I welcome our first session rapporteur, Hormone India rapporteur, that is Dr. Tony. He has done his DM endocrinology from SGPGI. He was my senior and presently he is heading Hormone India team at Trivandrum. Over to you, sir.
Okay, thank you. So I'll straight away start by introducing the chairpersons who will be introducing the speakers for the day. So can I please have the slides of the chairpersons? Tech team, can I please have the slides of the chairpersons? Okay, thank you. So for this session, we have 4 chairpersons. Dr. R.S. Jagat, he is Associate Professor, Gandhi Medical College, Bhopal. Dr. Promise Jain, he is a Senior Consultant at Kiran Diabetes Chest Center, Sagar, MP. Dr. D.P. Singh, Professor and Head, LN Medical College, JK Hospital, Bhopal. And Dr. Shivendra Verma. So I think Dr. Promise Jain sir has joined in. So sir, can you introduce our first speaker, who will be Dr. Subodh Jain. Dr. Ajay Shukla sir has joined. Yes. So sorry. So Dr. Rajesh Agarwal sir, you will be the first speaker. So Dr. Promise Jain, can you please introduce Rajesh Agarwal sir?
Yeah, sure. Kindly share the slide of Dr. Rajesh Agarwal sir. Good afternoon, everybody. And we have the MP-UP combination in this Hormone India. Basically 4 chairpersons and 3 of them from MP and 1 is from the Lucknow. And in this session, we have the 3 from the Lucknow, 3 from the UP as a speaker and 1 from the MP as a Dr. Rajesh Agarwal sir. Welcome, Dr. Rajesh Agarwal sir. Can you hear sir Agarwal sir?
Well, I want to take you at a new therapy, biomarkers.
Yeah, so basically Dr. Rajesh Agarwal sir is from the Indore and he is a renowned diabetologist and he is doing very good in the field of diabetes with the 300 articles in the national scientific journals, including the International Director of Alliance International, and he has honored with the Limca record with the some kind of the activity in diabetes. And I welcome Dr. Rajesh Agarwal and I request to Dr. Agarwal sir to start session. Dr. Agarwal sir.
The incidence of diabetes, if the GGT was higher.
Sir,
am I audible?
Yes.
Yeah. Just a minute to share my slides. Okay.
Suggested body mass.
Slides are visible now?
Yes, sir.
Yeah, sir. Go ahead, sir. It's visible, sir.
So thank you very much. First of all, at the outset, I must congratulate and thank Mayur Agrawal and Team Hormone India, who is arranging such a wonderful meeting and giving me this opportunity to speak on new onset diabetes after transplant. It is known as NODAT and sometimes also known as post-transplant diabetes mellitus or diabetes after transplant, and sometimes acronym is used DAT. So what is new onset diabetes after transplant or NODAT? It is a diabetes occurring in previously non-diabetic person after solid organ transplantation. And why it is important to discuss the NODAT? Because it increases the risk of infection and mortality as compared to classical type 2 diabetes or in a non-diabetic, in a traditional diabetes, and also increases the risk of graft rejection. We all know that diabetes is increasing and lot of financial burden on the population and government and family. Why I put this slide? Because to best is prevention. So if we prevent diabetes, so also complications of diabetes, and then transplantation will also be reduced, and so post-transplant diabetes will also be reduced. So that is the purpose of putting this slide there. The overall incidence of NODAT is 2 to 53% of all solid organ transplantation, in up to 25% in renal and liver transplant, you can see over here, and 30 to 40% in lung and heart transplant. While the incidence is much less than 10%, it is in bone marrow transplant. So the range is depending on the various factors like age and population studied and the various other factors. So this is another graph showing the incidence of type 2 diabetes, new onset diabetes after the renal transplant and after heart transplant. And most of the data are with renal transplant. So you can see the increased risk. And this is the Canadian exposure following the kidney transplantation. The risk of NODAT is increasing. The risk factors for NODAT are the patients who are having pre-existing risk factors for developing type 2 diabetes like family history, obesity, and insulin resistance, signs of metabolic syndrome are more prone to get new onset diabetes. And these are various non-modifiable and modifiable risk factors. Non-modifiable risk factors are age of the patient, age of the recipient, as well as of the donor. They are very important, and male sex, both recipient and donor. And age, male recipient and higher the age, more will be the incidence of NODAT. And African Americans, Hispanics, HLA mismatch, polycystic kidneys, and various genetic alleles, they are non-modifiable risk factors. Then hepatitis C virus, cytomegalovirus, pre-transplant glycemic status, proteinuria are other risk factors, including hypomagnesemia. And then modifiable risk factors are immunosuppressive therapy, most commonly steroids, cyclosporine, tacrolimus, calcineurin inhibitors, mTOR inhibitors, that is mammalian target of rapamycin inhibitors, then monoclonal antibodies, and various other risk factors for metabolic syndrome. So age has peculiarity. These are the data from United States renal data system, that older the age of donor and male sex is a strong independent risk factor. 90% increased relative risk in kidney transplant recipient aging 45 to 60 years, and 160% increase in risk if recipient is more than 60 years versus 18 to 44 years of age. These are the data from 34,000 liver transplant and 50,000 kidney transplant. The donor age, if it is 41 to 60 years, had worse survival outcome at 3 and 12 months than those who are less than 40 years of age. This is donor's age. Better survival outcome than those who are more than 60 years of age. Then ethnicity relative risk of NODAT is 30 to 68% in blacks and 35% in Hispanics as compared to whites, probably because of the genetic diversity and variable effects of immunosuppressive agents in this ethnic population. And tacrolimus is a potent cause of NODAT in blacks, specifically in blacks. These are various genetic alleles and association. We will not go into the details. Then pathogenesis of NODAT with immunosuppressive agents, be it glucocorticoid or calcineurin inhibitors, tacrolimus and sirolimus, which are the most commonly used drugs. So we know that steroid causes gluconeogenesis and decreases fatty acid oxidation, glucose uptake, glycogen synthesis are inhibited, and redistribution of body fat all leads to insulin resistance. Then these immunosuppressant drugs, they cause mitochondrial dysfunction, blood protein expression. They also inhibit beta cell proliferation and function and increases the beta cell apoptosis. To combine all these factors, there is insulin resistance and insulinopenia leading to the new onset diabetes. Obesity, we know that it is a pro-inflammatory condition, and it increases the TNF alpha and interleukin-6 synthesis. Insulin resistance and diabetes causes insulin resistance and diabetes. And there is also reduced adiponectin secretion, which is already low in patients who are undergoing transplant, and it is protective for diabetes. Then various medications. The only thing regarding the medication is glucose intolerance is reversible with these drugs, that is calcineurin inhibitor and tacrolimus, sirolimus, and know that is significantly higher in patients with tacrolimus as compared to cyclosporine, and it has an impact when manage NODAT. The patients who develop NODAT, then we may have to switch over from tacrolimus to sirolimus. Then steroids, they increase the important thing regarding steroids is the dose and duration of the therapy and post-transplant steroid dose, and that increases the risk of NODAT by 42%. Excuse me. Then hypomagnesemia and viral infections are there, and hepatitis C virus infection. Positive patients has 25% incidence of NODAT as compared to 14% with hepatitis C virus negative. And tacrolimus, if used in hepatitis C virus positive patients, then the risk is increased for new onset diabetes. The cytomegalovirus infection and calcineurin inhibitors, hepatitis C virus inhibitors, there is no clear relationship is found between cytomegalovirus infection and the risk of type 2 diabetes mellitus in general population, but in NODAT, their association is clearly established. To diagnose NODAT, fasting and post-meal plasma glucose to be taken into consideration. Regarding the word of cautious about A1C, because it is not recommended in first 3 months because of the altered RBC lifespan after transplant due to various reasons like transfusions, immunosuppressant, and hemolysis. So don't rely only on A1C for the diagnosis of NODAT or new onset diabetes in post-transplant period, immediately post-transplant period. And what are the consequences of NODAT? Are decreased graft function because of the diabetic nephropathy, hypertension, or lower immunosuppressant doses. Decreased patient survival because of increased incidence of sepsis, infection, and cardiovascular disease, and increased risk for cardiovascular disease because of all known reasons: hyperinsulinemia, glucose tolerance, hypertension, dyslipidemia, and insulin resistance. These are 2003 international consensus guidelines to evaluate the patient pre-transplant, and as usual, complete history, glucose, glycemic status, and high-risk patients should be identified. Then counseling should be done to reduce weight, diet, and exercise. And pre-transplant treatment of hepatitis C virus should also be taken care of. In post-transplant period, individualization of the immunosuppressive therapy, fasting plasma glucose weekly for first month, then at 3 and 6 months and 12 months, and then at least annually after first year, and depending on clinician's acumen, it may be discretion, it may vary earlier or later. And oral glucose tolerance can also be considered. This is the same, but those patients who are found to be NODAT positive, they should be taken fasting plasma glucose, lipid levels should be carefully monitored, A1C and diabetic complications should also be taken care of. And this is CGM after kidney transplantation in non-diabetic patients. Early hyperglycemia is very frequent and may herald post-transplantation diabetes mellitus and graft failure. So it can be used in hyperglycemia, appears to be a nearly constant characteristic immediately following transplantation in non-diabetic kidney recipients. And higher blood glucose values could identify patients at risk for later on new onset diabetes. A word about insulin, RSSDI recommendations that insulin therapy should be a preferred choice during the first 1 to 2 months of time post-transplant. and later on the treatment should be, diabetes should be managed as standard protocol. The patients who develop new onset diabetes, there should be modification of immunosuppressive medication depending on the condition, rapid steroid tapering or steroid sparing protocol, tacrolimus or cyclosporine therapy should also be considered, and calcineurin inhibitor and mTOR inhibitor combination should be avoided because they have increased risk of new onset diabetes as compared to other immunosuppressive agents. And rest of the management of diabetes is as per standard protocol. We will not go into the details because most of the things are already discussed, and Dr. Mayur is there who is taking all the topics to cover it. So no-date prognosis is associated with higher mortality compared to type 2 diabetes, higher graft rejection. Graft survival in no-date is 48% versus 70% in patients without no-date. And diabetic microvascular complications develop very rapidly in new onset diabetes as compared to classical or traditional diabetes mellitus. So it should be taken care of. Then this is China liver transplant registry data, no-date after liver transplant, median follow-up of 2.6 years. And no-date predictors are new onset hyperglycemia less than 30 days, ICU stays more than 15 days, and age more than 50 years, BMI more than 25, hepatitis C and cytomegalovirus infection, again corticosteroid at discharge. One interesting finding was from this study was, this registry was, patients of no-date who are on hypoglycemic treatment had poor prognosis and higher hepatocellular carcinoma recurrence as compared to those who are without treatment. Then no-date after heart transplant. This is this data from more than 300 heart transplant, and incidence is 32%. Risk factors are again same: BMI, cytomegalovirus infection, and age. No-date after kidney transplant. In calcineurin inhibitor, it is 20% about, and that is it develops just within first 6 months of the transplant in calcineurin inhibitor patients. And after lung transplant, you can see it is from the organ procurement transplant network. More than 3,500 single or double lung transplant, and no-date incidence is 33.4%. And the risk factors are again age, BMI, and hepatitis C virus infection. No-date after allogenic hematopoietic stem cell transplantation, that is bone marrow transplant, is incidence is 6.5%. These are the incidence from 600 adults with various hematological malignancies.
Sir, sorry for interfering. So 2 more minutes, sir.
Yeah. Okay, I will finish in 2 minutes. Okay. Cautious use of SGLT2 inhibitors. This is review of literature and meta-analysis, 16 studies and 300 patients. Is found to be safe in short term, but should large studies are required. Another study, another review of literature, 9 studies, 140 patients. Again, it is safe, and they have planned a new registry because of the limited evidence in this population. Another review of literature, 6 published studies, and they says that there is no risk of rejection or diabetic ketoacidosis, and safe in short term, but large long-term randomized controlled studies are required. So take-home message is incidence of no-date is up to 50%. It is positively associated with pre-transplant glycemic status and obesity. Advancing age and male sex are important risk factors for both recipients as well as donor. Immunosuppressant drugs, steroid dose and duration, also hepatitis C virus and cytomegalovirus, they also contribute to the incidence of no-date. No-date is associated with decreased survival and increased graft rejection. A1C should be carefully or judiciously analyzed in first 3 months. And word of cautious use of intensive insulin therapy and glitazones and SGLT2 inhibitors because of the risk of pyonephrosis, sepsis, and should be kept in mind. Thank you very much. I have finished in time. Dr. Tony?
Yes, sir. Yes, sir. Thank you. Thank you.
Yes, sir. You are in time, sir.
Yes. So,
Thank you very much.
Thank you, sir, for that wonderful talk on NODAT. So we are running a little late, so we can go to the next talk by Subodh Jain, sir. So DP Singh, sir, if you are available, sir, please introduce our next speakers, Dr. Subodh Jain, sir.
Good afternoon all, and thank you Hormone India team for giving this opportunity to share this platform with you all the eminent speakers and large number of delegates. As we all know, diabetic foot is very common and related complication, which can lead to even amputation and permanent loss of foot, and even it can lead to death due to sepsis and second infection. So in this important aspect, we are having Dr. Subodh Jain. Dr. Jain graduated from Denmark and completed his post-graduation also from there. He is Director of Diabetes Care and Research Center, Prayagraj, since 2022.
Yes, sir.
He is also in different affiliation and different large number of publication in different index and international and national journal. So now over to Dr. Jain for deliberation on this important topic. And so welcome. I would like to welcome Dr. Jain for his deliberation.
Sir, you're mute. Subodh, sir, you're mute. Subodh, sir, please unmute yourself.
Can you hear me now?
Yes, sir. Yes.
Yes. Okay. Thanks for the kind introduction, Dr. DP Singh. And firstly, I would like to congratulate particularly Dr. Ajay Shukla and Dr. Mayur Agarwal for conducting this wonderful Hormone India conclave. And Dr. Tony Joseph also. So my task is a bit clinical one, the examining foot and shaving amputations. As we are aware that
full screen mode, sir.
Can you see my slides?
Yes, sir. Slides are visible.
Slides are visible. Okay. So the most common complication of diabetes, type 2 diabetes particularly, is neuropathy, and the foot comprises of, because of this most common complication, there are foot complications are there. So next.
Sir, can you please make in full screen mode, sir?
It is in full screen, I think so. Full screen.
Okay, sorry, we are seeing it.
Okay. It's in full screen mode, I think so.
No, sir.
No.
So you can put it in a slideshow mode.
Okay.
The right sides or from the up also screen.
Okay. Slideshow.
So up.
Yeah.
Yes. This side is done.
Yeah. So as it's a very famous saying that coming events cast their shadows first. So it's very important to identify the foot at risk just by examining the foot. So unfortunately, it's a taboo, or we don't see our patients or don't allow them in clinic coming barefoot. So in my clinic, I have made a custom that you should come, as you come inside my clinic, you put off your shoes, you put off your socks, so that they think it's maybe due to some other cause, but the first and foremost important that I can examine the foot right as the patient enters the examination room or in my clinic. So the pathways to foot ulcerations are many. It is the peripheral vascular disease. The commonest is the somatic neuropathy or the sensory motor neuropathy, and then autonomic neuropathy. So this Rothman model says that if any two factors are present, they are sufficient to cause ulceration. As we know, the peripheral vascular disease, it was supposed to be the disease of the Western country or the Western people population, but now as with the investigations we found it is very common in our population also. So the sensory motor neuropathy causes the small muscle wasting and the insensitive foot. The pain is supposed to be most wonderful gift given to the human mankind, because if you have pain, you will come early to the doctor, and any kind of injury to a sensitive foot brings the patient immediately to the doctor. Insensitive foot or painless foot, they do not come to the doctor or the physician, and then they keep on injuring their foot on a regular basis. So that leads to infection and leads to the other. So the autonomic neuropathy is associated with somatic neuropathy in most of the patients, and that leads to there is decreased sweating, dry skin is there, callus formation is there due to the unequal pressure distribution on the foot or increased foot pressure. Most of the diabetic patients with prolonged diabetes duration, they have limited joint mobility, LDM we call it, and that leads to unequal distribution of the foot pressure. So these all factors, they lead to the formation of callus, dry skin particularly, it cracks, and there is a neuropathic ulcer or neuroischemic ulcer. Peripheral vasculitis directly can lead to the ischemic ulcer, though it is rare. The combination of the neuropathy and the ischemic foot, they lead to the neuroischemic ulcer. The autonomic neuropathy can also lead to the altered blood flow. There is stagnation of the poor venous return is there, stagnation of the blood flow is there, and distended foot veins are there, worn foot is there, and this is at-risk neuropathic foot and can lead to the pure neuropathic ulcer also. So any two factors, when they are combined in a single patient, they can lead to foot ulceration. So as has been said, the topic given to me is the examination of the foot. So examination of the foot is very important. The American Diabetes Association has come up with a comprehensive diabetic foot examination. The task force, they developed this as a protocol, and when you inspect the foot and ask the history, a good history will elicit that whether the patient had any ulcer in the past, or is there any an ulcer is present or not. The foot shapes, the calluses, you can see that at very prominent metatarsal heads, there are very common sites where they develop this heel area or the hallux, the intertarsal heads, they develop the calluses that can be seen. The ulcers, these calluses, with the combination of the dry skin and increased foot pressure, they crack and they tend to develop ulcers. These are the superficial ulcers. Then the shape, particularly the hallux valgus, and the small muscle wastes, due to the motor neuropathy, they tend to develop the calluses over these, and then they ulcerate. So this is the Charcot foot, the very common example of the neuropathic foot, and due to the destruction of the bones, the abnormal shape of the foot, the abnormal foot pressure distribution, they tend to develop this callus. Now we come to the second part, the prominent metatarsal head, plateaus, hallux valgus, muscle wasting, Charcot deformity in the neuropathic foot. The dermatological causes may be the examination. We can see the callus, the erythema, and sweating. We can examine by inspection the erythematous or the infection is there, and the absence of sweating. The neurological, the examination part comes, the most important or very simple or very cheap investigation is just by doing a 10-gram monofilament examination. So by 10-gram monofilament, you can examine the patient at different points, and you can write it down, and very certainly we can discern that this patient is having peripheral sensory motor neuropathy or not. So once it is detected, this foot is kept as a foot at high risk. So these examinations, they don't take much time. If one is very much conversant, what to do, it can be done within minute. It doesn't take much time. So the other test, the tuning fork test for the vibration potential, the 128 Hz, we can see for the large fiber, and this is monofilament test, the pinprick for the small fibers. We can test the temperature and the sweating for autonomic functions. This neuropad comes, say 10 minutes, you apply this neuropad and it turns from blue to pink. And this shows that whether sweating is present or not. So by this, you can also detect the autonomic neuropathy. So these are very simple tests. We do it for the proprioceptive sensation, for the large fiber sensations. Then motor functions, the muscle wasting may be there. The increased foot pressure, we can examine by this harassment. So this increased pressure, as we show by simply by this harassment, we can detect it. So though this is not a quantification of the test, but you have a clear-cut idea that this foot is at risk and the patient will develop callus and ulceration over this point. Another is for the circulation. For circulation, we can have this handheld Doppler. You need not to send the patient for the Doppler study or the color Doppler for the limb vessels, because he has to take appointment and he has to, it takes quite a long duration, or it consumes very much time for doing color Doppler test. But this handheld Doppler, we can see the circulation in the patient's foot. For ABI, we can go for ABI. These are the machines, they are available now, easily available, and one can do for the circulation of the lower limbs, one can go for the ABI. So though it is not required clinically in each and every patient, once you suspect that this patient might be having ischemic ulcer, you should go for ABI. Though the limitations are there. The classification of the ulcer, the most common classification, we go for this Wagner classification. 0 to 5, we grade it. 0 means no ulcer. 1 is superficial, 2 is deep ulcer, may involve tendons but not bones. The 3 is deep ulcer with bone involvement and osteomyelitis. The 4th is the localized gangrene of the particular 1 or 2 toes, while the 5th is the CVS one, the gangrene of the whole foot. This is the grade 5 maggot by the classification of maggot Wagner. The most common classification, the maggot Wagner classification, was deficient in telling the infection part. So this University of Texas ulceration classification came that it also take care of the infection, whether infection is present or not, ischemia is present or not, or infection and ischemia both are present. So they stage it from A to B. Clinically, we can very easily say that this foot is in stage A, grade B, 1, 2, or 3. So superficial ulcer, grade 2, deep ulcer with tendon and capsules. The probe is there. By probe, you can detect whether it is bone deep or it is involving joints also, whether presence or absence of ischemia and infection is there or not, or both are present. So this is very useful classification, University of Texas classification, but they do not predict the 1-year risk of amputation, limb amputation, as my topic is save amputation. So one should be able to predict whether this patient is going to have amputation or we can salvage the limb, and what are the possibility of the revascularization. So for this, another classification has come up. This is the Wi-Fi classification. This is the most advanced classification. The Wi-Fi means the wound, and ischemia, I for ischemia, and then Fi is for the foot infection. These 3 components, when they are graded and when they are taken into the consideration, one can predict very easily. So this is a very useful classification. It has got 3 components. rather 4, the 0, 1, 2, 3 grades in each of the component. And the wound means no ulcer, 0, absence of ulcer. 1 is the small or superficial, like the in Wagner classification. Deep ulcer in the wound or with the limited digit loss, that is the with or without skin cover, the metatarsal loss. Then deep extensive ulcer involving forefoot, this is the grade 3. Midfoot or calcanean involvement, and with extensive gangrene. The ischemia is taken care of by examining the ABI. So if
excuse me, sir, less than 2 minutes.
Yeah,
sir.
yes, yeah, I will cover it. I will cover it. So by doing ABI, we can classify them, and then foot infection. So with this classification, it has been shown that up to the sensitivity and sensitivity of the 90%, we can predict the 1 year risk of amputation and the possibility of the revascularization and the salvage of the limb. So now comes the part, the third part. Once you have examined, how can you prevent? So preventing from amputation, the key component is the patient's education. So what are the things, at what points we can emphasize patient education, that if it is a patient is having sensory motor neuropathy, he is on examination, we have detected that he is having decreased pain and proprioception, then daily fit, the foot at risk we have examined, and then we can educate the patient for daily fit examination, check inside the shoes, don't walk barefoot, measure with the hand, don't use blade, and a neuropathic foot, the moisturizing, use of moisturizer for the dry foot, then regular podiatry, well-fitted shoes and insoles, then the repetitive, one should be able to avoid repetitive trauma. And once the ulcer is there, if the patient is having foot ulcer, the address to the offloading, which is the main thing which can prevent, which can heal the ulcers, foot ulcers, and prevent amputation. Thank you. Thanks.
Thank you, sir. I think Dr. Alok had joined. I think we can go ahead with the session. Dr. Alok, sir, you are there?
Hi.
Okay. So, Dr. Tony, please go ahead, sir.
Yeah. Good evening, Dr. Alok. So, is Dr. Promise Jain available? Can you please introduce Dr. Alok? Can you bring up the slides for Dr. Alok?
Team, kindly display slides. Dr. Alok is a well-known oncologist working at Gorakhpur. Please display the slides.
Okay, so I'll only introduce sir. So Dr. Alok Tiwari sir, he is a surgical oncologist. He has various degrees to his credits. He is the HOD Department of Surgical Oncology Director, Synergy Institute of Cancer Care and Research, Gorakhpur. He's visiting consultant in various hospitals, and he has various awards. He has won various awards to his credit, and his specialty interests include surgical oncology, breast cancers, colorectal cancers, hepatobiliary and pancreatic cancers, bone, gynec-oncology, and robotic surgery. So over to you, sir, for the next session.
Thank you, Dr. Tony Joseph, for introductions. Thanks, Dr. Mayur and Ajay and the Hormone India team for providing us this opportunity. So can you display my slides? I had actually some important case, so I had sent my slide to upload to them. Mahima can do this.
Yeah, just a minute.
Yes, ma'am. Yes, sir. Just a second.
Yeah.
Thank you.
Yeah. So my topic is diabetes is causally related to the cancer. So one of the very common thing that we used to see even in our clinical practice, that in our OPDs patients are coming with cancers of various sites. They also commonly have diabetes. If you see that even every day in Gorakhpur data we had are not yet matured, but nearly or 34% of patients has diabetes mellitus or some kind of metabolic syndrome. So though evidences are, kindly change the slide. So though evidences are not yet completely mature that whether diabetes is particularly causing some cancers or it is related to some site-specific cancers, but if you see that there are certain cancer like pancreatic cancer and liver cancer, there is clear-cut association between the diabetes and the cancer of the sites. If we go by the epidemiological studies, then there is many studies like Patel's Jejuna Patel studies or Obesity studies where we find that the hepatocellular carcinomas, colorectal carcinomas have increased risk with metabolic syndromes, and nearly 81% risk increase of hepatocellular carcinoma is. Can you please change the slide? So there is associated risk with the diabetes and cancers. And if you see the mortality wise, the diabetes cancer is causing second biggest cause of the death. And this particularly true for developed countries, and where the diabetes is causing 12th most common cause of death. In our country, the problem with we don't have proper cancer registries, and neither we have knowing exact incidence of diabetes too. So we can't say particularly data for India what is true. But cancer and diabetes, we are diagnosing in the same individual, those who have some common risk factor. So please change this slide too. So there is one discussion that whether the relationship between the diabetes and cancer is actually there, or there is the common factors that is causing both disease. They are contributing to this. And there is any anti-diabetic treatment that is having any influence on the risk of cancer. Please change this slide. So as you know, there are change this too. There is some relationships between the metabolic syndrome and cancer. Those are common factors. Like you see with the increasing age, now we are having more and more people are going to be more than 70s or 80s years. And the age is one of the biggest factor where our cellular proliferation and the cellular mechanism get changed. So with that, we have more risk of the cancer in these patients. Then there are certain genetic factors, familial history of HOBC, and even the same genetic familial histories are in the diabetes too. Then obesity is a common factor. The physical inactivity, unhealthy diet, excessive alcohol consumption or smoking or endocrine disruptor exposure, the circadian rhythm disturbance and air pollution. So all of these you find that these are not something completely dissociated with each other. So these can make contributory factor for each other, but what are the biological evidences or what are the common mechanisms that can pinpoint? Particularly few organ we can pinpoint, like obviously pancreas is secreting insulin, the insulin is going by the portal veins to the liver. So these areas are more exposed to the hyperinsulinemia. Hyperinsulin status, but there are certain organs like the breast or colorectal where these activity are also increasing. The incidence of breast cancer and colorectal cancer is also increasing in diabetic patient too. The mechanism of these is not 100% correctly we can explain by the why this has happened. And if you see there, please change this slide. These modifiable factor, beyond that, the three common factors that in diabetes patient we may think that they are causing cancer, like the hyperinsulinemia, one, hyperglycemic state, and chronic inflammation, the cytokines release, and then one other is insulin receptor or insulin growth factor excess. So what happens? Please change the slide too. So what happens basically, if you see that cancer is a kind of nexus, a vicious circle between type 2 diabetes, cancer, and obesity. So there is, with obesity, we all know that the obesity increases your inflammatory markers. So that is IL-6 or TNF-alpha, all these are increasing, and that constant inflammation is one of the conditions that is conducive for development of cancer. So in the organs where there is less chances of higher insulin receptor status, we may explain that this may happening due to the pathway of the your inflammatory cytokines or means inflammatory pathway. So this is the breast cancers, liver cancers, and skin cancers, or these are more common in this. Then there is a leptin increase causes the activation of other oncogenic tumor factors. And this again increasing the cellular proliferation causing your breast cancer and ovary and prostate cancer. The prostate is somewhere there is a controversial issue, okay, whether it is obesity is only increasing the risk of prostate, because it has seen that diabetes has somewhere the protective in kind of prostate cancer. Diabetes has less incidences of prostate cancer. And then reduction of aponectin, you inhibit the proliferation pathways. And so renal cell carcinoma, breast cancer, and endometrial cancer risk increases. Change this slide, please. So now the questions come that only these factors are actually increasing the risk of malignancy, or patient ka kya position? Just a minute, please. एक बार OT देख के. So, or these factors are just coincidental. So if you see that in your practice, what you will find more commonly that your patients which are coming with diabetes, they are most commonly obese one. So in cancer patient, whatever we are particularly finding colorectal cancer or breast cancer or endometrial cancer, there is 1.5 to 2 times relative risk increment in case of malignancy for these organs. So somewhere obesity, particularly whatever we have concluded that diabetes is obviously increasing certain risk factor in liver and pancreatic cancers or colorectal cancer, but in other organs, it may be the common factor that is associated with unhealthy lifestyles or other modifiable factors that are contributing more to the malignancy than directly going to be a biological changes in that. And in this. And then other factors comes in case of the diabetes treatment also. So this is the basic things that you know how the cancer develops. There is obviously certain non-modifiable genetic factors in the body that all people will know the Nelson's double hit theory, that there are certain mutation engraved in our cells. Then gradually we have more exposure to the environmental factor, or the more mutations come by the exogenous factor, whether it is diet, your drugs, your mutations or anything. And this cell goes into the damaged state. And normally what happened, the normal cell cycle, you go for the apoptosis, but in the cancer cells, the decrease of apoptosis is going to causing you uncontrolled cell division and the mass formation and neoplasia. So this overall state of higher proliferation is somewhere contributing to the diabetes also, and particularly the role of, please change the slide, role of insulin-like growth factors comes here. And that IGF increment or decrease in IGF binding proteins may increase the risk of cancer, because they're somewhere dysregulating the cellular mechanism, and this hyperinsulinemia causes the mitogenic effect, as well as this is you're increasing the protein synthesis and the decreasing the cellular death. Overall goes for the increased cellular proliferation. So if you see that these are the common anti-diabetic therapies which is that we commonly use, the thiazolidinediones and metformins had certain roles that decrease the risk of malignancy. And then there is insulins. There is some questionability about insulin and insulin analog, that whether they increase the risk of cancer or not. Though the debate is not yet settled, but certain evidences that metformin is more favorable for a cancer specialist to decreasing the risk of cancer, whether insulin may increase the risk of cancer due to, again, the causing the more hyperinsulinemic state. Please change this one. So what happened with the metformins, that, you know, one of the protein synthesis pathways, that is mTOR pathway, and by the LKB1, AMQ, and P53, the direct effect is that in metformin is decreasing the mTOR pathway. And so it is when depressing the mTOR pathway, it is depressing the protein synthesis and decreasing the cell growth and multiplication, and decrease the cancer growth. Another effect come, obviously, it is decreasing the insulin levels. So insulin and glucose decrease, and inflammation settles, the patient's obesity corrected, and then again this Kaiser low inflammatory status, low hypoinsulinemia state, decrease the cancer growth. Please change this slide. Maima, can you please change? So bladder cancers, that it was found with the pioglitazone used when they treated with the pioglitazone, there was no bladder cancer into 98%, and whether not treated with the pioglitazone, it was 98.2%. So though it was statistically significant, but there was no clinical significance found in there. So yet that rule is not established. We are not using pioglitazone as a protective agent in the case of bladder cancer, but metformin, some studies have started using for a protective agent, even particularly in colorectal cancer. The data has done the study, that data yet has to be published. So when we are trying to focus on how the biological evidence by cell lines we can go. So you can see that insulin or insulin glargine is, again, they are basic mechanism same. It is causing hyperinsulinemia, increasing the proliferative state, and that proliferative state is going to change into the your cancerous stage. Up till now, insulin glargine has some evidences. Rest other insulins we don't have any particular evidence about that they increase the risk of cancer. Maima, can you please change it? So now the question comes that what are, as a particularly practitioners, we should think about whether we have to choose wisely our anti-diabetic therapy according to the risk of cancers, or we have to figure out that whether there is selective cohort of patients where we should avoid the particular OHA agent. Certain organs, obviously liver, pancreatic cancers have some kind of connection with the type 2 diabetes, and particularly there is a reversal causal effect is also seen, that if it is 2 year, normally we have found that sometimes the diabetes precede the pancreatic cancers, and the patients within a 2 year of developing diabetes, they get the pancreatic cancer. And particularly in type 2 diabetes onset, when it is occurring into the adult age group people, this may be a caution for us that if a patient is suddenly developing a diabetes and there is certain other signs and symptoms, then we should evaluate with the CT scan, particularly to look after the pancreatic parenchymal status. But if it is more than 5 years, then normally it has not seen any kind of particular association. But then there is a thought that it is actually diabetes that may secondary develop the pancreatic cancer. So please change this. Overall, if we can say, there is not still very strong evidences for changing any kind of therapy, or there is no very strong evidence that we can say that diabetes is, particularly cancer is associated with diabetes. Obviously in liver and in pancreas is there, but not in other cases. One thing that I want to say that whether your patient is coming in your OPDs of what age group, particularly females are coming, we are mostly, particularly diabetic practitioners, are focused on taking the only consideration for diabetes or deranged glucose, but get a brief history about some other sign and symptom of cancer too. Your patient if they are not properly screened every day life in our India, the screening is not it. Just simple ask few questions about breast lump the lady may have, she has the bleeding per vaginal or postcoital bleeding. These simple questions may give you a kind of insight that those patients who are increased risk of liver, pancreas, endometrium, colorectal cancer, you can screen on the basic level. So, and there is no issue, there is a association between the diabetes and some cancer, and they are partially due to the shared risk factor. So epidemiological supports, whatever are there, they are not yet mature that we can 100% figure out that. But aging, obesity, diet and physical inactivity is a common contributing factor for both of them. And healthful, we have to promote our patient for the healthful diets, physical activity, weight management, that all you people are doing in your diabetic reversal programs also. And that decreases the both risks. So decreasing the obesity is going to actually protective effect for the cancer too. There is a very limited evidence that metformin is decreasing the cancer risk, or exogenous insulin is associated with increased cancer risk. So particularly for choosing any therapy, if there is a very high risk factor, only then you may have some cautious approach. Otherwise, the first priority should be given to your blood glucose control. And cancer risk is not in diabetes. It is almost what is the average patient for the same age group, that they have same risk factors. So only the motivation that you can give your diabetic patient to, that not too much worry about the cancer. They have to be more motivated for healthy lifestyle and more go for your cancer screening programs. Females for 45 or above age group, if they have any family history of cancer, then screening should be started from the last member at whatever age they have diagnosed, less than 10 years before that. Thank you.
Thank you, Alok sir, for that good, wonderful talk. So just one question from my side. Sir, there are many centers which offer these cancer marker screening. So in people with diabetes, so is it routinely recommended, and is there any additional benefits of screening and finding out these cancers earlier?
So the problem is that the tumor markers are not certainty about the cancers. Okay, so when you are using screening like the PSA, one of the few markers are established. Yeah, PSA has decreased the risk of, has early evidence to diagnose the prostate cancer. But like commonly the people provide you the CEA for the colorectal cancer, they give you CA 125 for ovarian cancer and CA 19.9 for your hepatobiliary cancer. But none of these markers are isolated associated with malignancy. There is any inflammatory conditions that markers are increased. So whatever we have found that many patients come to us with these high markers and they have no symptoms. There is no localizing sign. There is no evidence even in ultrasound. And they particularly ask us to get up at CT scan done to figure out that maybe there is some cancer in my body hidden. So the routine marker screening is not actually recommended. Always there should be first detailed clinical examination. Then according that, whatever your clinician decides, whether he wants a marker study or he wants some kind of radiological study, you have to go for that. So routine, it should not be recommended in any patient. PSA has to be recommended in your patient if they are 50 plus age groups or they have any kind of urinary symptom. And even after 75 year or the life expectancy is less than 10 years, then it should not be recommended them too also.
Okay, Dr. Alok, like one real cancer which is seen like risk in diabetes is like in pancreatic diabetes, risk of cancer pancreas. So do you have any experience in that? Like we also see a lot of CA pancreas present as diabetes for the first time after 60s. That is number one. And also how to monitor chronic pancreatitis patients or FCPC PD patient for cancer prevention. So what are the markers you follow here?
See, we have one or two patients only where we can particularly link it, and it was obviously not from our side that we had figured out. It was the physician who was more apt in diagnosing that. So one patient developed diabetes mellitus and he has slight symptom of upper abdominal pain. That's why his physician recommended him to go for a CT scan, and that we find an incidental pancreatic tail mass was there. So most of the time what happened that in pancreatic patients, you get the head pancreas. The pancreatic head mass are not associated with diabetes that commonly, because you know that beta cells are more located in the tail region. So pancreatic tail masses may present with the diabetes, but head masses, the pancreatic ductal adenocarcinoma, we have less commonly seen with this association. And second thing is that in a chronic pancreatitis, whatever the etiological factor, that has to be balanced first. If it is alcoholic or some kind of other causative agent is there, they have to take care of that. Particularly ultrasounds are not that very sensitive for decreasing, analyzing the pancreatic masses. And again, the CA 90.9 not giving you very help in this condition, because in chronic pancreatitis, there is an inflammatory condition is always there. And until unless the pancreatic atrophy if occur, then your CA 90.9 level decrease down. So whether it is a poorly differentiated carcinoma or pancreatic atrophy is there, then you will not have the high marker. And in inflammatory condition, again, the marker is not going to help you. Because there is again high rise of the pancreatic CA 19.9 due to inflammation too. So if you think that the patient has very high, like a family history of pancreatic cancer or hepatobiliary cancer, or they have some genetic history of Lynch syndrome or any other, in these patients we recommend routine annual either US or endoscopic ultrasound or CT scan for the screening purposes. But it is not routinely recommended to screen the pancreas for pancreatic cancer up till now.
Thank you, Dr. Alok. Dr. Tony, you can go ahead.
Okay, so thank you, sir, for that wonderful session and answering our questions and queries. So next I'll go on to the next speaker, who is an eminent speaker, Professor Dr. Anubha Srivastava, madam. So can I have her? Yeah, thank you. So madam is well known to all of us. So she's Professor, Department of Medicine, Maryland Medical College, Prayagraj, and she has won various awards and accolades. She is the Joint Secretary, Diabetes Education Foundation, and organizer of various conferences. So, Madam will be talking about exercise prescription in diabetes. So, we know that people with diabetes, they need to do regular exercise. Not just people with diabetes, everyone has to do regular exercise, but more so in diabetes. So, we just tell often we forget to tell our patients to do exercise, and even if we tell them just do exercise, what type of exercise, how much time you should spend on exercising, all these are usually neglected in our clinical practice. So to shed light on this, I would invite Professor Dr. Anubha Srivastava Madam to come to the dais and shed light on this. Thank you, ma'am.
Thank you, Dr. Tony, for very aptly pointing up on this pertaining issues. We do talk about, but time नहीं मिलता है patient को बताने के लिए कि क्या करना है, कितना करना है, कर लेना. And at the outset, I would like to thank Dr. Ajay and Dr. Mayur for organizing a wonderful conference. And like COVID se kuch to acha hua, so we are here with very well connected with all of you. I think my slides are visible.
Yes, ma'am.
Yeah, so I'll just right away start with it. Yes, we do need to exercise, whether we are diabetic or non-diabetic. And as a physicians or as everyone practicing endocrinology or the diabetes, this is very important. We do write a prescription about it. We have seen this slide for the whole day, I think. So how important of this diabetes as the prevalence is, it can be taken into account that we are having a whole day of the 3-day conference. We are totally having a full day on diabetes today. So coming to the crux of the management, it is a triad where we talk about the nutrition, which will be covered in the subsequent day lecture. The medications, we are definitely talking in the exercise. And the center, we say, is the education, which we are doing, which everyone has to do. So this needs to be taught. So this exercise is an important therapeutic regimen for diabetes mellitus. We are very well aware about the cardiovascular benefit, the weight management, and the glycemic control it gives. The basic benefit appears due to the tissue sensitivity to the insulin, which produces a beneficial effect on the glycemic control. A UK-based study in 2004 studied in both the type of diabetes that only 34% took some form of activity, and 9% of those also didn't achieve the target. So you see, we are talking about diabetic patients, जहाँ पे हम prescription देते हैं, जहाँ हम बोलते हैं, yet we are not talking about the non-diabetic scenario. To define the physical activity, it is bodily movements produced by skeletal muscles that results in energy expenditure. But when we talk about an exercise, it's a subset of physical activity that is planned, structured, repeated, and has a final or intermediate objective to improvement or maintenance of physical fitness. In diabetes, there is a situation of insulin resistance, moreover in type 2, which is exacerbated by our bad lifestyle and sedentary lifestyle. So if we see the longest studies of diabetes prevention program and Darwin study of China, this has shown that weight loss brought about by the dietary restriction and physical exercise decrease the development of type 2 diabetes among obese patients, people with impaired glucose tolerance. So this is very important. Exercise is one of the major pillars in diabetes management, and if done properly as advised, will immensely benefit diabetics. Talking about the various benefits from the decrease in the mortality to lowering the risk of metabolic syndrome, to reduction in the incidence of osteoarthritis, to the reduction in falls in older adult and mental well-being. It is also shown having a beneficial effect in lowering risk of breast cancer and colonic cancers. A word about the sedentary behavior increasing the diabetic risk. So any waking sedentary behavior where the energy expenditure is less than 1.5 metabolic equivalents, whether you are sitting, reclining, watching a TV, or have been sitting for a very prolonged period. This, we actually label the amount or the energy expenditure in the metabolic equivalents. Anything between around 3 MET, we take it as mild exercise, mild advocation of exercise. Moderate comes around to 3 to 6, and more than 6 metabolic equivalents, if the energy expenditure is there, we say it is a vigorous exercise. So the studies have shown 1 hour of extra TV, you say, the children are seeing TV, we are sitting on the mobile and laptop, we are actually increasing a risk of 22% for type 2 diabetes. in any less than 2.5 hours of exercise or sitting, prolonged sitting, will actually increase our energy expenditure of around 350 calories per day. So the non-exercise activity thermogenesis is important for the prevention of obesity. So studies have shown that 8 weeks duration of exercise or a structured exercise will reduce the A1C by 0.66% in diabetes. This has been recommended by the American Diabetic Association also, that at least after every 30 minutes of a regular sitting, we should have some interrupted activity. We have been sitting for an hour over this laptop. We should get up, stretch ourselves, and actually this will benefit the diabetic patient. So having some evidence, we're living in the evidence-based era. So we have the follow-up epidemiological studies where proper diet along with exercise has shown to be useful not only in diabetes, but other non-communicable disease. The Darwin study in China, which was a 6 years follow-up study, which showed 31% patient improved with diet only when the prescription was there, and 46% when exercise, and on the combination, an average of 42 patients were improved. The diabetes prevention program, which has been one of the longest 10-year follow-up program, which showed the incidence of diabetes after randomization was reduced to 34% and 18% in subjects initially randomized to lifestyle and metformin intervention. There have been various data from Japan, from Germany, which has shown the leisure time physical activity, the habitual time physical activity has reduced the incidence of diabetes and comorbid and the complication and the comorbid conditions. So the physical activity definitely is important, more so for diabetics. How do so? It affects the acute effect, if you see, by the stimulation or by the insulin stimulation of the blood glucose uptake in the skeletal muscle. Also, simple, mild intensity of 15-minute post-meal walk can be considered at a moderate aerobic exercise, and that has shown to be improved in the blood glucose levels. The aerobic and the resistance exercise training both has shown to be effective, and this physical activeness lasts from 2 to 72 hours. So if you don't exercise regularly, the beneficial effect goes. On longer runs, if you're daily exercising on most of the days, this beneficial effect on blood glucose can be seen with moreover on the various metabolic profile and all-cause mortality, and even having a mental well-being. Hence, the effect of the exercise manifested by improved insulin sensitivity decreases within 3 days after exercise and almost no longer apparent after 1 week. Therefore, diabetes patients should engage in physical exercise at least 3 days per week with no more than 2 consecutive days between bouts of physical activity. So this was one of the, I was talking about the mid-intensity post-meal walking and effective for glucose homeostasis in type 2 diabetes patients. So some exercises is essential. Talking upon hyper-intensity exercise, so there is a modest improvement in the metabolic control if we talk for the diabetes as per se to other forms of exercise training, and it should not be overstated for its role in weight loss, but definitely because of its cardiovascular benefit and a cardiorespiratory benefit, it has been inculcated in the schedule of the program for diabetes. Not only diabetes and exercise is essential for everyone, but also during pregnancy. The maternal benefits are irrespective of diabetes, but specifically if a patient, a diabetic pregnant patient exercises, it decreases the number of women who required insulin, shorter labor, and decreased incidence of operative delivery, and definitely reduce fat mass in the fetal health benefits. So there was one of the study which was mentioned, what exactly why we talk doesn't accumulate in practice. So this was one of the problems related to exercise therapy guidelines. So if you see, there is lack of time to teach. As I said, we are very busy. Everyone is very busy. We don't charge extra. There is definitely exercise educators, this is very significant. We have diet educators, but there are very few people who are specializing in exercise education. Lack of any guidebooks, for exercise therapy, patients do not practice exercise even after instruction, and lack of facilities and possibility of the fear, especially type 1 patient, because of exercise, their blood glucose level may fluctuate. As we know, the aerobic exercise, once you begin, the chances of hypoglycemia is more. And during the strenuous exercise, the resistance exercises, because of the increase in the catecholamines, there is chances of hyperglycemia. So the patient fear may also be there, and the chances of getting prone to injuries may also be there in the back of their mind. So now what can we do? We have seen the problem. So we need to regular exercise. We are very well aware about that, the schedule of exercise. So what type of, now we have decided that exercise is essential. We should prescribe it to our patient. But what has to be prescribed? What type has to be there? How much has to be there? Certain tips to start over. Anything which you enjoy, you will do it for a longer period of time. Have some group or a partner which will definitely help you to do it on a longer duration of time. Start slowly, and the importance is a warming up session of 5 to 10 minutes and a cool down session after it. Drink adequate amount of water, ensure a proper footwear, do have an identification card, because you're a diabetic, chances of hypoglycemia should be made aware of the partners you are exercising with. Always carry some snack or some carbohydrate food. Do not exercise. We have told you sick days, we should skip exercises, or the chances of the blood glucose is high, or the ketosis are there. We should refrain from exercising. So start slowly, time it right, know your limits, do test your sugar pre-exercise and post-exercise, take measures to protect your eyes and feet, and be prepared. We'll be talking about the precautions for exercising in both the type diabetes. All the elderly patients of a longer duration of diabetes or the complication of diabetes should have an exercise tolerance test done before initiating any exercise, and they should have what type of exercise they should do. Specifically, the retinopathy patients, specifically severe NPDR and PDR, the non-proliferative and the proliferative diabetic retinopathy, some exercises, especially the strenuous exercises, may risk the chances of vitreous hemorrhage. For the peripheral neuropathy, though most of the exercises can be done, but recommendations are for the non-weight-bearing exercise. The moderate intensity walking may not lead to increased risk of foot ulcer or re-ulceration in peripheral neuropathy. The ADA guidelines for the physical activity considers the various complications which a diabetic patient ensues. And you see, most of the cardiac complications, they recommend once after the testing, if they are capable of supervised structured exercise program, they should do so. Start slowly, start gradually. Most of the aerobic exercises and some of the moderate intensity exercises can be done. A word about the neuropathic patients. The weight-bearing exercise, as we have discussed, should be done with proper foot care. The patients who have foot ulcer or amputation should avoid weight-bearing exercise and should monitor their feet daily. Patients with autonomic neuropathy should maybe a challenge, because they may have more chances of having partial hypotension. So some of the exercises should be restricted to them, and symptom limited exercises should be there, and they should avoid exercises in hot environment and hydrate well. Eye diseases, as we have said, because of the chances of vitreous hemorrhage, the very vigorous exercises should be avoided in PDR and non-PDR patients. The kidney disorders doesn't refute patients to have most of the exercises or activities are okay. So if we see a mnemonic, what type of exercise? Strengthening exercises, aerobic exercises, flexibility exercises, endurance exercises should be added. So safe exercises are there, which can be recommended to most of the group of the patients which you are seeing in your OPD. Talking on the type of exercises, this can be breathing exercises, which are very well part of yoga and is now incorporated into our structured exercise program. Aerobic exercises can be walking, which can be 30 minutes, gradually can be increased to 60 minutes. Newer guidelines are incorporating more than 30 minutes is advocated. But studies have shown that around 60 minutes of exercise have a beneficial effect. Jogging, swimming, and static bicycling may be a good choice for aerobic exercises. Not only that, we should mix and match with the 20 to 30 minutes of strength training exercises using push-ups, sit-ups, lunges, squats, or dumbbells should be intermixed with your aerobic exercises. Stretching exercises maintains the flexibility of joint and the muscles of the body. Balancing exercises and the foot exercises also may be helpful. We are very well aware now we are living in a technology world where every apps are available, the exercising apps are available, the watches are available. So you can actually track down how much you have exercised, you have done the exercise, how much calories you have spent, and that depends upon the age of the patients. Role of yoga in diabetics. Now it is a promising adjuvant for diabetes management along with exercise, and I have a better metabolic profile and a better mental health also. So various asanas has been advocated which can be practiced in diabetics. So evidence about it, the exercise prescription. These are various guidelines which talk about the type, mode, duration, intensity, and frequency of exercise. A word about the type 1 diabetics is the recent guideline from the ICMR in 2022 by our own ICMR, which recommends a regular monitoring of pre-blood glucose, blood glucose prior and after the exercise, depending upon the intensity and duration of exercise. Regulation of dose of insulin, the basal and the bolus, according to the exercise. This can be done. And not only that, the insulin requirement can be influenced by the amount or type of food consumed. And sometimes, if the blood glucose are lower, the carbohydrate can be given along with the exercise. Talking on type 2 diabetes, 60
Madam, the time is almost up, ma'am. Can you?
Just winding up. So we recommend 30 to 60 minutes for type 1, 150 minutes spread over in a week, along with mix and match of exercise. This RSSDI 2022, this will be the guideline which will be declared. So we are not talking about steps, amount of exercise. So just to write a prescription, I think this will do. Frequency, you have to do 3 to 5 times. Intensity, your heart rate rises up to 120 beats minutes or you don't get breathless. Timing, the type, and it should be enjoyable. So my take-home message will definitely be exercise regularly and with specific precaution should be advised to the comorbidities. Yoga is an adjuvant. Some of the useful tips for the patients when they exercise. Thank you.
Madam, I am Dr. Manish Sharma.
Yeah.
Hello.
Yes, sir, you're audible.
Dr. Manish.
Actually, there is a concept now, new emerging concept of reversal of diabetes.
Yes.
It is due to it is done by vigorous diet control and with exercise. These two modalities, these two things help in reversal of diabetes.
Sure.
So, what is your opinion on this?
Yes, definitely. This is the recent coming up concepts on the reversal of diabetes. The lifestyle modification, specifically as you talked about the diet, the exercise, hit early, hit hard. If you're able to maintain a weight or reduce the weight of a patient of 5 to 10% of body weight, definitely you are able to improve the insulin sensitivity and hence reverse diabetes. But I think when we think of a longer way, we have to maintain a blood glucose or HbA1c of 5.6 for more than 1 or 2 years to label them as reversal of diabetes. How many of your patients you are able to maintain at that level with lifestyle, without any medications? So these are things which should be pondered, but yes, definitely the lifestyle modifications have a very well stay, and we should motivate all our patients with a guided diet and guided exercise, and definitely do need to write the prescription, FITTE, enjoyment also. So put it like SMBG, HMBP, this exercise diet as advised by the dietitian, and this exercise program advised by all of you who are prescribing diabetes medications.
Thank you.
Thank you. Thank you.
Thank you, ma'am. So we'll come to the close of this session, but we do have more talks on frequently encountered, infrequently discussed topics. So next we'll have the next Hormone India rapporteur, Dr. Ajay Shukla. He was my colleague at SGPGI. He is the organizing chairperson of this conference. And over to you, Dr. Ajay, for taking forward the session.
Thank you, Dr. Tony, sir. I'd like to invite chairperson, Dr. Can we have slides? Backend team. I'd like to invite chairperson Dr. Atul Patel, Dr. Manish Sharma, and Dr. Somnath Raghuvan, please. So Dr. Atul Patel, Consultant Medicine, CIMS Bhopal, Navodaya Hospital, Bhopal. And Dr. Manish Sharma, sir, is Consultant Physician, Civil Surgeon and Hospital Superintendent, District Hospital, Harda. And Dr. Somnath Raghuvan is Assistant Professor, Gandhi Medical College, Bhopal. So I invite Dr. Atul Patel to invite our first speaker, Dr. Arun Kumar Kedia, sir. Dr. Atul Patel, sir.
Can we have the slides? Yeah.
Can we have the slides, please? Am I audible?
Yes, yes.
Yes, sir. Go ahead.
Hello.
Unmute yourself. Unmute.
Good afternoon. Am I audible?
Yes.
Yes, sir.
Good afternoon to all. Our next speaker is Dr. Arun Kumar, sir. He is consultant physician and head of ICU Life Birth Hospital, Raipur, life member of API RSGI, chairman of API Raipur Chapter 2022, district coordinator for state RSSDI, scope certified obstetrics physician, part of various clinical trial and registries, reviewer for Journal of Royal College of Physicians. Sir, now it's over to you.
So, good afternoon to all. I hope I'm audible.
Yes, sir. The slides are visible and you're audible. Good afternoon, sir.
Okay. So, at the outset, I must thank Dr. Mayur, Dr. Atul, Dr. Ajay Shukla, and the entire team for conducting this wonderful 3-day academic session. And I'm sure it must be a very tedious job for the team to organize so many speakers on a platform in such a brilliant manner. And the best part is that it is going very much in time. So without much delay, I think Dr. Anubha spoke very well on the importance of exercise in diabetes. And what I am going to tell you is probably what is the result of not exercising in diabetes. And the topic allotted to me is diabetes and sarcopenia. So sarcopenia is a common problem that we are facing in day-to-day practice. And all the more it is going to be much more. The only problem is that we are not much aware about what is sarcopenia. So the definition in general for sarcopenia is basically it's a degenerative skeletal disorder whereby you have a loss of muscle mass, muscle strength, and the muscle function. So we see often very much in our day-to-day practice when the patients come to us and when they have shown to us, it is very difficult for them to get up from the chair and go back to their home. Many times we see them that they come with support. Many times we see them, they have a tendency to fall even in the OPD while they are walking. And that is where we must start looking out for sarcopenia in all our patients. So diabetes and sarcopenia, overall, it forms a bidirectional link. We do not know what causes and what is the effect. It could be the diabetes causing sarcopenia, or the other way around also is true that sarcopenia could lead to exacerbation of diabetes. Now, the reason why we are discussing is, on one hand, we have a rising cases of diabetes globally, and on the other hand, we have an increasing life expectancy, which is leading to a rising population of the elderly population. And these elderly people are likely to suffer from sarcopenia due to old age. Now, this sarcopenia could lead to exacerbation of diabetes, could lead to uncontrolled diabetes or could lead to new onset diabetes. And that is why we must understand that how diabetes and sarcopenia are linked to each other and how they can exacerbate the problems together. So if you see this bidirectional link between sarcopenia and diabetes, we know that diabetes is a condition of insulin deficiency or insulin resistance, which leads to catabolic effect and can lead to sarcopenia. On the other hand, diabetes is also a condition of chronic inflammation, whereby we have increased inflammatory cytokines, there is lipid peroxidation, there is mitochondrial dysfunction, there is increased free fatty plasma acids, and all these can lead to muscular dysfunction. On the other hand, with aging, you can have a decrease in protein intake, decrease in physical activity and exercise, which can further lead to degeneration of the muscles, leading to sarcopenia. Now, on the other hand, if you have sarcopenia, then the muscle mass is reduced and you can develop a skeletal muscle insulin resistance. And this skeletal muscle insulin resistance, can lead to increase in the activity of beta cells, whereby there is hyperinsulinemia, and overall with hyperinsulinemia and decreased muscle insulin sensitivity, you can land up in diabetes. So this is how the bidirectional link between sarcopenia and diabetes is very strongly studied, and we must understand this, and we must start looking for sarcopenia in all our patients of diabetes and try to prevent it as much as possible. Now, if you come to the definition of sarcopenia, the defining criteria are diverse. We have no consensus definition on sarcopenia. And the earliest definition of sarcopenia that was found in the literature was by Baumgarten, who defined with the help of calculating the appendicular lean mass compared to the height. But then the first study that was done was the European Working Group of Sarcopenia, who gave the criteria for low muscle strength, low muscle mass, and poor physical performance. And that is how they defined sarcopenia. We have certain upgradation and certain revisions of various definition, but as of now, there is no consensus onto a clear-cut definition of sarcopenia, and it may vary from ethnic areas, geographical areas. And we recently had a paper from India by Dr. Nitin Kapoor, where they have come out with South Asian classification and consensus on the definition of sarcopenia, which of course is missing on this slide. But that is something which is worth reading, and I would request all of you to go through that paper also. Now, coming to what is the prevalence of sarcopenia and diabetes. So we don't have much study from our country, but then studies from Japan and China have shown that in adults more than 60 years of age with diabetes, their prevalence of sarcopenia could be as high as 15 to 20%. Similarly, studies from the Korean population, they have shown that there is a 3 times higher chances of sarcopenia and decreased grip strength compared to non-diabetic patients. Similarly, in a study done in 2,675 elderly people, it was shown that women showed double the risk of sarcopenia and diabetes compared to non-diabetic patients. And similarly, in the English longitudinal study on aging, they found that the odds ratio for developing sarcopenia and diabetes was 2.43 in men with diabetes. So this is very important, that diabetes per se increases the risk of sarcopenia, and that is how we must ensure that we examine the patients for sarcopenia. Interestingly, it has also been found that type 2 diabetes patients, even with similar muscle mass, present with lower muscle performance and strength compared with non-diabetics. So muscle mass may not be the only way, but muscle performance and strength are the other way to diagnose sarcopenia. On the other hand, if we see the prevalence of diabetes in sarcopenia, then we have studies again from Korea, where we have a large study where the patients were studied from age above 40 years, and the individuals in the lowest skeletal muscle mass relative to body weight quartiles had 2-fold higher risk of developing type 2 diabetes compared with individuals at the highest quartile. Similarly, in the Korean genome epidemiology study, again a large study, this also showed that the patients in the lowest muscle index had 2-fold higher odds of incident type 2 diabetes compared to patients who had a good skeletal mass after adjusting for all the other confounders. Similarly, lower hand grip strength was found to be predictive of elevated fasting glucose in more than 17,000 Chinese men and women aged over 40 years. So all these evidences clearly mention that the prevalence of diabetes is increased in the presence of sarcopenia. And moreover, in the presence of sarcopenia with obesity, which is again a big problem that is upcoming, there is a still greater risk of incident type 2 diabetes because obesity per se leads to metabolic syndrome. So it is very important to understand what are the mechanisms of sarcopenia in diabetes, and this is where the focus of our talk would be. We know that diabetes is a condition of insulin resistance, and prior to diabetes development, we have insulin resistance in our population. So the study which was done on osteoporosis in men, the men aged 65 years above without type 2 diabetes, but in the highest quartile of insulin resistant, they showed twofold higher risk of losing more than 5% total lean mass over approximately 5 years. Similarly, in the NAN study, they found that the gait speed decreased across increasing quartiles of insulin resistance compared to non-diabetic older men. And in the Baltimore longitudinal study of aging, the knee extensor strength was lower across increasing quartiles of HbA1c even before diabetes was diagnosed. So all these evidences clearly mention that with increasing insulin resistance, the muscle health deteriorates, and that is where the sarcopenia develops. So the loss of muscle strength and mass in individuals with poor glycemic control, even in patients with insulin resistance, this is basically due to increased protein degradation and decreased protein synthesis, and that is what we will discuss in the later slides. Second important mechanism is the chronic inflammation associated with diabetes, and we know that interleukin-6, tumor necrosis factor alpha, C-reactive proteins, they are all elevated in patients with type 2 diabetes, especially when there is associated obesity. And studies have shown that there is an inverse relationship between IL-6 and muscle strength. Similarly, there is an inverse relation between CRP as well as the hand grip strength in various population studies. So apart from this, the inflammatory markers are also negatively associated with muscle strength, which is now considered the principal component of sarcopenia. So I would emphasize again and again that sarcopenia is not just loss of muscle mass, but it is also a decrease in the muscle strength. The other mechanism, that is oxidative stress, which occurs in type 2 diabetes through dyslipidemia, insulin resistance, increased advanced glycation end products, and mitochondrial dysfunction, they all lead to impairment in the muscle repair. There is impairment in the satellite cell differentiation in the myocytes. There is a decrease in the damage of, there is an increase in the damage of DNA, and there is an overlapping mitochondrial dysfunction. So these impairments in oxidative capacity, it leads to a decreased metabolism of macronutrients and leads to a poor physical performance. There are studies which have shown that now type 2 diabetes has intergenerational effects on mitochondria, and studies have shown that patients born, in fact, the children born out of diabetic patients have almost 30 to 40% lesser mitochondria than the patients who are born out of non-diabetic patients. So these are recent studies and recent findings which we need to further study. Diabetes is associated with increased advanced glycation end products, which is positively further associated with insulin resistance, obesity, and we know that these advanced glycation end products lead to increased protein cross-linking within the muscles, thereby interfering with the contractility, increasing inflammation, increasing oxidative stress. The study in Japanese adults showed that higher skin autofluorescence was associated with lower hand grip strength and leg extension power. Now, this skin autofluorescence is one of the surrogate marker for studying advanced glycation end products. Of course, these are used in research purpose, but what we need to understand that these are one of the ways to study advanced glycation end products and its relation with grip strength, abduction strength, and hip flexion. Diabetes is associated with various micro and macrovascular complications. There are studies which have shown that with the presence of microvascular complications, there is a decrease in the muscle strength, there is decreased contractility, and nerve damage can also lead to muscle atrophy. Similarly, diabetic retinopathy can affect vision, which is one of the key components of balance, and balance we know is required for locomotion as well as physical performance, and also helps in preventing the falls. Similarly, diabetic nephropathy causes catabolic wasting, there is muscle wasting, there is increased inflammation, protein loss, there is reduced vitamin D synthesis, associated mitochondrial dysfunction, and metabolic acidosis, which can lead to muscle wasting. Macrovascular complications, especially the atherosclerosis leading to peripheral vascular disease, can cause a decrease in the blood supply to the muscles and is related to lower hip extension and knee and hip flexion in older adults. So reduced blood flow in peripheral arterial disease leads to ischemia, leads to decreased muscle strength, mass, and performance, and it can lead to reduced physical activity and exercise due to the pain associated with peripheral vascular disease. Adipose tissue infiltration into muscles is another very common, and sarcopenic obesity is very common in diabetes patients. The inter and intramuscular adipose tissue is basically an ectopic fat which is associated with poor metabolic outcome, and this leads to decreased in insulin sensitivity, and it is an independent predictor of physical function as well as falls. The adipose tissue localized ectopic is also a reason for increased localized cytokines leading to muscle dysfunction. Then there are certain anti-diabetic drugs which are also associated with decrease in body weight. There may be some drugs which may lead to muscle mass. The only drug that is anabolic is insulin, and there are some studies which show that metformin is anabolic. But the rest of the drugs have not shown any positive effect on muscle mass. So if we see the causative factors for sarcopenia, two most important factors are decrease in physical activity and the poor nutrition, which can lead to sarcopenia. And that is where we have to intervene in our diabetes patients. So coming to the treatment of sarcopenia and diabetes, we can have caloric restriction for decreasing obesity. We have to go for exercise training, resistance training, the vitamin D supplements, omega-3 fatty acid supplements. And that is how probably we have some evidences in favor of these supplements for treating sarcopenia. So the most important is physical activity. We need to have supervised aerobic as well as strength training. Resistance training is found to be the most effective strategy. It improves muscle strength, size, as well as the quality. And if we combine resistance exercise with aerobic training, then on one hand, aerobic training will improve the metabolic health. On the other hand, resistance exercise will improve the musculoskeletal health. So for diabetic patients who are obese, we must combine both these exercises. Coming to diet, calories restriction is very important, especially for obese patients. But at the same time, we must see that there is adequate proteins. We must supplement patients with branched chain amino acids because they are known to improve the muscle synthesis. Vitamin D receptors are present in the skeletal muscles, and vitamin D supplementation has been shown to improve muscle strength. Omega-3 supplementation improves muscle performance, decreases chronic inflammation. And so we need to go for medical nutrition therapy, which has to be individualized based on the availability, affordability, and the social taboos prevalent in the society. So based on that, we must go for a medical nutrition therapy to prevent sarcopenia or to treat sarcopenia. Proteins may not be sufficient, so proteins have to be combined with exercise. There must be vitamin D supplements and other micronutrients to augment the effect of exercise and improve the muscle strength. So to summarize, on one hand, we have aging, hormonal imbalance, low dietary intake, inactivity, and chronic inflammation in diabetes. On the other hand, we must address energy needs, protein requirements, amino acids. We must go for essential fatty acids, vitamin and mineral supplementation, and there should be multimodal interventions in all these patients. So the key message is identify that there is a bidirectional link between type 2 diabetes and sarcopenia. We have different operational definitions of sarcopenia, and that is why we are not able to find out the right patients. But evidence for most of the effective and feasible interventions in both these conditions is lacking, and that is why there is a need for further research to better understand, treat, and prevent comorbid sarcopenia and type 2 diabetes. With that, I thank you all, and the message is keep exercising till we find what we can do for sarcopenia in the future. Thank you.
Thank you, Dr. Arun sir. After back-to-back session from Dr. Anubha ma'am and from Dr. Arun about exercise and sarcopenia, due to shortest time, we are moving ahead with the next session by Dr. Abhishek Srivastava. I request Dr. Manish Sharma sir to invite Dr. Abhishek Srivastava. Dr.
Hello.
Manish.
I am Dr. Manish Sharma.
Yeah.
Dr. Abhishek Srivastava, please join. Dr. Abhishek Srivastava is MD, PhD Endocrinology, Royal College of Physicians.
Yes. So
Dr. Abhishek.
Yeah.
Please join.
Yeah. So Dr. Abhishek is a very famous consultant, MD, PhD in oncology from Jabalpur. Dr. Abhishek, I invite you to take a session on testosterone deficiency in diabetes. Yeah.
Thank you. And first of all, I would like to congratulate Dr. Mayur, Dr. Ajay, and whole Hormone India community. I say that's the perfect way for inviting me and organizing such a huge and mammoth conference and a successful conference. I'm really congratulating you all people. Thank you for this opportunity. And let me share my slides. Okay. So hopefully slides are visible.
Yeah, you're visible and audible.
Yeah, thank you. So today we would be discussing about the testosterone deficiency in type 2 diabetic patients probably, or we could call it as the levels of hypogonadism. Yeah. So what we would be like discussing in these 15-20 minutes is a very brief to know about hormone testosterone, then the prevalence of hypogonadism, basically in type 2 diabetic male patients, then some pathophysiology or association of hypogonadism or low testosterone levels in type 2 diabetic patients, and whether there are some real world associations where we could say that hypogonadism is actually associated with type 2 diabetes or any other metabolic diseases, and few treatment options available to us as a physician. So to define initially hypogonadism or low testosterone levels along with the presence of any of the following signs and symptoms. Basically, what do we follow in actually diagnosing hypogonadism are the very widely accepted Adams questionnaire. So among those few signs and symptoms are there like decreased libido, erectile dysfunction, the decreased muscle mass, bone mass, depression, anemia, basically normocytic normochromic, and the increased adipose tissues mass. And how we could define low testosterone level, it is actually clinical defined as a total serum testosterone concentrations under 300 nanograms or milligrams per deciliter. Normally we take these levels above 300 and less than 1100 basically, but it varies in various pathological references also. See, we could easily debate as whether free testosterone or total testosterone actually is should be used, but basically various studies or the different studies have actually, some studies have advocated taking total testosterone, some studies have advocated taking free testosterone, but what we are taking actually is total testosterone because it is widely and easily available pathological interventions available at the periphery also. Something about testosterone. We all know the levels of free testosterone are actually very less, and it is the levels of free testosterone which are bioavailable and actually has their actually the actions done over the cytoplasmic nuclear levels. One more thing is 50% of the testosterone actually is bound to albumin also, but these albumins are very not tightly bound. Therefore, we can take these testosterone levels also as a free testosterone, but basically 1 to 2 or 3% of the bioavailable testosterone is actually of use. Rest is actually bound to sex hormone binding globulins, which are actually known as total testosterone, where we do actually the total testosterone levels. How do we take testosterone? How we could define what are the benefits or the uses of testosterone, how it actually affects in our body. Sexual differentiation, certainly. Secondary hair differentiation, certainly. Differentiation of the prostate lining, the bone mass, the erythropoiesis, the psychotropic actions is actually taken by the testosterone. Libido, certainly one of the most important cause. Lipid metabolism also has been taken care by the testosterone. The bone mass differentiation, and actually epiphyseal closure initially in the early stages of the life, basically. So these are the testosterone and its metabolites and their functions. So now I have already discussed whether total or free testosterone, but different studies I have already discussed it before. But total testosterone or free testosterone, I usually prefer total testosterone because it is easily available in our setups also. So few conditions are there where we could say, okay, if total testosterone is bind with sex hormone binding globulins, there are certain conditions where we could say if the levels of SHBG are suppressed, then the total testosterone levels would be altered, or if the levels of SHBG sex hormone binding globulin is increased, then also the levels of testosterone would actually alter. So very few I would actually point out are the conditions where SHBG levels are suppressed, mainly could be obesity, type 2 diabetes, and hypothyroidism. These are the most commonly metabolic disorders which are being encountered in our day-to-day practice, in our day-to-day OPD life. So these are the level or conditions where we could see that the levels of sex hormone binding globulin are decreased, and thereby it alters the total testosterone levels. If you could look, see the pictures of the testosterone deficiency, certainly I've discussed the clinical parameters of testosterone uses. If we could correlate with that, if we could say emotionally, certainly low testosterone levels does possess a higher level of depression, poor concentration levels, low self-esteem does lead to high levels of anxiety, decreased muscle mass, high levels of abdominal obesity, loss of libido, anemia. Certainly, I've already told you. Few of the metabolic complications could also be seen as osteoporosis, insulin resistance, certainly, and sarcopenia, what Dr. Kedia sir has discussed in our previous lecture. And something about reproductive is actually the subnormal genital size, loss of pubic hair, erectile dysfunction, and sexual dysfunction, basically. Now, what could be the pathophysiological conditions lying behind the low levels of testosterone or hypogonadism in type 2 diabetic male patients? Few of them is actually insulin resistance, most importantly. And we all know that the high level of inflammation, the high levels of oxidative stress is being possessed by the high levels of insulin resistance. Thereby, that is the reason why we could easily say that insulin resistance could be one of the most important metabolic parameters where we could say that the levels of testosterone could be decreased. And when these are few animal data where they have studied, where they have actually shown why insulin resistance could be termed as the basic pathophysiological conditions lying behind low levels of testosterone suppression. Then if you look at a few of the human data, basically, we know that LH utilizing hormone is secreted in the pulsatile fashion. And when LH pulse frequency and amplitude are compared between obese and lean patients, lean men, then certainly LH pulse frequencies was similar. However, the amplitude of the LH secretion was significantly decreased in the obese population. Thereby, it also proves that we know that in obese population, actually insulin resistance, there is a high level of insulin resistance. This also proves that in obese population, along with insulin resistance, the amplitude of the LH secretion actually is significantly decreased, and thereby the low levels of testosterone it possesses. Now, weight loss has been shown to increase LH and FSH concentrations, certainly. In various studies, we have actually seen that weight loss has been shown to increase the LH and FSH. Now, if we talk about the estradiol and leptin, why it is important? Testosterone basically is converted to estradiol by aromatase enzymes in adipose tissue. So increased adiposity leads to increased aromatization and estradiol formation. And we know estradiol, like testosterone, can decrease FSH and LH release through negative feedback. Thereby, that is the reason why we always say insulin resistance, obesity, not obesity. If there is an abdominal obesity, then also it can lead to low levels of testosterone. And we know that leptin actually regulates LH and FSH secretion, much like insulin. And in obese individuals, we have seen emptying of studies where they have actually shown that high levels of circulating leptin levels due to leptin resistance thereby reduces the levels of testosterone. There is a term we can say that leptin resistance and insulin resistance. And we know that leptin actually regulates the LH and FSH secretion. Thereby, we can say that high levels of leptin resistance and high levels of insulin resistance both could actually lead to low levels of testosterone. Inflammation, oxidative stress certainly leads to low levels of testosterone levels. High levels of inflammation is being seen in type 2 diabetic patients, obesity, and the patient with metabolic syndrome. Basically, these are the most commonly disorders of high levels of where high levels of oxidative stress are seen. And these inflammatory mediators, they interfere with the insulin signaling transduction. And we have already actually noted that insulin dysfunction results in decreased GnRH, gonadotropin releasing hormone levels, and subsequently hypogonadism. But these effects are basically underscored by the fact that testosterone supplementation results in reduced levels of inflammatory mediators. And we would discuss it in our later slides, how testosterone levels would actually benefit in reducing the levels of inflammatory mediators. Some studies where we could prove that we could prove that type 2 diabetes is associated with the low levels of testosterone or hypogonadism. Not even type 2 diabetes, but even metabolic syndrome. Few of them are where Dimsa et al. Actually studied were the first to assess the prevalence of hypogonadism in type 2 diabetes based on free testosterone concentrations, actually. And where the results showed that 32% of the cohort had subnormal free testosterone, and that LH and FSH were significantly lower in these patients. See, subnormal free testosterone and subnormal total testosterone is actually not, from my point of view, even if a patient is at a level of subnormal testosterone, say 250, total testosterone, say 250 milligram per deciliter. But if he has the symptoms of signs and symptoms of hypogonadism, then we can easily say that the patient actually has a level of hypogonadism along with type 2 diabetes or other metabolic conditions. Kapoor et al. Also found a high prevalence of hypogonadism in type 2 diabetes patients. 50% of the patients in cohort had borderline low total testosterone levels. I've already discussed low testosterone level, and 75% of patients with low testosterone also had low gonadotropin concentration. But we are mostly concerned with low level of testosterone along with the signs and symptoms of hypogonadism, which I have discussed it earlier. This was one of the studies which actually I did, where I have actually showed the prevalence of hypogonadism and its relation with glycemic control, body mass index, and type 2 diabetes mellitus. And in this study also, we have found that patient of type 2 diabetes actually shows high prevalence of hypogonadism along high levels of hypogonadism, where the levels of glycosylated hemoglobin was more than 8, 8.5 or 9. So this shows that higher level of HbA1c, the prevalence of hypogonadism or prevalence of low testosterone would be much more higher, the prevalence. In our study, actually, we have seen around the prevalence of hypogonadism in around 23%, 25% of the patients, where the mean HbA1c level was varying between 8, 8.5 and 9. Now, is hyperglycemia or age to blame? Certainly. In one way, we say that hyperglycemia does lead to high level of oxidative stress, and oxidative stress does lead to insulin resistance, or even does lead to lower levels of testosterone. Or whether we should blame the age. We all know higher aging actually has a higher impact on decreasing the levels of testosterone. So here, the few studies are there where Tomar et al. Compared the incidence of low testosterone in patients with type 1 and type 2 diabetic mellitus, where high baseline HbA1c, and found that only 6% of the type 1 diabetic patients were hypogonadal compared to 26% of the men with type 2 diabetes. Why? This study has been shown high levels of prevalence of hypogonadism in type 2 diabetes because of high levels of insulin resistance was there, high levels of abdominal obesity was there. That is the reason why we could easily say that.
Dr. Abhishek, just 1 minute left.
Sure, please. I'll be fine. Obesity and metabolic syndrome. Actually, obesity in the absence of type 2 diabetes is associated with low testosterone levels. We have already seen in various studies, individually, obesity is actually associated with low levels of testosterone and hypogonadism. Why? Because of high levels of resistance, high levels of metabolic disorders. And these are the various studies where we have seen. Basically, so we could easily say low testosterone levels and obesity and metabolic syndrome actually could be individually associated. Diagnosis, certainly a few points. When you should actually measure total testosterone levels, total testosterone concentrations actually should be confirmed by taking morning samples in 2 separate days in fasting state. Since food actually intake suppresses testosterone level, that is the reason why we always say fasting state, morning, take the testosterone samples. And in general, a combination of low testosterone levels with clinical features of hypogonadism, such as decreased sexual, I've already discussed before, could be attributed as could be associated as, or can be termed as hypogonadal patients in type 2 diabetes. a few complications. We know that the low levels of testosterone levels could be associated with a higher degree of development of cardiovascular diseases, higher degree of development of neuropathy, and even nephropathy. But basically, who should receive testosterone treatment? Men with clinical symptoms and testosterone levels of less than 8 nanomillimole. We could easily say men with clinical symptoms and testosterone varying between 8 to 12 nanomillimole per liter, where additional investigations indicate presence of hypertension. Now, if we can turn to milligram per deciliter, then testosterone levels varying between 200 to 300, but clinical symptoms are present of hypothyroidism, then they should actually receive testosterone treatment. But if you have a testosterone levels of less than 200 or even 150, but without the symptoms, then also you can see that the supplementation of testosterone could be beneficial for the type 2 diabetic patients. Contraindications: certainly untreated or suspected carcinoma of the prostate, not to be given; moderate to severe symptoms of benign prostatic hypertrophy, breast cancer, liver tumor, significant polycythemia, severe cardiac failure, and untreated sleep apnea. Sleep apnea, obstructive sleep apnea, basically is actually an absolute contraindication where testosterone supplementation should not be started. And few of the testosterone replacement therapies are there: intramuscular injections, topical patch, topical gels are there. Adverse effects of the testosterone replacement therapy could be polycythemia, breast tenderness, BPH, and prostate cancer. These assays should be performed yearly. And oral testosterone should be there are tablets containing 40 milligram testosterone. It could be given as twice BD or TDS daily. And if you buccal testosterone levels are also there, subdermal testosterone implants are also there, and intramuscular injections very widely used and easily available as testosterone 250. Currently the most widely used form of testosterone, and injections every 2 weeks or 3 weeks could be given to type 2 diabetic patients, and injection site reaction should be actually seen basically. And these are actually intramuscular injections are widely available. The rest are to be given as per the individualized or customized. Thank you.
Thank you, Dr. Abhishek, for such a lucid presentation. We have one query from Dr. Arun. Can testosterone deficiency be linked with the sarcopenia? And one follow-up that, do all diabetic men need test for testosterone?
Yeah. See, type 2 diabetic patients aging more than 50-55 years, certainly I would prefer 55 or more. We know that aging certainly decreases the levels of testosterone. But when there are signs and symptoms present of hypothyroidism, then certainly we should go for testosterone levels. I do not advocate going for testosterone treatment, testosterone levels or pathological investigations for each and every patient, basically. But if you find the symptoms of hypothyroidism, then certainly you could actually go for the
sarcopenia is one of them. Like if severe sarcopenia.
Yes, that's what actually is there. It is actually associated.
So, Dr. Manish Sharma, sir, please invite our next speaker, Dr. Mithun Bhartiya, for ED case-based discussion.
Hello, Dr. Mithun Bhartiya. Please, I am inviting on the behalf of Hormone India to give your lecture.
So, Dr. Mithun Bhartiya, yeah.
He will not be available live. He has sent a recording. He's traveling to Sweden probably. Tech team, please take over. Play the recording.
Very warm good afternoon. I thank Dr. Mayur Agarwal at the onset for designing this beautiful conference of Hormone India. And it gives me great pleasure to be part of this academic adventure that he has started. So we're going to talk today about ED case-based discussion. And I'm going to start with a disclaimer right at the beginning that we are a reflection of our own perspective in life. Because whatever we do or how we behave is a reflection of our upbringing, our social environment, our academic environment, our peers, and our gurus or the teachers who we have learned. If you are a basal bolus, if you've learned from a basal bolus teacher, you will prescribe basal bolus. If your teacher has been premix, you will prescribe premix. I've been born and brought up seeing dog, cat, and a mouse as sworn enemies, with Tom and Jerry as my favorite cartoon character. But when I was in San Francisco and I saw this dog, cat, and a mouse together, He changed the whole perspective of looking at things. So this is what we have, and this is what we should put in the dustbin when we are seeing a patient, especially a patient with sexual dysfunction. Because the bias of a clinical bias should be removed when we are handling cases of erectile dysfunction that are there. Now, before I start, as I've been guilty in my earlier days of training, I've refused treatment to a lot of people because of my own ignorance. And that is a reflection of why I want to talk about, so that people don't make the same mistake and patients don't suffer in the same process. A couple of things are very important is honesty, disclosure, and trust. And these are I would say, the basic pyramids of clinical consultancy. But what is more important is to say no, or to say when you don't know. And to actually accept that is more difficult. It's like with a loaded gun in front of you, when not to pull the trigger is important. So when faced with a sexual dysfunction patient, when to prescribe is far more important than just prescribing Pd5 inhibitors that are there. So let's start with one question. A high-profile couple comes to us. The distraught diabetic husband says once he has ejaculated, it takes time for him to get an erection. So what are you going to do? You're going to ask him to get his sugar further controlled, his blood pressure further controlled, do nothing, give him a branded Viagra, or ask him, which I've heard people doing it, to try with somebody else to see what happens. Now, in medical science, I've always learned with clinical experience that nothing is right and wrong, everything is gray. And there are varying degrees of gray. So yes, everything can be tried other than the last option. But you must understand the pathophysiology of erections when we are going to do that. So if you look at the model of Marston Johnson's 4-phase model, you can see once there is excitement, there is plateau, there is orgasm, and then there's resolution. And once there's resolution, it takes, there is a refractory period of time for which the process for which to start again, which you can see on the right side is the male sexual response. If you remember your physiology days, you need to stimulate a nerve to get a muscle to twitch of a frog. And, there was a bit of a gap in which you can stimulate that again. And that, my friend, is the refractory period. Whereas a woman on the other end is polyorgasmic, and various cycles of this sexual response are happening together, and they do not require a delay. So in this scenario, it's a normal physiology. Reassure the patient that it is normal for a refractory period for a man to happen. The next question is, a 60-year-old diabetic comes to you with erectile dysfunction. He said he has tried a cheap Pd5 over the counter with no help. The total duration of sex is 2 minutes. What do you do? So you can always say, well, you've tried a cheap one, let's try a branded one, let's try a longer acting Pd5. You're too old, leave that, sex, park that in the side and look after your life and become a brahmachari, or none of the above. So let's again understand what the question is trying to say. The question is trying to say that he gets an erection, but he ejaculates. The total duration of sex is 2 minutes. So this sounds like premature ejaculation, and the new coined word for it is premature orgasm, because you don't have sex with a stopwatch on. You have sex for sexual satisfaction. So the correct word to be used is premature orgasm. And for that, the line of treatment is completely different rather than prescribing a Pd5 inhibitor. Now, there are various causes of erectile dysfunction between psychological, vascular, neurological, endocrine, and miscellaneous. But I think there's a great degree of overlapping that is with each other. Nowadays, we believe that there is type 1 and type 2 diabetes are two opposite strands, but there are varying degrees of gray in between that. So one cause of erectile dysfunction is not primarily related to just one cause. There are various causes that may intermingle with them to cause the disease that we'll be having for the patient. So a holistic approach is very important to understand that are there. Nowadays, a lot of recreational substances are used, as well as drugs, pharmacological drugs, which can affect erectile dysfunction that is there. Now, also when the patient comes to us in the clinic, there's a lot of baggage that he's carrying along, and he attributes the erectile dysfunction to a lot of things. I've heard various kinds of stories. I've heard that I've masturbated since the age of 10 years. That's why I have erectile dysfunction. My dog bit me 10 years ago. That's why I have erectile dysfunction. He wants, the expectations are very different. He wants sex to last 60 minutes because he's watched some porn movie and he feels that he needs to, his wife feels that he should work like a porn star. He may have had sex outside and now cannot perform with his wife, and so there's guilty conscience. He's read on Google Baba, and there is a lot of questions that are coming. But the fundamental interesting point that many people come to say, sir, I've come alone, my wife does not know. Baba, if you are having sex with your wife does know what is going to happen. So it's always important to bring her in confidence in the clinic, because it brings a different perspective to the whole consultation that is there. Now, for the most common prescription that happens is Pd5 inhibitors. So you see, if there's a non-erect penis, there's sinusoidal cavity lined with endothelial cells. When there's sexual stimulation, the release of nitric oxide, which activates the GTP cyclic GMP pathway that are there, which decreases calcium, causes smooth muscle relaxation, and increased blood flow, causing erections. However, the cyclic GMP is rapidly converted to 5-AMP by Pd5 enzymes. And this is where the Pd5 inhibitors act to keep the cyclic GMP alive, not to get it changed to 5-AMP. And this is primarily how Pd5 inhibitors work. Now, there are various degrees of Pd5 inhibitors that are there in the market. We have sildenafil, vardenafil, tadalafil, avanafil that are there. But very important to understand the duration of action, the doses, and the interference in renal and as well as hepatic impairment to decide how much dose to be given in which patients and what amount. And the drug interactions is very important that are there with this, that are there before with this there. Also, based on the sensitivity or the selectivity of the Pd5 inhibitors and their activity against other PE enzymes like Pd6, Pd1, Pd11, that will reflect on the side effects that a patient may have. Are they super selective? If they're less super selective, patient may contain some side effects, like if enzymes like sildenafil, which is a low activity like Pd6, they activate the photoreceptors and you get a bluish tinge that are there. That's also there with tadalafil and vardenafil that is there with that as well. Let's go to another question. We often get a lot of patients who are who read the internet and come and sees us. For example, a Google diabetic person who had a stent realized that erectile dysfunction leads to heart attack. And he had erectile dysfunction 3 years ago and wants to know if this was true. Now, is this always true? Is it always no? Get out of jail card and partially yes. Now, it's very important to understand that when we have given MCQs exam, always yes and always no is never the right answer. Partially is always the right answer. But let's look at the reason why. You see, the threshold for symptom development is 50% lumen obstruction. And the diameter of the artery of the penis is 1 millimeter, that of the heart is 2 millimeters. So the narrower the artery, the chances of problems with that artery is higher. Hence, you can say erectile dysfunction is a precursor of endothelial dysfunction of the heart. So if you could nullify the vascular risk factors, get the patient to stop smoking, stop him to get his alcohol, get his diabetes under control, we can go a long instance for reducing him to have an angioplasty or a bypass or a stent or an intervention in the future. Lastly, I would like to say what appears to the outside may not appear inside. And it's very important to ask. To ask is the most important thing, because unless you ask, you will not be able to help the patient, because diabetes, my friend, is a chronic condition. It waxes and wanes with time. There are various life episodes that happen which causes a diabetes to get worse. So we cannot cure diabetes. Our aim is to provide a good quality of life for the patients. And sexual dysfunction or good sexual life is an important part of a satisfactory life that a diabetic person may live. With that, I end my topic, and once again, thank Dr. Mayur Agarwal for the opportunity. Thank you so much.
Hello. Hello. Am I audible?
Yes, yes.
Okay. So now we will invite Dr. Anuj Maheshwari, sir. So can we have a slide? Yeah. So Dr. Anuj Maheshwari, sir, is Professor of Medicine in Hind Medical College, and he's very famous personality known all over India. He's right now Vice President RSDI, and he has several papers. He's a research-oriented person, and I invite him for taking the next session, insomnia in people with type 2 diabetes. Yeah.
Thank you, Ajay. Thank you, Mayur, for giving me this opportunity. Hope I am audible. I'm sharing my screen.
1,000 children were included in the study. To report the age of
Can you listen me?
Yes, sir. I'm audible, sir.
My screen is
Visible, yes, sir.
visible.
Yes, sir. Please.
Yes, sir. Perfect.
Can you see my screen now?
Yes.
Okay. In next 15 minutes, I shall be talking about the insomnia and diabetes mellitus. We all know about the diabetes mellitus, talking about for last 2 days. But insomnia is a thing which is largely neglected by many of us. Many of us consider it as a passive state. Is it really a passive state? Actually, it is not. Sleep is a basic biological function and is essential for life. I think nobody would disagree with this thing. But it should always be considered as an active state that is critical for our physical, mental, and emotional well-being. Many a times, once we do not have adequate sleep or we have a defect in the quality of sleep, it can result in metabolic errors and cardiovascular dysfunction. Sleep is an emotional issue, and all diseases, particularly chronic diseases like diabetes, invite emotional reactions which can also affect sleep adversely. Many of times, it is highly ignored in our lifestyle. In our ancient times, it was very well respected and honored, but modern lifestyle has generated several diseases because of irregular sleep pattern, in which type 2 diabetes, cardiovascular disorder, and are very well connected with the sleep disorders, and they are occupying prime position in nowadays in human beings' life. All these 3 disorders are closely related and they are increasing each other once they are together. And sleep always plays an important role. Parallel to this is the rising prevalence of type 2 diabetes in our country, and we cannot deny that it may not be having the role of sleep irregularity in continuous rise in type 2 diabetes. Let's talk, how does insomnia impact glucose metabolism? As we all know that sleep is a metabolic regulator and sleep debt has harmful effects on carbohydrate metabolism. There has been done a study in which it has been proven that oral glucose challenge was higher in people, those who had sleep deprivation for a longer time. The people, those who have been kept away for 60 hours or more, they have been found to be having higher insulin response to their oral glucose challenge as compared to those who had their sleep pattern normal. And it suggests that insulin resistant state is induced by the acute sleep deprivation. Chronically reduced sleep times are associated with obesity, and once it is deprived, the subjects develops the daytime sleepiness and have a tendency to overeat and eat fast. Many of the time, it is seen that chewing tobacco, smoking also drive away the sleep, but are risk factors for type 2 diabetes also. There is somewhat relation with the lack of the sleep with type 2 diabetes, chewing tobacco and smoking always remains there. Subject deprived of the sleep for several days or more become irritable, fatigued, unable to concentrate, and usually disoriented. I don't think anybody would disagree with this fact, but considerable stress is generated out of this, and as a result of this, stress hormone like ACTH and cortisol are all highly secreted in early morning and they get low in the late evening. These effects result from a 24-hour cyclic alteration in the signals from the hypothalamus that cause cortisol secretion. It has been demonstrated that glucose tolerance is markedly better in the morning than in the evening. So chronic sleep restriction coupled with the eating contributes separately to the development of obesity and ultimately may impact on the causation of diabetes also. It is not uncommon to find nap pod in commercial organizations where employees can take a power nap to boost their performance. Chronic sleep deprivation in young healthy volunteers has been reported to increase level of pro-inflammatory cytokines, decrease parasympathetic and increase the sympathetic tone. It increases the blood pressure, increases the cortisol level as well as elevate insulin and blood glucose level. For all these reasons, the shift workers always remain on the higher risk. Although shift work concept is good for the industry, but it comes at a human cost. Shift workers are at heightened risk to a spectrum of illnesses. It results in circadian rhythm disruption. Shift work can have deleterious effects on metabolic equilibrium and can precipitate diabetes, particularly in genetically prone subjects due to chronic sleep deprivation. Data from the Sleep Heart Health study indicate that people sleeping 6 hours or less and those sleeping 9 hours or more per night have a higher prevalence of type 2 diabetes and impaired glucose tolerance. This is in comparison to people sleeping 7 to 8 hours per night even after those with insomnia symptoms are excluded, suggesting that voluntary sleep restriction may account for some of the public health burden associated with type 2 diabetes. Now talk about obstructive sleep apnea, which is again a very important risk factors for the metabolic disorder. Among the sleep disorders, obstructive sleep apnea, insomnia, sleep deprivation, excessive sleepiness, and restless leg syndrome have an impact on the glucose metabolism. Obstructive sleep apnea appears to have the strongest association with these metabolic disorders. In clinical practice, detailed sleep is often not recorded. Detection and treatment of sleep disorders in diabetes is essential since their treatment is highly rewarding. So we can see it here that high blood pressure, heart disease, diabetes, obesity, they all are generated through the sleep apnea if sleep apnea is there. Here you can see in this particular picture that difference of the normal airflow and sleep apnea. You can see that wide airway is providing the normal flow of the oxygen and keeping the heart healthy. On the other hand, if there is a sleep apnea, then oxygen supply is less and it keeps our heart always in the stress. So sleep disorder breathing is a spectrum of disorders which consists of snoring, upper airway resistance syndrome, and sleep apnea. It can be obstructive, central, or mixed. Must be appreciated that obstructive sleep apnea is a risk factor for the development of hypertension, ischemic heart disease, diabetes, and stroke. Habitual snoring predicts the onset of diabetes. There has been a study in which it was seen that people, those who have sleep and sleep-related disorders, 21.1% have the difficulty in initiation of the sleep. 21.9% are having the difficulty in maintaining sleep, and 12.2% have the excessive daytime sleepiness. Although difficulty in initiating sleep and difficulty in maintaining sleep are not very much different in the occurrence, the sleep complaints are often related to the presence of underlying sleep disorder breathing, which many a times is not well appreciated neither by patient nor by the doctors. Nocturia, physical complications of the disease, and underlying depression also. Many a times these things are responsible for irregular sleep, responsible for midnight awakening, and they produce the person in the sleep disorder. Polysomnography done in diabetic subjects revealed more wakefulness, a high number of the awakening, and fragmented sleep. Let's see how does it works with the insulin resistance. Patients with sleep apnea had significantly higher level of fasting plasma insulin and glucose levels than their obese control. So even if the people, those who are obese, they may not be having as much as high plasma insulin or level as it may occur with the sleep apnea symptom. Also, the group with sleep apnea demonstrated a higher degree of visceral but not subcutaneous fat compared to their obese control. There is repetitive pharyngeal collapse in sleep, resulting in cyclical hypoxemia, cyclical hypertension, and release of stress hormones and catecholamine. Nocturnal symptoms like many a times apnea, choking, dyspnea, restlessness, diaphoresis or excessive sweating, acid reflux, drooling, somniloquy, frequent changes of the posture in the sleep, and sometimes people are not able to sleep supine. They have got the bruxism also while sleeping. So all these symptoms may be associated with obstructive sleep apnea as well as a result of the cyclical hypoxemia which is occurring out of the obstructive sleep apnea. In diabetic subjects, there is often postprandial drowsiness is seen with a poor concentration, fatigue, and depression. Therefore, symptoms can be confusing and misleading. Flow chart is showing the close association of sleep deprivation with sleep apnea and type 2 diabetes mellitus. I would like to have your attention on the sleep disorder breathing and obstructive sleep apnea. How does it regulates so many disorders around the human beings and its life, that it's not only producing the apneic activity which is responsible for cyclical hypoxia in the night, which leads to increased sympathetic activity and rise in the catecholamine and cortisol level. The same thing is coming up from the modern lifestyle, which is generating rise stress, and stress is leading to the obesity. Many a times in depression also the people eat more, and it also contributes with the obesity. And this obesity is again associated with the sleep deprivation, nocturia, sleep fragmentation, insomnia, and it is adding up with the stress. On the other hand, we can see that all these things, once those who are giving rise to the high level of the catecholamine and cortisol, they are putting up the high stress on the metabolic system, producing insulin resistance and leading to the occurrence of diabetes. Sympathetic stimulation is connected with the insulin resistance, or we can say decreased insulin sensitivity. It results in release of the stress hormone and catecholamine. And once these effects are known to decrease the insulin sensitivity and worsening of the glucose tolerance, there is strong possibility that changes in sympathetic nervous system activity, corticotropic function, and systemic inflammation are associated with subjects with short sleep duration, insomnia, thereby causing metabolic dysfunction. Patients who are sleep deprived often exhibit fast eating and binge eating, which adversely affect glycemic status and digestion. In obstructive sleep apnea, there is excessive release of the stress hormone, catecholamine, cortisol, that cause the Cushing-like disease. Nocturnal excessive cortisol and catecholamine secretion can also spill over in the daytime. That is called as spillover effect, and it results in the fasting hyperglycemia. Hypothyroidism can be associated with obstructive sleep apnea. Daytime tiredness and sleepiness can be confused with hypothyroidism. Administration of the thyroxine without treating obstructive sleep apnea can precipitate cardiovascular events in sleep due to cyclical hypoxemia, particularly when in REM sleep. So there is a potential mechanism which is linking the sleep apnea to the glucose intolerance. Once a fragmented sleep is there or intermittent hypoxemia is there, it is not only causing the sympathetic activation, increasing the catecholamine level, but it also leads to the high level of the cortisol. It increases the reactive oxygen species, inflammatory markers by activating the inflammatory pathway, and it induces the leptin and reduces the adiponectin level. And all these are the prerequisites for the development of the insulin resistance, and it causes the pancreatitis beta cell dysfunction, ending up with the glucose intolerance and type 2 diabetes. There has been a study in which the sleep duration and risk of type 2 diabetes has been studied in a meta-analysis of prospective study. And it has been found that there is a U-shaped relationship. Dose response relationship was observed between sleep duration and risk of type 2 diabetes, with the lowest risk observed at a sleep duration category of 7 to 8 hours per day. Compared with 7 hours sleep duration per day, the pooled relative risk for type 2 diabetes were 1.09 with a 95% confidence interval ranging between 1.04 to 1.15 for each 1 hour shorter sleep duration among individuals slept. So what we could find that 7 to 8 hours is the ideal duration of the sleep. Let's come over to the conclusion of the talk. Both short and long sleep duration are associated with a significantly increased risk of type 2 diabetes, underscoring an importance of appropriate sleep duration in the delay or prevention of type 2 diabetes. There is a close relation between sleep, circadian rhythm, obesity, insulin resistance, hypertension, cardiovascular disorders, which needs to be dissected and managed. There is evidence to show sleep disorders such as obstructive sleep apnea, insomnia, short or long-term sleep duration, and restless leg syndrome are potential risk factors for insulin resistance, glucose intolerance, type 2 diabetes, and metabolic syndrome. Thank you for your kind listening.
Yeah. Thank you, Dr. Anuj sir, for this wonderful session. As we are running short, we'll just move ahead with the last leg of this first session. I invite Dr. Harsha Guna. Can we have slide? Yes, sir. Dr. Harsha Guna is MBBS MD from Sanjay Gandhi PGI.
Number, go room number.
So, Dr. Harsha, please invite our chairperson to introduce our speaker.
Yes. So thank you very much, Dr. Ajay. We are having a fantastic session for as of now. Now we will move on to the next session in the Hormone India program. That is, we have 3 chairpersons for this session. We are going to have a very interesting thing. Dr. Rashmi Verma, who is an assistant professor in PCMS Bhopal, and Dr. Soumya Gupta, who is a consultant physician in multi-specialty hospitals, and Dr. R.B. Patel, sir, who is a director at Bhagwati Nursing Home, Harda, for the last 30 years, and he's been a secretary of the Indian Medical Association. Welcome, everyone. And now I hand over the sessions to the chairpersons. Sir, you are on mute, sir. Dr. Patel, sir, you're on mute.
Dr. Soumya, can you take over?
Yes,
and
sir.
can you introduce the first speaker?
Good afternoon, everyone. Our next speaker is Dr. Muklesh Gupta, sir. He is MBBS, MD Medicine, PGBD. He has done PG Diploma in Diabetes, fellow in RSSDI. He's senior physician and diabetologist in Lucknow. Sir is director, diabetologist and physician Udyan Healthcare, multi-specialty hospital at Lucknow. He is also secretary Lucknow Diabetes Study Society. He is secretary Indian Podiatrics Society, UP chapter. He is also joint secretary UPRSSDI 2022. He is rendering services in rural areas of Jagdishpur and Hyderabad for more than 30 years at Social Commitment. He has done many research publications and participation in clinical trials. He is also in charge of Udyan Healthcare Ethics Committee and DHR Registry. So I would invite Dr. Muklesh Gupta sir to start the session.
Okay. Is my screen visible?
Yes, sir.
No. Are the slides visible and moving?
No, sir.
Sir, I think you have to share the screen.
Yeah, I shared it. Just a minute.
Technical team, can you share the slide?
Okay.
Sir, for that we need his their slide.
No, I just try again. Give me a second. So can my screen be seen now?
Yes, sir.
So are the slides there?
No, this is the WhatsApp page, sir. I think you have to share from. Close this, sir, and we can. You're sharing whole screen, sir, right?
Yeah, I'm sharing the whole screen.
I think you can close the WhatsApp and then we can.
Okay. So at the outset, I would like to thank Dr. Ajay, Dr. Mayur, and Dr. Shivendra. And straight away moving on to the topic, which is allocated to me, is diabetic peripheral neuropathy. And whenever we talk of diabetic peripheral neuropathy, pregabalin certainly comes to our mind because we prescribe it day in and day out. But today what I'll be talking is beyond beyond pregabalin in the management of diabetic peripheral neuropathy. I'll briefly rush through the initial slides to set the context and just to recapitulate some basics about the diabetic peripheral neuropathy. Now we know that diabetes is the most common cause of peripheral neuropathy, which accounts for nearly 32 to 53% of cases of peripheral neuropathy. We are also aware that diabetic peripheral neuropathy basically affects nearly 50 to 90% of our diabetic population. And this is one of the most common complications in diabetes, which ultimately also contributes to the development of diabetic foot. And we are also aware that diabetic foot is something which leads to amputation. And once amputation is in picture, then there is a very high mortality to come in future. Briefly going to the pathogenesis of diabetic neuropathy, it roots to hyperglycemia and various processes, involvement through the N6 fatty acid metabolism or the DAG or PKC activation, glycated products, oxidative stress, polyol pathways, and all this finally culminating into ATP depletion, nerve conduction velocity impairment, endoneural hypoxia, and the damage to the nerve endings. This is pictorically, we can see that there is occlusion of the vasa nervosum, and that leads to damage to the myelinated and the unmyelinated nerve fibers. Now, once we talk of a person with diabetes 20 years from the diagnosis, then we can see that only 10% of the patients, they are left without neuropathy. Rest 90%, 50% will be symptomatic, and 40% will be asymptomatic diabetic neuropathic patients. Briefly touching the classification, we are all aware about sensory motor neuropathy, the autonomic neuropathy, the mononeuropathy, and the proximal neuropathy, how we divide diabetic neuropathy. The symptomatology will depend upon the type of the fibers they are involved, large fiber neuropathy or the proximal motor neuropathy and the acute mononeuropathy. Basically, it affects the motor functions more so than the sensory. But if the smaller fiber neuropathy is there, then we have more of sensory symptoms. The symptomatology, if we talk about then, there are positive symptoms or negative symptoms, the spontaneous pain, allodynia, hyperalgesia, dysesthesia, paresthesia, and the negative symptoms in form of hypoesthesias, anesthesias, hypoalgesia, and analgesia. How the patient comes to us, that depends upon the class of the nerve fibers involved. More so, they are the peripheral small fibers they are involved, and therefore sensory motor neuropathy is something which is more common. The common symptoms with which the patient first comes to us are burning, lancinating, tingling, and shooting electric shock-like pain, where they are typically worse at night or when the person is tired or when the person is stressed. The things which we normally mention on our prescription is the hyperalgesia, which is the exaggerated response to painful stimuli, or allodynia, which is basically the sensation of pain that is produced with a stimulus which is normally not capable of producing pain. If the pain is evoked by simple contact, then it is known as hyperesthesia. If the person is having unpleasant sensation of burning, that is dysesthesia, or abnormal sensation, that is paresthesia. The involvement of large fibers may cause numbness, tingling without pain, and loss of protective sensation. Feet feel like they are wrapped in wool or person is walking on cotton. And all this ultimately will interfere with the activities of daily life, disability, psychosocial impairment, and overall quality of life of that individual. The common signs which we see in day-to-day practice, if the sensory neuropathy is there, dystrophic nails, callus formation, dry or cracked skin, sharp-cut foot. If there is motor neuropathy, then muscle wasting, muscle weakness, claw toe. And if suppose more so commonly what we see sensory motor neuropathy in form of painless ulcerations, neuropathic edema, Charcot's arthropathy, callosities, etc. Many times we forget about this entity. This is the autonomic neuropathy, and patients do come to us with symptoms like postural hypotension, gastroparesis, diabetic diarrhea, neuropathic bladder, erectile dysfunction, neuropathic edema, Charcot's arthropathy, so on and so forth. But this basically skips our attention because many a times we don't think about it, or many a times we don't have facilities to detect it. The diagnosis most often is the diagnosis of exclusion, and principally it is a clinical one, a combination of typical symptomatology and symmetrical distal sensory loss, or typical signs in the absence of symptoms in a patient with diabetes is highly suggestive of diabetic peripheral neuropathy. But many of the patients, nearly 50% of them, once we test them, they will not be able to pick diabetic neuropathy. So what are the common tests? We are all aware about the 10G monofilament, which is the Siemens-Winston filament for knowing touch, or the vibration sense using 128 Hertz tuning fork, or the other test to check for the temperature and the other losses. But nowadays we have devices which can test all of these in a very comprehensive manner and in very quick time. That is the NeuroTouch, and we don't miss on the testing part as far as the peripheral neuropathy is concerned. So these are the devices which can be used in day-to-day practice to detect diabetic neuropathy. If we talk of autonomic neuropathy, which skips our attention, but once we have facilities, then we see that this is also not very uncommon, but certainly these facilities are not available in many of the centers. So what we need basically is something which can be used in our day-to-day practice, and that is the neuropathic symptom score or neuropathy disability score, which can be used very easily in clinics and they have got very high sensitivity and specificity to the tune of nearly 90%. The management goals in case of painful diabetic neuropathy that we have to achieve at least 50% of pain relief, but we have to be realistic on this account. At the same time, we should also be setting the secondary goals like the changing the mood of the person, changing or improving the sleep pattern, the functionality of the patient if it is affected, that has to be improved, and the overall quality of the life has to be addressed. We are aware that pregabalin is something which is prescribed very commonly, but what I'll be discussing now from here, nearly 10 minutes or so, will be what beyond pregabalin. So we can address various spots in the pain management pathway. And if we talk of the central pathway, then medications that can affect the central sensitization like the alpha and the delta ligands via the tricyclic antidepressants, tramadol or opioids. We can affect the descending modulation through the SNRIs, TCAs, tramadol or opioids, or we can even address to the nerve terminals in form of the local application of capsaicin, local anesthetics, or tricyclic antidepressants. At the same time, we can also stimulate the spinal cord. This is what I'll be trying to talk. So we are aware that there are agents beyond pregabalin and gabapentin. They are duloxetine, topical capsaicin, tapentadol, amitriptyline, and venlafaxine. They can be used. And if I briefly touch upon these, duloxetine and venlafaxine, they basically root through the increasing the activity of noradrenergic and the serotonin neurons in the descending pathway of the dorsal horn cell. And these descending neurons inhibit the activity of dorsal horn neurons, suppressing excessive input, which is perceived as pain from reaching the brain. Duloxetine became the first agent approved by FDA in 2004. The dosage is 60 to 120 milligrams per day. And the common side effects are nausea, somnolence, hyperhidrosis, constipation, dry mouth, etc. Venlafaxine can be used in the dose of 150 to 225 milligrams. Practically similar side effects, excepting for hallucinations and increased heart rate, which can be additionally there. If we talk of tricyclic antidepressants, amitriptyline is the most commonly used tricyclic antidepressant because of the fact that it acts at more than one places in the pain pathway, and certainly this is of use in addition to the first line drug. Dosages ranges from 10 milligram to 90 milligram per day. The adverse effects are the cholinergic side effects, which we are all aware about, and also the QTC prolongation, which we should take care of. If we talk of opioids, then all guidelines, they talk of avoiding their long-term use, but tapentadol is the only opioid specifically approved by FDA for the use in treating peripheral painful diabetic neuropathy. Tapentadol is a strong analgesic that combines the mechanism of an opioid receptor agonist and also the norepinephrine reuptake inhibitor. And therefore, it is having dual mechanism of action, and it is recommended, approved, and this is something which we use in our day-to-day practice. The dosage is 200 to 500 milligrams per day. The normal adverse effects are nausea, vomiting, and dizziness. Topical capsaicin in 2020, the FDA approved capsaicin 8% topical patch for treating painful diabetic neuropathy. Topical capsaicin works via agonism of the transient receptor potential vanilloid 1 receptor, that is TRPV1, and topical exposure is thought to reduce the TRPV1 expression, nociceptive nerve endings in the affected area, providing period of pain relief lasting for several months. The other agents, there is a very nice article which is published very recently, that is the American Association of Neurologists Guidelines Subcommittee recommendation, and they have basically taken into cognizance all possible modalities to treat diabetic peripheral neuropathy. And briefly to talk about carbamazepine, may be tried 200 to 600 milligrams BD. L-carnitine, there are 2 RCTs showing improvement in pain and nerve regeneration. ALA, there are conflicting results. Sodium channel antagonist or blocker in form of lamotrigine, that is 200 to 400 milligram per day, lacosamide 400 milligrams per day, or sodium valproic acid in the dose of 1000 to 1200 milligrams per day, or 20 milligram per kg per day. Or there can be a combination of valproic acid and glyceryl trinitrate that can be used. But the line is that if only partial efficacy is achieved, achieved with one agent, then adding a second medication should be of different class that may provide a combined efficacy greater than that provided by each medication individually. If we talk of the clinical evidence which is available, there are numerous RCTs, which the double-blinded trials, which are talking of the positive effect of all these agents in the management of painful diabetic neuropathy. Now coming on to something beyond the pharmacotherapy, and that is the neuromodulation. The International Neuromodulation Society defines neuromodulation as medical technologies that reversibly enhance or suppress nervous system activity with the goal of treating disease, and in both implantable and non-implantable devices that deliver electrical, chemical, or other agents. So what are the neuromodulation therapies? The neuromodulation therapies are intrathecal therapies, transcutaneous electrical nerve stimulation, and spinal cord stimulation, and more recently is the 10 kilohertz spinal cord stimulation, which has been found to be useful. There are a lot of evidences which are available, which have tried as RCTs as far as the efficacy is concerned, and I'll talk briefly about all of them. Transcutaneous electrical nerve stimulation TENS is a non-invasive, inexpensive, and easy-to-use form of neuromodulation to treat both acute and chronic pain with few contraindications and no known drug interactions. Patients treated with TENS have electrical stimulation applied, and then there is high frequency, more than 50 hertz, or low frequency, less than 10 hertz of bursts, which are given to the cutaneous stimulation. The mechanism, of course, is not very well known, but the hypothesis is that it can improve microcirculation, higher levels of beta endorphins and enkephalins that increase expression of protein, including calcitonin, gene regulating protein, and the nerve growth factor, and reduce inflammation. So through these mechanisms, probably the TENS gives that benefit. Talking about other modalities like low frequency pulsed electromagnetic field, that is known as PEMF, or frequency modulated electromagnetic neural stimulation known as FREMS. There is some data, but the effects, they are transient. If we talk of intrathecal pain therapy, then ziconotide or morphine is recommended and FDA approved for chronic neuropathic pain, such as associated with painful diabetic neuropathy. So ziconotide is recommended more strongly by the Polyanalalgesic Consensus Conference also. There is no tolerance or withdrawal, and significantly less respiratory depression. It is non-opioid analgesic that binds selectively and reversibly to N-type voltage-sensitive calcium channels, thereby blocking the release of pro-nociceptive neurotransmitters in the spinal dorsal horn. If we talk of the conventional spinal cord stimulation, that it was first used in 1967, and it is being used since then. But then there are a lot of advances which have happened in this direction. And if we talk of the effect, then the mechanism is based on the gate control theory of Melzack and Wall. And if we talk to the functional MRI imaging, then it has been shown that the activation of supraspinal areas that modulate pain transmission in the dorsal horn via descending serotonergic and the noradrenergic projections. The burst spinal cord stimulation, unlike the conventional and the high frequency spinal cord stimulation, which delivers stimulation at a constant or tonic frequency, in this burst spinal cord stimulation, it is characterized by clusters of high frequency pulses separated by the longer interpulse intervals, and it is intended to emulate naturally occurring neuronal firing patterns. There is a limited evidence, but what we have, something which is now having a very good outcome, is the 10 frequency, the high frequency 10 kilohertz spinal cord stimulation. And if we talk of the trial, then the Senzapan study, which is a 6 months result of this study, were presented in 2021 meetings in the North American Neuromodulation Society, and it is set to achieve the primary endpoint of 50% pain relief in 86% of the subjects. So this is something which is being used. Now, talking something about futuristic in the diabetic peripheral neuropathy or the painful diabetic neuropathy, then there is the role of hepatocyte growth factors. So, if this is briefly discussed in or published in November 2021. If we talk of a snapshot on this product, then this is cDNA plasmid coding for human hepatocyte growth factor. It is given as intramuscular injection with angiogenic potential. The potential target is basically to prevent the development or progression of diabetic neuropathy. There are phase 3 trials and extended trials of this. Hepatocyte growth factors basically is a multifunctional cytokine known to induce neurotrophic activities, including the enhancement of neuronal survival. And if we talk of this extension study, then there is a regeneration potential of this hepatocyte growth factor, which has been identified, because patients, those who are expressing or those who are given with this hepatocyte growth factors, only 2 weeks following injection, but the pain relief was continued over a period of nearly 8 months or more. And therefore, that gives that there is something which these factors, they do to the regeneration potential for these drugs. But if we talk of the peripheral neuropathy, then we should not forget about the basic foot care education, which is part and parcel. We are all aware about it. And we have to remember that we have to take care of all these factors once we are talking or treating peripheral neuropathy in our patients. Thank you so much for your patient listening. And I should compliment, because we are witnessing the potential of Young India through Hormone India. And I must compliment Dr. Mayur, Dr. Ajay, and Dr. Shivendra and team for their out-of-box thinking in creating this fantastic conference. Thank you so much for your patient hearing. Over to you once again.
Thank you, sir. Dr. Harsha, I think we can go ahead.
Yes, Dr. Ajay. So thank you very much, sir, Dr. Muklesh Gupta, sir, for the excellent talk about diabetic neuropathy. Now we'll move to the next session. It is but by none other than a very famous and renowned speaker and very active speaker throughout India. He is none other than Dr. Sunil Kota, sir, from Behrampur. He will be talking about thyroid disorder screening for people with diabetes mellitus. And Dr. Sunil Kota doesn't need any introduction. He's a famous endocrinologist from Orissa. He has authored many books and published many studies as well. And let's start us with the topic, Dr. Sunil, sir.
Thank you so much. Thank you so much, Dr. Harsha, for those kind words. Hope I'm clearly audible to all of you.
Yes, sir. You're very much audible. Yes, sir.
Thank you so much, Dr. Harsha, Dr. Mayur, Dr. Ajay. It indeed is a vibrant and young team. I can see many familiar faces, including that of Raka, sir. And today I will be taking you through this wonderful interaction between these two common endocrinopathies. Those are thyroid and diabetes. If you want to learn about the physiological effects of thyroid hormone, there are multitude. First of all, it acts on the liver to produce more of glucose by glycogenolysis and glycogenesis. It acts on the intestine to increase the absorption of glucose across the intestinal wall. Not only that, it acts on the beta cells to make them more responsive towards the ambient glucose. So it acts on insulin secretion. And also it acts on the peripheral tissues to increase the GLUT4 expression. Therefore, the glucose uptake is enhanced. So there are a number of mimics. Like glycemic control may mimic hyperthyroidism by virtue of fatigue, increased appetite, and weight loss. At the same time, diabetic nephropathy may also mimic myxedema by virtue of edema, fatigue, pallor, and weight gain. So with this brief preamble, I'm going to take you through the following points. First of all, I would be talking to you about prevalence of thyroid dysfunction in diabetes. So are these strange bedfellows or mutual companions? By this point of time, we have a number of evidences suggesting that these are actually mutual companions. And in this study in 2014, compared to general population prevalence of 6.6%, the prevalence of thyroid disorder in diabetes population is around 10.8 to 13.4%. This exactly is in sync with the meta-analysis by Kadiala et al. In 2010, that there is a 11% frequency of thyroid disease. And if you talk about international references, we have a number of studies from across, and what you can see is that the overall prevalence is somewhere between 6 to 12%, but then Nigeria is an outlier, and the predominant manifestation of thyroid dysfunction is hypothyroidism, somewhere between 10 to 30%. Again, UK, one study we have Perros et al., which suggests a prevalence of around 47%. This was a study, I take it back to my endocrine residency days, where we have studied 200 patients of metabolic syndrome, and we found hypothyroidism in 42 people, and the prevalence was really high. And obviously, it was in tune with what others have reported. The subclinical hypothyroidism was again higher. And there are a number of studies from across India, Punjab, Tamil Nadu, Pune, Bangalore, Imphal, and the overall prevalence is somewhere between 25 to 35%. Again, hypothyroidism contributing to the most of the thyroid dysfunctions. Again, this was one of our seminal articles, I would say, rather seminal articles from our side, not really the seminal article. In 2012, we looked at around 260 type 1 diabetic patients, and hypothyroidism was found in 28 patients. Compared to other studies, Menon et al., Goswami et al., our prevalence was a bit lesser. And this is just to give a glimpse of the number of studies that have been done across the globe to look at the prevalence of different types of thyroid abnormalities in type 1 diabetes. Overall, autoimmune thyroid disorder was found in 3.9 to 24%, antibody positivity in 2.5 to 32%, overt hypothyroidism up to 15%, subclinical up to 11.5%, and clinical hyperthyroidism had a range between 0.07 to 9.3%. Not only that, presence of autoimmune thyroid disorder does increase the chance of getting a diabetes antibodies. So that you can see the ICA 1.3 to 19%, followed by GARD 65 was found in 5.3 to 11% of patients. So where is the link? We have a number of common susceptible genes within HLA-DR3, CTLA4, PTPN22, FOXP3, AI, RE gene, and we know the different types of PGAs or the polyglandular autoimmune syndromes, especially type 2 and type 3. There is a strong association between these two disorders. Not only that, there is this polymorphism of deiodinase type 2, which is associated with an increased risk of type 2 diabetes, which obviously the chances go up with age. So thyrotoxicosis and diabetes, again, a number of studies are there. Prevalence, there is a wide range, somewhere between 12 to 57%. So that again is important. That should alert us towards screening every patient with hyperthyroidism towards diabetes, though there are no clear-cut guideline recommendations. So what exactly does it do? There is an increase in hepatic glucose production by GLUT2, which gives rise to glycogenolysis. There is non-oxidative disposal of glucose, giving rise to more of lactate. There is lipolysis, giving rise to more of free fatty acid. These lactate and free fatty acids form the substrate for gluconeogenesis. There is increase in gastrointestinal glucose absorption, increase in insulin clearance. There is a release of biologically inactive insulin precursors. There is increase in the counter-regulatory hormones, and also there is apoptosis of beta cells. So simply remember, hyper gives rise to hyper, that is hyperthyroidism is associated with hyperglycemia. Not only that, we know there is a condition called CQ thyroid syndrome. There can be poor glycemic control, which can mimic the diabetic hyperthyroid state. And not only that, we have typical osmotic symptoms of hyperglycemia can also be found in patients having thyrotoxicosis. So we need to be careful about picking up the cases of CQ thyroid syndrome. Not only that, there is increased incidence of dysthyroid optic neuropathy. There is increase in goiter size as well. And we know we should be cautious about using the thiazolidine if a patient is having diabetes and active graves of ophthalmopathy. What about hypothyroidism and diabetes? There is reduced glucose-induced insulin secretion. There is decreased hepatic glucose output. Insulin resistance goes up because of decreased translocation of GLUT4 to the surface. There is reduced clearance of endogenous and exogenous insulin, reduced appetite and decreased food intake. So you can simply remember, hypo gives rise to hypo. That means hypothyroidism is associated with predominantly hypoglycemia. Effect of hypothyroidism is there on the complications of diabetes because of the coexisting dyslipidemia, hypertension. There is increase in CV risk. There is increased risk of nephropathy and retinopathy. There is aggravation of muscle weakness. There is an immune suppressive state. There is a potential of increased infection. And also there is decrease in counter-regulatory response, pushing the patient towards hypoglycemia unawareness. Not only that, hair loss gets aggravated. There is a worsening of pulmonary function, and also there is exercise intolerant setting in with fatigability. We know the classic signs of neuropathy in diabetes, but then this is Voltman signs of hypothyroidism, delayed tendon jerk relaxation. So somewhat having a similarity with that of the neuropathy of diabetes. So what about the effect of drugs? Metformin inhibits the AMPK in hypothalamus and therefore enhances the inhibitory modulation of thyroid hormone on hypothalamus. So it reduces the TSH in patients having primary hypothyroidism. It shrinks the thyroid nodule size. And in addition to levothyroxine, the chances of reduction of the thyroid nodule goes up from 30% to 50%. And also it is associated with higher remission rate in diabetic patients with differentiated thyroid carcinoma. Sulfonylurea, especially the first generation ones, they reduce the iodine uptake and they have a goitrogen effect. There is similar observation also with gliclazide, but thankfully we do not have any contraindication for usage of sulfonylureas. But again, reiterating the same thing, that there is chances of exacerbation of Graves' ophthalmopathy when you use glitazones. Incretin mimetics, they have a hyperplastic effect on the C cells, in the animal study, but we do not have any human studies, good number of human studies. But then GLP-1 receptor agonist, however, not recommended in patients with personal or family history of MTC or men type 2. Statin-induced myopathy is again more common in hypothyroid patients, so lower dose statin should be administered. And very importantly, it is something, levothyroxine replacement in diabetes, and I'm not going to read out the slide in detail, but co-administration of levothyroxine does help in reduction of A1C in patients having type 2 diabetes and coexisting subclinical hypothyroidism. So there is a school of thought, though these are not represented by a big group of people. It states that if a person is having diabetes with subclinical hypothyroidism, please start treating with levothyroxine, thereby giving the patient a better glycemic control and reducing the chances of glycemic complications. Effect of antithyroid drugs, glucose control usually improves with return of gluten to euthyroid state, and apart from that, the beta blockers can mask the warning symptoms of hypoglycemia. So there is a probability of hypoglycemia unawareness if the patient is on beta blockers. What about pregnancy? There is a modestly increased risk of GDM in thyroid disorder, 3 times increased risk of thyroid disorders in GDM in pre-GDM, and 25% of the women with type 1 diabetes may develop postpartum thyroiditis. And if these two disorders coexist, there is an increased chances of cesarean section, preterm deliveries, and hypertensive disorders of pregnancy. So how do we translate this particular knowledge into clinical practice is that a person of type 1 diabetes planning for pregnancy or at the beginning of pregnancy, go for TSH and TPO antibody. If you find only antibody positivity, then TSH should be checked at 3, 6, and 12 months after delivery. Screening for GDM, if TSH is higher than normal time, than the normal trimester specific values, we have to look for the first part of the pregnancy. And about the thyroid carcinoma and diabetes, we have a number of studies, but the conclusion is that there is lack of overall association of thyroid carcinoma in most of the studies. So last part of my presentation would be to talk to you about few of the practical recommendations that we can actually inculcate amongst ourselves. Screen for type 1 diabetic patients for thyroid disorders, T3, T4, TSH, anti-TPO antibody, anti-TG may not be done, but this is a guideline which I'm quoting. There is a question mark after the anti-TG antibody. If the TSH and antibodies are normal, repeat annually or biannually. But if the antibody is positive with normal TSH, repeat every 6 months. But the chances, the testing frequency can go up if there is an impairment of linear growth, goiter, or there is onset of hypothyroid symptoms. As far as type 2 diabetes is concerned, you can see there is no definite recommendation when exactly should we be subjecting the patient to thyroid disorder screening. But then it is the 88-2000, dates back to 2000, but then still it states that from 35 years onwards, do the TSH and once in every 5 years in all adults. This is something which I found interesting. This was published in 2018. All patients with diabetes, baseline evaluation of TSH and anti-TPO antibody. If there is thyroid dysfunction, if it is overt, start, treat, and monitor it. Subclinical hypothyroidism, we all know what are the indications to treat. If the person is euthyroid and if is type 1, annual TSH. If it is type 2, many may not agree, but this is the recommendation by this particular paper. TSH more than 2 or TPO antibody positive, annual TSH should be done. In case both the values are below these thresholds, once in 3 to 5 years, TSH can be done. That brings me to the summary of my presentation. Both overt and subclinical thyroid disorders are frequently encountered in diabetes, and we know hypothyroidism and hyperthyroidism have a vivid effect on the blood sugar levels. All diabetes should be screened at baseline for the thyroid dysfunction. Again, question mark comes with that particular statement. Metformin in TSH, yes, there is innovative therapy of thyroid proliferative disease. As we all know, the thyroid nodules, they shrink in size once you start using metformin. There is an increased risk of diabetic complications like nephropathy, retinopathy, neuropathy, and also cardiovascular disorders. They do go up. So you may start treating patients having SCH with TSH more than 4.5 with levothyroxine. This might prevent later complications of diabetes. And also we should be very much alert towards recognition and promptly correcting the thyroid dysfunction to optimize metabolic control and reduce cardiovascular disease risk in patients with diabetes. So thank you all for the patient listening. Hope I finished it on time, and thanks to the organizers. Lovely conference, great content. Congratulations to all of you.
Thank you very much, sir, Dr. Sunil, sir. It was an excellent session. I think if we have 1 or 2 minutes, Dr. Sanjeev Gulati has asked a question that the dose of levothyroxine in subclinical hypothyroidism with type 2 diabetes. If you can spare 30 seconds or 1 minute, we can have a quick answer for that.
See, there is no separate guideline to suggest what should be the dosage. If a person having type 2 diabetes is having subclinical hypothyroidism, you can start with 25 to 50 microgram. But as we all know, if there is any coexistence of other disorders, especially the involvement of cardiovascular system, then probably you can even start with a lower dose.
Yes, sir. Yes, yes. Thank you very much, sir. Yes, that's well answered question. So we can move on with the next topic. Yes, the next speaker is a very well-renowned person, Dr. Satyam Jayant, who has done his MD and DM from Chandigarh, who is a consultant diabetologist and endocrinologist. And his topic is diabetes and bone. And that's going to be a very interesting thing. We know how diabetes affects the bone, and many people differ in their opinion. Some suggest it causes increased risk of fractures despite causing an increased BMD. So we'll see this topic from Dr. Satyam Jayant. We'll welcome Dr. Satyam Jayant.
Thank you, sir, for kind introduction. And I also thank Dr. Mayur Agrawal and team Hormone India for inviting me as a speaker to share my view on the given topic, diabetes and bone. So are my slides visible to everyone?
No, the slides are not visible. Probably you are in whiteboard mode.
Okay, just.
Just stop sharing and reshare.
Oh, please. Now,
team, do you have the slides to share?
Is it visible to now?
No, it's not visible yet.
Not visible. Share screen. I think probably now it is visible.
Yes, sir. It's visible, sir. Yes.
Okay. Thank you. So today's given topic to me is diabetes and bone. As all of us know, diabetes is a pandemic disease, worldwide prevalent, and more than 450 million people are suffering from diabetes. As the longevity of diabetic patient increase, there is a more and more complication also increase associated with diabetes. So fracture is one of important entity that is also found significantly in diabetic patient. And despite of being preserved or increased BMD, the risk of fracture is increased in type 2 diabetic as well as type 1 diabetic patients. So studies has revealed that fracture risk, either it is at hip or non-hip region, it is increased in type 1 diabetes by 4 to 6 fold and 2 to 3 fold respectively, while it is in type 2, it is around 1.5 and 2-fold increase respectively. And fracture-related consequences are also worse in diabetic patient as compared to non-diabetic. So this is the systemic meta-analysis of major 12 study that revealed that the overall risk of fracture in type 2 diabetes is around 1.7 times higher as compared to non-diabetic population. Similarly, in a type 1 diabetic patient, the meta-analysis of 6 study revealed the relative risk is around 6.3 times higher as non-diabetic patient. So fracture burden in diabetic patient, as per WHI data, it increases the risk of fracture at every site, but most common site of fracture is hip, pelvis, and upper leg, followed by foot bone, and risk is increased at every place. So this is a study conducted at the PGI, in which they found the prevalence of osteopenia and osteoporosis around 40 and 33% individual who have suffering from type 2 diabetes. And they also give the predictors of fracture. So in the predictor of osteopenia and osteoporosis that may lead further future fracture, among that, female has 5.9 odd ratio for the osteopenia and osteoporosis. Increasing age is another risk factor. Normal body mass index is another, and most common risk is use of pioglitazone. That is around 10.6 odd ratio having for the osteopenia and osteoporosis. So come to the diabetes and bone health. Bone remodeling is compromised both in type 1 and type 2 disease, as it is low bone turnover state, and it occurred due to the alteration in the microarchitecture of the bone. It happened due to the increased cortical porosity, a small cortical area, and decreased tensile strength of the bone. BMD and FRAX both underestimate the fracture risk in diabetic patients, so it is not reliable, and we should use correction factor for that. And fracture risk reduction should be an important goal in the management of type 2 diabetes, as we have other important goal in the diabetes like blood pressure, cholesterol, LDL, and TG. Similarly, we also have the fracture risk prevention tool as well. So come to the mechanistic insight of the bone disease in the diabetic patients. So it occurred due to the impaired glucose insulin homeostasis, and it has direct as well as indirect effect. In the direct effect, it impaired the function of osteoclast and osteoblasts, so both function is diminished in diabetes patient, and indirectly it also affect on the muscle. So muscle weakness may lead to the altered anabolic signaling, and deposition of the advanced glycogen end product may lead to the abnormal collagen cross-linking that may impair the bone remodeling and biomechanics, and bone vasculature also altered due to the endothelitis of the distal bone end, and that may lead to the decreased vascular supply to the bone, and it may lead to the altered microarchitecture, and that may lead further fracture. So this is the graphical or pictorial depiction of the type 1 versus type 2 versus healthy diabetic bone disease, in which we found that the number of osteoblast is reduced, and there is a more and more adipocytes, and there is a more advanced glycogen and products deposition in the bone that may lead to the abnormal cross-linking, and there is an increased cortical porosity and decreased per area bone strength, so it may lead to the decreased tensile power of the bone. So these are the three main issues: bone strength, bone quantity, and bone quality. So quality. So all are impaired in diabetic patients. So this is a pictorial diagram that shows that at the similar BMD, diabetic patient have higher risk of the fracture, and utilization of insulin further increase the risk of fracture, especially in the women as compared to men. So we should use correction factor for predicting accurate fracture risk by adding 0.6. So if suppose one patient has observed t-score of -2, then it should be -2.6 for calculation of the fracture risk. So we have different modality to assess the quality and quantity of the bone. In the osteoporotic fragility fracture with or without type 2 diabetic patient, we have indentometer as well as X-ray microfocus CT system. So these are the basic microarchitectural difference between the type 2 as well as control individual, and we found that trabecular thickness as well as the trabecular number significantly reduced in the diabetic patient as compared to non-diabetic. So what are the determinants of bone health in diabetic patient? The duration of diabetes, poor glycemic control, and associated complication, as well as anti-hyperglycemic agents that we have used in the treatment of diabetes are determinant for the bone health. So as the duration of diabetes increase, the fracture risk is increased. So this is depicted in this table. So the risk of diabetes individual who have or experience the fracture increase with the duration of diabetes. So glycemic control is another important risk factor for the fracture, as the individual who have poor glycemic control are more prone to get fracture. So associated complications like diabetic retinopathy, diabetes duration, and utilization of the insulin, blood glucose level, and presence of the cataract. These are the another important associated comorbidity that individual with type 2 diabetes usually have. So these are the, if present, may increase further risk of fracture. So come to the drugs that are used in the diabetes and how they affect the bone health. So come to the glutazones that are important drugs that usually increase the fracture risk, that has been evident from the ADOPT study with the rosiglitazone and proactive study with the pioglitazone. We have 22 RCT that confirm the atypical and as well as osteoporotic fracture risk increase, and twofold higher risk in pre and post menopausal women. The reduction in BMD at hip is 1% and lumbar spine is 1.1 with the duration of 1 year utilization of the glutazones. So reduced bone formation as well as increased bone resorption is the important inciting mechanism, and affected individuals who are using pioglitazone may develop this fracture risk because of it increase osteocyte and promote the production of sclerostin and DKK1 that and rankle. DKK1 actually involved in the WNT pathway that is important in the bone formation, and differentiation of primitive mesenchymal stem cell to the adipocyte is also promoted by the glutazone. So these are the another mechanism, and simultaneously glutazone also reduce the androgen and estrogen level that further increase the osteoporosis and osteopenia. The fracture risk is similar to non-user after discontinuation of therapy, that is evident in ACCORD study. So this is another study that shows the individual who are using pioglitazone have lower testosterone level as compared to placebo. So come to the SGLT2 inhibitors, that how they affect the bone. So in the CANVAS study, the risk of fracture, especially in upper limb and ribs, increased with the canagliflozin. The odd ratio was 1.23, and there is also increase the fracture at the upper limb as well as rib, and increase the bone loss at the hip by 1.2% in 2-year study. While in the EMPA-REG study, there is no increased risk of fracture has been captured with the empagliflozin, and similarly in the DECLARE TV, there is no increased risk of the fracture observed with the dapagliflozin, although the incidence of fall increased due to the decreased intravascular volume. So come to the another agent, that is incretin based therapy. Both osteoclast and osteoblast express the GLP-1 receptor. Animal data shows increased trabecular but not cortical bone mass with the exenatide and liraglutide. Liraglutide decrease the fracture risk. Odd ratio is 0.38, means there is a significantly decrease the risk of fracture in the individual who are using liraglutide, while the risk little bit increased with the exenatide. And to large observational study, there is a no increased risk with the GLP-1 agonist observed. And DPP-4 inhibitor, there is a no any risk increase for the fracture in type 2 diabetic patient. So come to the metformin. We have animal data that shows the utilization of metformin increase the BMD. It occurred due to the RUNOX and AMP activation, and it also inhibit the adipogenesis through AMP kinase and mTOR pathway. It decreased the osteoclast development and improved bone microvasculature. So overall, metformin has beneficial effect on the bone health, and it is also evident in the ADOPT trial. There is no increased risk of fracture has been observed in the metformin versus glimepiride group. So come to the sulfonylurea. Sulfonylurea has limited RCT that demonstrate the risk of fracture risk. Although glimepiride increase the osteoblastic differentiation in rat, but human data is lacking, and there is a conflicting result regarding the fracture risk. And sulfonylurea increased fracture risk probably because of hypoglycemia. Once patient developed hypoglycemia, there is a more risk of fall, and fall may precipitate the fracture in the individual who are at the high risk, means individuals who are lean and thin, then they may get fracture. But sulfonylurea per se does not increase the risk. Come to the insulin. Insulin is an anabolic to the bone health, but studies shows that with the utilization of insulin, the risk of fracture is increased. So it is again because of concurrent hypoglycemia and diabetes. In diabetic individual, utilization of insulin further suggests that diabetes is in advanced state. So this may be the conflicting points that may cause increased risk of fracture in insulin group. So come to the vitamin D. Vitamin level tend to be lower in type 1 as well as type 2 diabetic patient. Obesity may contributory factor for vitamin D deficiency, and calcium and vitamin D supplementation should be given to all patients who are at risk for the fracture to minimize the fracture risk. So come to the summary of anti-hyperglycemic drug on the fracture. Insulin definitely increase the BMD as it is anabolic, but fracture is increased because of hypoglycemia and advanced diabetes condition. Sulfonylurea BMD effect is not known, and fracture is per se not increased, but due to the hypoglycemia, fracture it increased due to the increase in the fall. Metformin has neutral effect. Glucagon definitely reduce BMD and increase the fracture risk. GLP receptor agonist, especially liraglutide, increase the BMD and fracture risk does not affect it. While in exenatide, there is a little bit increment in the fracture risk as well. And DP4 inhibitor is neutral at the point of BMD increment and fracture risk increment. And SGLT2 definitely decrease the BMD and increase the fracture risk. So strategy for the fracture prevention in type 2 or type 1 diabetic patient. All subjects with higher fracture risk should avoid glutations as well as SGLT2 inhibitor, and all patients should have good glycemic control. Appropriate address to the diabetic complications, especially neuropathy, autonomic neuropathic dysfunction, cataract, and fall prevention should be adopted in all individuals, and optimal calcium and vitamin D intake should be ensured in all diabetic patients who are at risk, and weight-bearing exercise should be advised, and cessation of the alcohol and tobacco should be advised to all individuals. So does fracture management differ in diabetic patient? Answer is yes, because BMD and FRAX score underestimate the fracture risk in type 2 diabetic patient. Use of TBS may be more rewarding, and lower turnover state in diabetic lead to the concern for the utilization of bisphosphonate. However, the bisphosphonate, SUNS and recombinant PTH have similar anti-fracture efficacy in diabetic patient as compared to non-diabetic, and fracture risk assessment should be important goal in management of type 2 diabetes or diabetes with osteopenia or osteoporosis. At the conclusion, patients with diabetes have increased risk with the worst fracture-related outcomes. BMD, T-score, and FRAX underestimate the fracture risk in patients with diabetes. Newer modality like TBS and HRPQCT may have more predictive and actually predict fracture risk. Majority of anti-diabetic agents have neutral effect on the bone health. However, the glutagens and SGLT2 inhibitors should be avoided in high-risk individual. Beside the HbA1c, LDL-C, hypertension, and lipid, fracture risk reduction should be a goal in the management of diabetes. With this, I thanks. And if there is any question, I will be happy to answer. Thank you for patience here.
Thank you, Dr. Satyam. Dr. Harsha, are you there? So we like to move ahead with Dr. Sanjay Kapoor, sir. Sanjay Kumar, sir. Dr. Harsha Guna, sir. Yeah. So Dr. Sanjay Kumar is a director and chief gastroenterologist of Bhopal Institute of Gastroenterology and Gastrocare Hospital. He's fellow of American College of Gastroenterology, past president of ISG, MPCG. He has more than 30 publications. And with that, I invite sir for present his talk.
Hello, everyone. Am I audible?
Yes, sir. Yeah, you're audible.
Thank you,
for
the Hormone India team, for giving me this opportunity. I'll be very happy to interact on a very important topic, which is often ignored, I believe, by many physicians. That is fatty liver and diabetes. I'll just try to share my screen. Are you able to see?
Yes, sir.
Yeah. So as I said, this is a very important topic because most diabetics would undergo regular investigations and screening for a number of diseases, but often liver is ignored as seen in practice. My talk will be, this is not moving.
Yeah, it's not moving.
No, sir.
No, I think it's moving now.
Yeah.
I will just make it a. This okay. So the flow of my talk will be, first I'll briefly discuss about the clinical scenario and epidemiology, then association of NAFLD and diabetes. What is NAFLD? What is its natural history? What could be the screening tools? And is efficient screening tool? And what are the current recommendations by various societies? I'm getting some disturbance.
Backend team, please mute everyone. Except sir. Yeah.
So if you look at the epidemiology, the global prevalence of non-alcoholic fatty liver disease amongst diabetic patients is nearly 55%. And if you see here, we in India are about 57.9. The maximum prevalence is in Europe, which is about 68%, and lowest is in Africa. For well-known reasons, it's about 30%. I'll start with two index cases. This was a 60-year-old female who came to me. She's a diabetic for 20 years. She was on regular follow-up with a physician, and she presented with hematemesis. When we evaluated her, she had large esophageal varices on endoscopy, and we did the endoscopic varicose ligation. Her hemoglobin was 7.5, platelets were low. The bilirubin, OT-PT were normal. The only finding on LFT was a reversal of AG ratio. Ultrasound showed coarse ecotexture of liver and mild ascites. We did a fibroscan which showed high E score of 32 kPa, which is suggestive of cirrhosis. Another case, a 72-year-old male who was a diabetic for 25 years, developed some loss of appetite and dyspepsia for 1 month. And when he was evaluated by an ultrasound, it showed a large liver lesion of 10 into 7 centimeters. When we did a triple phase CT abdomen, it showed that it was hepatocellular carcinoma. He was hepatitis B and C negative. So are these both complications of diabetes mellitus? A very big yes. These are the complications of diabetes mellitus. They can develop fatty liver and cirrhosis, and they can develop hepatocellular carcinoma. Second question, could these have been prevented? Yes, to a large extent. If you diagnose fatty liver in time, when fibrosis is setting in, there are ways to halt it, if not reverse it. So let us see the incidence of liver disease in diabetics. So how common are they? The prevalence of NAFLD and NASH in patients with diabetes is over 60%. Patients with NAFLD have 2 to 3-fold risk of development of diabetes. The reverse is also true. Patients with diabetes mellitus have a higher prevalence of steatohepatitis, cirrhosis, end-stage liver disease, and HCC. Presence of diabetes and IGT seems to accelerate the course of NAFLD and is a predictor of advanced fibrosis and mortality. As age increases, so does the prevalence of NAFLD. Interestingly, type 1 diabetes mellitus do not have NAFLD unless they are obese. So they also develop NAFLD only when they become metabolically inaccurate. So what is NAFLD? It is defined as a condition in which 5 to 10% of hepatocytes exhibit macroscopic steatosis by light macroscopy in the absence of other etiologies of liver disease. NAFLD predisposes to diabetes, cardiovascular disease, NASH, cirrhosis, and HCC. And there is a huge need of liver transplantation in this patient. In fact, this is the commonest cause of liver transplantation across the globe now. In a recent meta-analysis, the global prevalence was estimated to be 25% of NAFLD. So imagine about 1/4 of world's population is affected by NAFLD. NAFLD and metabolic syndrome share common pathophysiology. That is why they frequently coexist. Once we say that diagnosis of NAFLD, it requires exclusion of both secondary causes of fatty liver and daily alcohol consumption of more than 30 grams of men and more than 20 grams of women are excluded. So there are various causes of macrovascular and macrovascular steatosis. Alcohol causes macrovascular steatosis, and variety of drugs like valproate, etc., they cause microvascular steatosis. All the pregnancy-related causes, they also lead to microvascular steatosis. Now, NAFLD includes 2 pathologically distinct conditions with different prognosis. One is non-alcoholic fatty liver. The other is, of course, non-alcoholic steatohepatitis. We'll come to that. So, NAFLD is a broader term. It encompasses all the conditions, NAFL, NASH, and NASH-related cirrhosis. So, NAFLD is excessive hepatic fat accumulation, steatosis more than 5% of hepatocytes, and exclusion of secondary causes and alcoholic fatty liver disease. If you look at the histopathology, NAFL is pure steatosis and mild lobular inflammation may be there. But in NASH, you have ballooning degeneration and severe inflammation and early fibrosis. Now, NASH could again be classified into those with early fibrosis and those with more than early fibrosis. Those are F2 or F3 fibrosis. And these two both can gradually lead to cirrhosis, that means F4 fibrosis. NASH patients can directly develop HCC even without developing cirrhosis. So that's important to understand that our second index patient had HCC without developing cirrhosis. Another interesting thing is, could there be different types of NASH? Yes, one type is based on metabolic insult, like we see in all diabetics and all those with metabolic syndrome. The other type is actually genetically predetermined injury, in which PNPLA3 variant is there, and number of other mutations. They cause more prominent injury and inflammation of the liver and higher risk of progression to cirrhosis or hepatocellular carcinoma. This is the mechanism for development of cirrhosis in lean NASH patients again, because they are genetically predetermined for progression. So the progress of disease in these patients is faster. As far as the pathogenesis is concerned, it is believed that it is a multiple hit model as opposed to previously believed 2-hit model. And numerous studies suggest that NASH develops by multiple intra and extracellular events in different cell types, such as hepatocytes, hepatic stellate cells, Kupffer cells, and macrophages. And there is a what is known as inter-organ crosstalk between liver and other tissues, especially the muscles and adipose tissue and intestines. But the key event is insulin resistance. And there is emerging evidence that intestinal microbiota and ammonia may be key players in progression. So NAFLD is currently the most important public health problem worldwide. In India also, there is a huge work going on in NAFLD, and even government is starting several schemes for screening patients at the primary health level. So patients with NAFLD experience elevated rates of cardiovascular events and higher than expected all-cause mortality. So it's not only liver-related mortality. Since they are a part of metabolic syndrome, they actually lead to all the cardiovascular causes of mortality also. So liver fibrosis is the strongest predictor of liver-related complications and mortality. As you can see here, as the fibrosis increases, the mortality rate in these patients due to liver-related cause increases. If you see the natural history of NAFLD, about 12 to 40% of fatty liver patients develop NASH. About 5 to 10% of them start developing fibrosis. And once they develop fibrosis, up to 50% of them will develop cirrhosis. Some of them, about 7 to 10%, will develop hepatocellular carcinoma. And majority of them will need liver transplantation, which if they don't get, mortality is sure. Now, another interesting thing is NAFLD an appropriate term? It is a kind of a negative term, non-alcoholic fatty liver disease. So there was an expert panel consensus in 2020, and it was published in Journal of Hepatology, and they've suggested that now we should rather call this MAFLD. That means metabolic dysfunction associated fatty liver disease. The only difference would be that now amongst the MAFLD, we would be including even alcoholics who are otherwise fitting into criteria of metabolic syndrome, like if they are hypertensive, diabetic, hyperlipidemias, and they are obese and they develop liver disease. It may not be always related to alcohol. Even if they are taking alcohol, they would be classified under MAFLD. So now the principal questions which has been asked, that should you screen these patients? So first, let us see what are the various methods by which we can screen these patients for liver fat and fibrosis. So of course, you can do a simple ultrasonography, you can do a CT scan, you can do MR elastography. Then there are various combination of tests, and they are put into a formula and you get a score. So one of the popular score is a FIB-4 score. Then you have a non-alcoholic fatty liver disease fibrosis score. Then fibrotest, fibrometer, ELF, fibroscan, and RFE. So among these three which I have marked, ultrasound, MR elastography, and fibroscan, are good in the sense that they give you a fat score also. Ultrasonography is more or less arbitrary because they grade fatty liver 1, 2, 3. But MR elastography and fibroscan give you a definite value, which I'll come to and explain it in a better way. Now coming to fibroscan, which is accepted all over the world for estimation of liver fat and fibrosis. This is basically a transient elastography. What is transient elastography? So this is a machine known as a fibroscan machine, and it has a transducer. In fact, 2 transducers come. Less than 70 kg patients are tested with M probe and more than 70 with an XL probe. So what this transducer does is that it produces a shear wave. And if you put over the right hypochondrium over the liver, the shear wave will pass through the liver, and the velocity with which it passes through liver tells you how hard is the liver. So that is the simplest way to explain it. And that is beautifully converted into a formula, and you get a score which is known as a E score, elastography score. So M probe tests from 2.5 to 6.5 centimeter inside liver, and XL up to 7.5 centimeter inside liver. So it is a safe and easily performed in 5 to 10 minutes in any clinic or outpatient setting. Patient needs only 2 to 3 hours fast before the procedure. And this must be interpreted with caution in some clinical settings such as congestive cardiac failure, in obstructive jaundice, in deep jaundice, in significant transaminitis. So those are the writers. You have to be very careful in assessing that. The value may be falsely positive. So when fibroscan came in 2012, it was mainly to assess the liver stiffness or the liver fibrosis. And there were many studies which showed that it showed a good sensitivity to pick up fibrosis. And of course, the specificity of was low. Then the character of CAP, that means the controlled attenuation parameter, was added to fibroscan machine. Basically, the same probe generates an ultrasound wave, and the dampening of ultrasound wave going through the liver tells you how much fatty the liver is. So when we do a fibroscan study in a patient, it allows quantification of decrease of the amplitude of the ultrasonic signals in the liver. And this is how it is done. So firstly, you do with M or XL probe, you get ultrasonic signal, and you have to check whether good elastogram is coming. If good elastogram is coming, then that means your measurement is valid. And then you get two values like this. Like in this patient, you got a CAP value of 216 and elastography score of 6.5 kPa, kilopascals. So anything more than 6 is suggestive of early fibrosis, and any value of more than 225 suggests fatty liver. So based on various investigations, the prevalence of NF-LDF, as you can see in this chart, that if you do a computed tomography, if you do a liver ultrasound, CAP score on FibroScan, NMI, the CAP score on FibroScan has the maximum sensitivity to pick up fat in patients who have got NAFLD. And if you look at the prevalence of advanced fibrosis as compared to fibro test and NAFLD score, the E score on FibroScan again scores much better than other modalities. So what are these FIB4 and NAFS score? These are very simplified scoring systems which are available on Google, and anybody can do it. And in fact, what you have to do is you have to put few values. Like in FIB4, there are 4 values. You have to put the age of the patient, AST level, ALT level, and platelet count. And it gives you a value. If the value is less than 1.45, it has a negative predictive value of more than 90% for advanced fibrosis. Then there is similarly a NAFS, NAFLD fibrosis score, in which apart from these 4 parameters, you have to put in patient's BMI and albumin, and it calculates for you what is the value of NAFS. So this is a very popular score in the UK, NAFS, and FIB4 is actually now getting popular across the globe. So how do we use these scoring systems? I'll be just coming to that. So the question before this is why to screen? Why to screen your diabetic patients for assessing their fat status, and why should you know that they are developing a fatty liver or NAFLD? So this was a very nice study in GUT 2016. It was published. This was about 2,000 patients were examined, and they did with a FibroScan. About 93% had valid CAP and 98% had valid liver stiffness measurement score. And the study showed that the proportion of patients with increased CAP and LSM was 72% and 17%. That means out of 2,000 patients examined, 72% had increased fat in the liver, and about 18% had increased fibrosis in the liver. So this is a huge number. So that only suggests that if you detect these patients in time and you can take preventive measures, you can perhaps halt the progression of fibrosis. That means you may prevent development of cirrhosis and HCC in these patients. Similarly, this was another paper in Journal of Gastroenterology and Hepatology. The data of 557 patients was analyzed, and the prevalence of NAFLD and advanced fibrosis based on transient elastography, that means FibroScan, was 72% and 21% respectively. Again, so more than 70% patients had fatty liver. And this was a wonderful review in Hepatology Communications in 2021. And authors in detail described that why screening patients with diabetes mellitus is important. And although they have not defined a time, they only say that all those who have been diagnosed as diabetes, you have to evaluate them on these parameters. And they are proposing that the algorithm should involve the first step annual fibrosis score, that means FIB4 score, which is very easy, putting the 4 values, the OT, PT, age, and platelets, followed by vibration control transient elastography. For those who have indeterminate or high score, that means if the FIB score is high, more than 1.3, then you do a FibroScan. So they have made things even simpler. So patients at low risk, those who are having FIB score of less than 1.3, and fibrosis score less than 8 can be followed up with the primary care physician with yearly review, while patients who have higher risk, more than 1.3 and more than 8, should be referred to a liver specialized center. So this was a very clear guideline published in 2021. So those are the reasons that why you should screen these patients. Now the question is whom to screen. Now, various societies have recommended differently. ASLD, that means American Association of Study of Liver, they say that in type 2 diabetes, suspect NAFLD and NASH and determine patient's risk of advanced fibrosis by any of these methods. They also recommend the initial blood test and then transient elastography. They say that the increasing number of metabolic diseases, increasing risk of progressive liver disease. So you should look for all the metabolic diseases in a particular patient. Then EASL, European Association of Study of Liver, they recommend NAFLD screening in persons at high CVD risk, including type 2 diabetes or metabolic syndrome. Then ADA, American Diabetic Association, recommends NASH and fibrosis screening recommended in persons with type 2 diabetes or pre-diabetes, both with elevated ALT or fatty liver. Our association, that means APASL, Asia Pacific Association for Study of Liver, it recommends they have already incorporated the term MAFLD, you can see here. So they say that the screening of MAFLD by USG should be considered in at-risk populations such as patients with overweight, obesity, and diabetes and metabolic syndrome. So all diabetics should undergo a ultrasonography to assess the fatty liver or fibrosis. Patients with MAFLD should be assessed for other components of metabolic syndrome and be treated accordingly. And patients with MAFLD should receive advice and support for lifestyle intervention to reduce the risk of events from metabolic and cardiovascular disease and to resolve fatty liver disease. So I'm not going into the treatment of NAFLD today in this talk, but all of you have to understand that primary treatment of NAFLD is a lifestyle modification. It was shown very clearly that if an obese patient loses about 10% of body weight, then his fatty liver score improves tremendously. And even the early fibrosis has been shown to reverse. So it's primarily lifestyle measurement, although there are certain drugs also. So based on this, I think the first line primary management of these patients should be, the first thing should be to rule in or rule out advanced fibrosis by doing a FIB-4 or NAFLD fibrosis score. If FIB-4 is less than 1.3 and NFS is less than 1.455, then it is a low risk. And this patient you should advise them lifestyle modification and exercise and no further assessment and repeat evaluation every year. But if the FIB-4 is higher than 1.3, then this is probably intermediate to high risk. And this patient should be sent to a liver specialist and a LSM, that means a transient elastography, and liver stiffness measurement should be done by doing a fibroscan. And if it is less than 8, then still a low risk, and you can attempt lifestyle modification and exercise more vigorously. There is a role of vitamin E, pioglitazone, and even saroglitazar has been used quite well now in last 4 or 5 years and has shown good results. And you should continue to repeat the evaluation every year. But if liver stiffness measurement is more than 8, then it is intermediate to high risk. Then you should consider a liver biopsy. Or nowadays, we generally avoid liver biopsy because fibroscan scores are also quite reliable. And based on them, you can start treating these patients and follow them with every 6 monthly fibroscan scores. And if you see that the fibrosis score is more than 10 or 12, you should do an endoscopy to rule out esophageal varices and do a triphasic CT scan to rule out hepatocellular carcinoma. Should you screen for other liver disease? We have been talking about NAFLD only, but yes, you should always test HbSAg in these patients. So all diabetics should get their hepatitis B surface antigen tested and should be vaccinated if they are negative. This is a CDC recommendation. And especially this is a must for those having diabetic nephropathy because they may have to undergo dialysis and they will be put to additional risk of acquiring hepatitis B and C. So we don't have any vaccine for hepatitis C, but for at least hepatitis B, they should all be tested and vaccinated in time to prevent this dreadful disease. So I think I would summarize by saying that it is very important to screen patients of diabetes mellitus right from outset for development of fatty liver. There are good ways to do it. There are simple liver tests and scoring systems. You can do a simple ultrasound to get an idea. But if there is a slightest doubt, the best test would be to do a fibroscan to assess liver fibrosis and to take their CAP score That means control attenuation parameter score for assessing their liver fat. And the beauty is that you can do repeated testing. It is a non-invasive test, so you can do it every 6 months or 1 year, and then follow these patients, how they are doing, whether they are doing well on treatment or not. Thank you so much for the patient hearing.
Thank you, Dr. Sanjay Kumar, sir. Sir, I'll just ask a quick question. Sir, is there any role of ammonia testing? Or second is, sir, platelet counts are seen many times low in CLD patients. So, like, how to read them? Like,
yeah. See, first of all, there is no role of ammonia in this particular setting. Ammonia gets raised only when there is a significant liver failure. So, for screening, for it has no role. Secondly,
platelet counts. Yeah.
Platelet counts are very, very important. In fact, those are one of the first get lowered in patients who are developing fibrosis. So that is why all these scoring systems incorporate platelet count in this course. So in fact, we have seen so many patients over the years who have been going to places for thrombocytopenia, and they've been investigated heavily. And even people have done both patient, but not done a fibroscan.
Yeah.
The unfortunate part, on this forum, I think I would like to make everyone aware that it is very important to rule out a chronic liver disease in all patients who are diabetics and having low platelet count.
Okay. Thank you, sir. Dr. Muklesh, sir, are you there, sir? Yeah. Dr. Muklesh? Okay, I think we can go ahead to the next session. Thank you, all the speakers, Dr. Muklesh, Dr. Sunil Kutta, Dr. Satyam Jain, Dr. Sanjay Kumar, for this wonderful session. With this, we are ending session 1.
A special thanks to Dr. Sanjay Kumar. He had an workshop and he is attending live our conference. Thank you very much, sir.
Thank you, Mayur. It's a wonderful conference. I am sure it's going to send good message across the India.
Thank you.
Thank you, Mayur.
With this, I invite Priyamvada, who's Dr. Priyamvada. She is consultant oncologist, Max Hospital, Patparganj, New Delhi. She is in Hormone India, Noida. Dr. Priyamvada Tyagi, you please go ahead with the next session.
Good evening, everybody. So for the next session, we are focusing on diabesity. So the chairpersons for this session are Dr. G.K. Lahoti, Dr. Vishal Baghel, and Dr. V.S. Mishra. The first talk will be by Dr. Arvind Gupta on medical nutrition therapy, low calorie versus fat diets. Can we have his CV, please? So Dr. Arvind Gupta, he is a senior consultant physician and head of Department of Diabetes, Obesity and Metabolic Disorders at Mahavir Jaipuria Rajasthan Hospital in Jaipur. He has fellowships from American College of Endocrinology. He has received multiple awards. He has been chairman RSSCI Rajasthan chapter, has been joint secretary of Indian Society of Hypertension. It is my privilege to invite you, sir, for this session.
Thank you. Thank you, Dr. Priyamvada. Can I share my screen?
Yes, sir.
Sure, sir.
Just a minute. Just a minute. Yeah.
Yes, sir.
My slides are visible?
Yes, sir.
Yes, sir.
Okay. Thank you, Dr. Mayur Agarwal, and all the team of Hormone India for inviting me to this beautiful virtual conference. Dear friends, what I'll be talking today on a very, very important aspects of medical nutritional therapy. And what I'll be giving just a brief about few diets, and it is you to decide the pros and cons of those diets and how to recommend and why to recommend and when to recommend. It is your take. These are my disclosures. Dear friends, we all know about the increasing prevalence of diabetes, and they are all alarming. If you see here, whether it is the urban India or whether it's the rural children and all world obesity, the people with obesity is increasing like anything. And if you see, it is in last 17 years, if you see this data, this is again very much alarming. In 1998, the overweight people were only 8.4%, and they are increased in 2015 by 15.5%. Dear friends, weight gain is associated with increased risk of diabetes, and everybody knows that even a 5% weight increase is associated with a 33% increase in diabetes prevalence. And I think 1.5-fold BMI increase is associated with 90-fold increase of diabetes incidence in women, 40-fold increase in diabetes in men, and moreover, it is ectopic fat, which makes a big difference. Prevalence of abdominal obesity and visceral obesity, especially in Indians. Our own study of Jaipur Heart Study clearly mentioned that whether it's a rural or urban, in the men and women, the incidence is around 41% in urban and around 51% in urban women. I need not to go into those details about the BMI and the overweight, but I think we have to keep little bit lower BMI. And now for Asians, I think the little cutoff is not 25, but it is less than 25. And this again, I don't know, I don't want to detail about in the August audience of this particular Hormone India, that they are metabolic, mechanical, mental, all sorts of side effects and adverse effects are associated with the obesity. It is worth mentioning here that obesity and COVID-19 relationship. Obesity increases the risk of severe COVID-related COVID-19. We have seen in first and second wave, even in third wave, we have seen this association. And what are the contributors and influencers? Probably these are most important thing. The biological and medical causes, we all know about that. The food, beverages, the behavior of the person, the environmental factors which are glued to our youngsters, it is enormous. Maternal and developmental also, we know that it is the maternal nutrition also important as far as the future obesity or diabetes is concerned. Of course, social parameters are again very important, the psychological parameters, and especially we have seen in COVID-19, there's so much of psychological feature. We are in the lockdown, the obesity increases like anything. Of course, the economic, now we are a growing economy of the world. And because of the growing economy of the world, now your purchasing power is more. Hence, you can purchase good food and the calories we are eating too much. Of course, environmental pressures on physical activity is again going to increase the obesity incidence. Dear friends, we know about the metabolically healthy and unhealthy obesity. The only thing is that we have to be very careful while managing the diabetes, seeing the metabolically healthy or unhealthy obesity. And the only thing is that there is a difference in the metabolically healthy obesity. The adipose tissue hyperplasia is of course there, but there is a normal angiogenesis and normal adipogenesis. Hence, there is a small insulin sensitive adipocytes are there. Of course, subcutaneous fat store are more in the metabolically healthy obesity, while in unhealthy obesity, adipocyte hypertrophy is there. Hence, you have more hypoxia, apoptosis, increased adipose tissue stress, increased immune cells stress. So how to manage? I think this is the 5A I want to present in front of you. You have to ask for the permission to discuss the weight to the patient. The counseling is very, very important. Then you have to assess the different scores and different methods by which you can determine the total obesity, as well as you have to give the goal to the person that how much weight they have to reduce. It is 5%, 10%, or 15%. Then according to the assessment of the obesity, you have to advise accordingly. And if patients agree, then you have to assist with your whatever the counseling, the medical or nutrition, and any therapies. And this is what we know, that even the little weight loss is associated with the hypertension and hyperglycemia. And if it is 5 to 10%, it is beneficial in prevention of type 2 diabetes, NAFLD. You have just listened about PCOS and dyslipidemia, while 10 to 15% weight loss is very useful in cardiovascular disease and NASH. Of course, if you are actually very keen for more than 15% of the weight loss, I think you can think of type 2 diabetes remission and reducing the cardiovascular mortality. This is one study which has come from UCLA, and I have just downloaded from the Dainik Bhaskar here. And what this suggests that if you are taking these pizza, burger, and all these things, and if you have a genetic preponderance, I think it is very difficult to reduce that obesity in the later on. So you have to start as early as possible if you want to do the medical nutrition therapy in your patients of diabetes, patients of obesity. And what are the principal components? Probably this is what we have learned, and we are actually advising to our patients that 50 to 60% calories come from carbohydrates. Preferably it is from the complex carbohydrates, and then 10 to 15% from proteins, and 20 to 30% from visible and invisible fats. Now I'll give you some of the different diets which we can advise to our patients depending on their assessment of the obesity and individualized comorbid diseases. Dear friends, we have the low carbohydrate diets, we have low fat diet, low glycemic diet, Mediterranean diet, and very low calorie diet. And if I can compare here, I'll give you a little brief little later. But low carbohydrate actually is defining the characteristics of that 45% or less than 40% of your total calories from carbohydrates. Low fat means you are less than 20% calories from the fat. Low glycemic diet means limiting your glycemic load from those food. And Mediterranean diet is supposed to be one of the best diets, and even our Indian diet is one of the best diets, mimicking the common themes of traditional dietary pattern. And of course, very low calorie diet, what is known as typically ketogenic diet, where we give less than 800 calories per day. So which diet is best? Whether it is Atkins diet, which says that it is high protein, low calorie, low carbohydrate diet, American Heart Association, which says that it is 30% of fat, very high carbohydrate, very low fat, Mediterranean diet, or Fizikova full moon diet. These are the diets which have a different percentage. Of course, from clinician's perspective, the most important thing is the calorie expenditure. We have to be very focused and concentrate on this calorie restriction and calorie expenses. Of course, the optimal rate of weight loss is again very important, which is very strongly recommended to our patients. Most diets have the short-term results. Hence, we have to be very careful while advising. Of course, goal of 5 to 10% weight loss, especially within 6 months, is the most advisable to the patients. So for that, pursuing that weight, this much of diet, vegetable and fruits are very, very important, which contains high fiber, whole grain foods, and water consumption is the most important thing. Now, carbohydrate restricted diet. There is one study which says that very low carbohydrate diet versus high carbohydrate diet has no significant difference in weight loss. Even moderate carbohydrate diet and high protein diet has equal sort of a weight loss. Of course, the low carbohydrate diet is little better. So overall, we want to know about the the total long-term studies, and long-term studies clearly said that low-carb diet may reduce diabetes risk independent of the weight loss. So it is still good to have the low carbohydrate and little bit high protein and high fat. Then it is very important now, it is very popular with the general population, the ketogenic diet. Dear friends, in ketogenic diet, if you see here, the most of the carbs are now converted into the high fat, and the total calories is very less in the ketogenic diet. So, so overall, ketosis from the prolonged fasting is heavily popular, increases the insulin resistance. Hence, while low carbohydrate ketogenic shows a dramatic improvement in the short term, they can increase the morbidity and mortality in the long run. Please see to it that ketogenic diet cannot be on a longer period of time. Of course, high protein diet also have been compared with the standard protein diet, and again, based on systemic review or 24 methodological limitations, high protein diets are associated with decreased body weight, decreased fat mass, decreased triglyceride, increased fat-free mass, increased resting energy expenditure. One of the study, which is very, very, popular study known as preview study, it is a 34-month study, clearly suggests to us regarding the efficacy of the protein diet, the high protein diet also. Of course, the low calorie diet, or this is reduced fat intake, low fat diet is pattern should be less than 20%. It may be less than 25%, less than 30%. So all are almost similar, having the similar metabolic effect. Low glycemic index diets are also now getting very popularity, which decreases the body mass, decreases the total fat mass, and decreases the BMI. So this is also getting popularity now. Paleolithic diet, where we are taking most of the raw fish or the raw meat or the eggs, vegetables, fruits, and nuts. And again, this Paleolithic diet has, studies are done, randomized control trials have been done. It is a short-term follow-up, but long-term follow-up has not been done. What is more important is the Mediterranean diet, which is very, very important and very, efficacious, which reduces your weight, reduces your calories total, and of course, the metabolic effects are enormous. So, now, a word about the commercial weight loss diet. Please see to it, our youngsters should not go into the commercial weight loss diet. This is very, very dangerous diets. Then the calorie restriction, of course, we need calorie restriction. And for that calorie restriction, portion control is very, very important. And I should not go into the details of that. We know that the portion control is very important, and calorie restriction. Our whole, discussion is on the less calories, more proteins, and less carbohydrates. So if you compare the different diets, I think low carbohydrate versus low fat has equal effect almost. Low calorie vegetarian diet and low calorie Mediterranean diet is better as compared to other things. Of course, vegan diet may increase weight loss as compared to non-vegetarian diets, and some people have already studied and presented and published this thing. Little bit word about the intermittent fasting. Again, this is getting more molecular studies are being for the intermittent fasting. And of course, for those small trials, this is okay as far as the intermittent fasting is concerned. The only thing warning here is the dietary supplements. Please do not have the dietary supplements. Here, the diet supplements sold for weight loss, muscle building, and energy were associated with almost 3 times the risk of severe medical outcomes as compared to vitamins. Please ask your youngsters if they are going for gym and taking commercial supplement. This is not a good thing. So, dear friends, we know about the different components, and we have to design our medical nutrition therapy in such a way that it should be balanced. It should be, the carbohydrate should be less, high protein, fat should be, good quality of fat should be there, cooking practices should be good. And this is how we actually design our medical nutrition therapy in this form. The protein should be increased. The fat should be in the form of the good PUFA and MUFA ratio should be there. And I think omega-3 fatty acids is still important. Two important things: refined oils and refined fats are not good because they are the good source of oxygen-free radicals and more source of trans fatty acids. Again, frying, especially the reheat of oil and reuse of the oil. For our ladies, most of the time, what they do, they actually use the reheat and reuse of oil, which actually ultimately converts to volatile decomposition products and acrolein chemicals developed into the reheat of your, and this is very irritating to your colon and sometimes may cause colon cancer. So take home message: calorie restriction is the most important if you have having the medical nutrition therapy for obesity. The composition of macronutrients in such a way that it should lead to weight loss, and of course micronutrients should be added if the people are feeling the deficiencies. The weight loss is not difficult in the short term, dear friends. You have to counsel your patients for a long-term maintenance of that weight loss. Healthy, balanced diet is ideal for health benefits, irrespective of whether it causes weight loss or not. Weight reduction must focus on the whole lifestyle and not solely on the diet. So this is my message to all of you for today's medical nutritional therapy. Weight loss diets are fad diets. The whole problem with the world is that fools and fanatics are so certain of themselves, yet wiser people so full of diets. That is the Bernard Russell told us. So prevention mantra: eat less, eat on time, eat right, work more, sleep well, and on time, and smile. This is the mantra given by Dr. Shashank Joshi, and I adopt to my whole patient. Thank you very much.
Thank you, Dr. Arvind Gupta, sir, for this wonderful talk. And as you rightly said, that eating on time, eating well, sleeping on time, and always doing it with a smile is the key to a happy and healthy life. So thank you so much, sir, for your words. So moving on from lifestyle intervention to the pharmacotherapy in obesity, I would like to invite Dr. Sanjeev Gulati, sir, for the next talk on pharmacotherapy for obesity. Sir is an internal medicine specialist practicing at Bhopal. He has fellowship in diabetes from CNC Vellore. He's a keen academician and is a part of many national and regional conferences on diabetes and obesity. He has multiple publications and has he has a chapter in RSSDI. Dr. Sanjeev Gulati, sir, please welcome.
Thank you, Dr. Priyamvada, for kind words of introduction. Thank you, Dr. Mayur and Team Hormone India. Hello, Dr. Arvind Gupta, sir. We had a wonderful talk about the medical nutrition therapy in the management of obesity. Now we move on to the next part of this diabetes session, that is pharmacotherapy for the management of obesity. So this is again to reiterate the prevalence of obesity is rising. 650 million people as of now are living with obesity across the globe, and we fall into the category of that part of the world which has a prevalence of approximately 10 to 20% people living with obesity, and that's too high. And this is a forecast about the overweight and obesity prevalence in India. Number of people living with, women living with obesity in our country was 4.4% in 2010. It's going to threefold by 2040. That is 14% women and 9.5%, that approximately 10% men would be suffering from obesity. And they are all going to have all these complications of obesity. This slide has already been shown by Dr. Arvind Gupta, sir. Metabolic, mechanical, mental health, anxiety, depression, asthma, NAFLD. We have already listened about NAFLD. Commonest cause of chronic liver disease now across the globe is becoming NAFLD. So cardiovascular complication, chronic back pain, type 2 diabetes, of course. So these are the complications associated with obesity, not to repeat again. But there is a progressive weight loss as a dose-dependent, incremental and tissue-dependent biological effect. Even a 5% weight loss in somebody who is trying to lose weight by either lifestyle intervention or by pharmacotherapy can lead to improvement in the liver sensitivity for the patients of even type 2 diabetes, reduction in the liver fat content, that is triglyceride, improvement in the beta cell function, muscle insulin sensitivity, abdominal adipose tissue may come down, and adipose tissue insulin sensitivity will come down. So these all factors are going to increase with further 5% weight loss. Majority of these pathophysiological mechanisms which ultimately lead to the cardiovascular or many other complications of obesity may show an incremental benefit with further 5% weight loss. So 10% weight loss may lead to further reduction in the hepatic fat content. We have already listened to Dr. Sanjay Kumar. This is a known fact that 10% weight loss can lead to reversal of early NASH fibrosis in patients of NAFLD. Beta cell function improvement may further go up. Insulin sensitivity in the skeletal muscle may further go up. Abdominal adipose tissue may further come down. Adipose tissue insulin sensitivity may remain same with the further weight loss. But most important, one of the most important feature which may be seen with the further 5% or 6% weight loss is gene expression in subcutaneous adipose tissue. Probably this is one feature which is associated with long-term epigenetic changes leading to higher prevalence of future generation to come about the obesity and type 2 diabetes also. And if somebody is able to lose further 5% weight, approximately more than 15% weight loss, liver triglyceride fat content will show further improvement, beta cell function, insulin sensitivity, gene expression in the subcutaneous tissue, abdominal adipose tissue will show further improvement. Another improvement which is very remarkable here with the 15% weight loss is inflammatory markers, which are the surrogate markers for the many metabolic diseases like chronic kidney disease in type 2 diabetes, NAFLD, cardiovascular diseases, many malignancies. This may also come down with the more than 15% weight loss. So this is an incremental beneficial impact of the weight loss on the people of obesity. With each percentage of weight loss, somebody is going to be benefited in some way or other. Then why do we need pharmacotherapy at all? We have so many fashion diet. We have low calorie diet, very low calorie diet, carbohydrate restricted diet, Atkins diet. So why do we need pharmacotherapy at all? Because obesity is not caused by a lack of willpower. It is not only always the hedonic factors which lead to overweight or obesity. It's not always overeating which may lead to obesity. It's a chronic disease and it has to be treated like a chronic disease. Body weight is generally influenced by the genetic factors which are generally determining the set point for BMI. So every individual will have a set point for BMI, whether that individual is a lean individual or obese individual. And somebody who is trying to lose weight by the lifestyle measures or intensive behavioral therapy, this weight loss would be countered by the physiological adaptations which are homeostatically regulated and which facilitate the regain of whatever weight that person has lost with the lifestyle interventions. So this weight loss is again countered by the homeostatic mechanism by two main mechanisms. There is suppression of appetite in the long run, and there is increased reduction in the energy expenditure, which is more than the expected for amount of weight person has lost. It is not about the how rapidly person is losing weight. Amount of weight loss is the reduction is energy expenditure is more than the expected for the weight loss person has lost. And this weight loss by lifestyle intervention not only lead to suppression of appetite, but also reduction in the both resting and non-resting energy expenditure. This is how we can here explain that how there is a genetically determined set point for BMI for every individual. This is a study from approximately 9 or 10 Cameroon individuals who were made to overeat, or they were adopting overfeeding practices for a period of approximately 4 to 6 months. And they put on a lot of body fat and body weight mass. But when they returned to their original diet, almost all of them, they returned to their original weight within 2 years' time, and original body fat mass also within 2 years' time. So it is not only the obese individuals, they have a set point for obesity, it is for the lean individuals also. We have seen many a times in our clinic that people come to us that we are not able to put on weight, especially adolescent males and females both. and they are not able to put on weight despite of the fact they are eating excessively. It is because of the set point for BMI for them also. If they try to overeat and put on weight, the body fat mass increases, and that lead to increase in the leptin hormone levels that ultimately suppresses the appetite. So there is a set point for BMI for every individual, which is by and large determined genetically. That is why it is very difficult to maintain whatever weight somebody has lost with the lifestyle intervention in the long run. And that is the time when we need pharmacotherapy intervention for maintenance of lost weight. So this is the meta-analysis of almost 80 studies involving more than 26,000 people who were tried on different methods for the weight loss. This is a slightly old study when the newer drugs like GLP-1 analogs were not available and sibutramine was still in use. This is a weight loss with advice only, so free advices do not cause weight loss. So this is a significant weight loss with the very low energy diet. We can see here significant weight loss over the period of 6 months. But what we see here is the majority of the weight is regained over the period of long run. So those people seen here, those people who were put on the pharmacotherapy in the form of early state or sibutramine, they maintain whatever weight they have lost with the lifestyle intervention plus pharmacotherapy. So if somebody wants to maintain the weight loss for a longer period of time and rapidly lose weight, it is the pharmacotherapy plus lifestyle intervention which should be adopted, because whatever weight somebody loses with the lifestyle intervention alone, majority of the people, they regain whatever weight they have lost in 2 to 5 years' time. So this is again a slide to show the strong genetic predisposition to obesity. This is a study of twins who were either brought up in the same families or two different families. That means reared together or apart. There was a very strong correlation for body weight and BMI, whether obese, normal weight, or thin or lean twins. There was a very strong correlation between the monozygotic twins. Either they were raised together or they were raised in the different families. So this shows that there is a very strong genetic predisposition to the body weight and to the BMI. So homeostatic regulation of body weight occurs in hypothalamus based on the inputs received about the short-term food intake and long-term energy stores. The arcuate nucleus of hypothalamus, there are two sets of interconnected neurons which are opposing each other's action about the energy balance. So those neurons expressing NPY, that is neuropeptide Y, and agouti-related peptide, they stimulate food intake, while those expressing pro-opiomelanocortin, these suppress the appetite. The long-term signaling from the periphery to the brain is received either from the bloodstream or by the vagus nerve via the leptin hormone and insulin. So these two hormones, they regulate the long-term energy stores of the body. So whatever the treatment options we have available for management of obesity? If we try lifestyle modification only, we can lose up to 3 to 8% of the weight. But if we try a combination of pharmacotherapy plus lifestyle modification, the weight loss could be achieved up to 16%. And you can see here, this weight loss is even more than what the person can achieve with the gastric band intervention. So this approach could be probably the best approach in patients who are requiring weight loss before somebody is actually a candidate for the bariatric surgery. So what are the principles of medication for management of obesity? Medicines, they don't work by themselves. They reinforce somebody's intention to lose weight and reduce the food intake. Catch the low-hanging fruit first. That those people who are taking some medicine which are causing weight gain, like diabetic people who are taking pioglitazone or sulfonylureas, if you have an option, either stop those drugs first and put them on either SGLT2 inhibitors or GLP-1 analogs, because these drugs can cause weight loss, which are associated with some people are taking antidepressant medicine, some people are taking migraine prophylaxis, anti-epileptics are known to cause weight gain. So you can discuss with their psychiatrist or neurophysicians if they can be switched over to either weight neutral medicines, that would be a better choice. So catch the low hanging fruit first before putting them on any pharmacotherapy for the management of obesity. So these are biological adjunct to behavioral therapy. Not all medicine will work in all patients. Evaluate the efficacy in 12 to 16 weeks. If weight loss is less than 5%, you can either discontinue that drug or change or add another drug to that therapy. In some point of the time, if the weight loss plateaus, this may not be a sign of loss of efficacy of that particular drug. Maintenance of weight loss is a sign of success. So this is a common practice that patient loses some weight and that weight loss is not further incremental. So there is no further weight loss after 5 or 7% weight loss. The people lose hope and they stop all the efforts, including the pharmacotherapy. This should be properly explained to the patient because maintenance of lost weight is very, very important. And maintenance of lost weight is a success of therapy, not the failure of therapy. So there is no ideal medication. Every medication has a different safety and tolerability profile. Pharmacotherapy, when we come to the individual drugs, Orlistat is the only drug approved by our country for the management of obesity in non-diabetic individuals. Drugs approved by FDA and European Medical Agency are the Orlistat, glucopion, naltrexone combination, phentermine, topiramate combination, liraglutide in the doses of 3 milligram, and semaglutide, latest drug approved for the management of obesity, is 2.4 milligram weekly injectable therapy. I don't know why our pharma people or our government agencies are not taking obesity as a serious disease. That is why we are not getting these drugs, liraglutide 3 milligram, semaglutide 2.4 milligram early in our country. Because I have heard about semaglutide, there was a shortage of this drug in countries like Australia. So why our people are not bringing it to India? This is not known to me. Only drug approved is Orlistat, which is not very potent drug to lose weight. Though it's a very safe drug, it's a pancreatic lipase inhibitor, blocks the absorption of 30% of the ingested fat. The only safety concern are loss of fat-soluble vitamins, which can be handled with supplementation of some multivitamin tablets, unpleasant steatorrhea, which can be done with the very proper counseling of the patient. Maximum weight loss is 5 to 7%. It is also available as an OTC product in some countries like European Union and US at a lower doses of 60 milligram, should be given with meal to be effective. Another drug is Contrav, which is available in European Union and US also. Glucopion is a mild dopamine and norepinephrine reuptake inhibitor as a single agent approved for the treatment of depression and smoking cessation. So if your patient is obese and is suffering from depression and is habitual smoker, then the first drug of choice could probably be glucopion and naltrexone combination. But unfortunately, this is not available in our country. Probably off the level, some people are using available online by the India Mart, but not the label indication in our country. Naltrexone blocks the autoinhibitory feedback that is associated with decline in weight loss due to lifestyle measures. This combination may also regulate mesolimbic system, which is associated with the hedonic factor contributing to the obesity, like smell of the food, taste of the food. So these are the hedonic factor which also contribute to the weight gain in people who are genetically determined to put on weight. Phentermine topiramate combination. Phentermine is a sympathomimetic agent which affects both food intake and increases the energy expenditure. Weight loss mechanism with topiramate is not completely understood, might be associated with decreasing appetite and feeling of fullness after meal, which lasts a little longer than usual. So if some of your patient is taking sodium valproic acid or valproate for the epilepsy, you can request or for the migraine prophylaxis for that matter, you can request the treating physician or neurophysician to switch that patient to topiramate for the migraine prophylaxis. It's a good drug for the migraine prophylaxis also. So that this is probably, if doesn't cause any weight, this would be a weight neutral therapy. So though the sodium valproate causes significant weight gain in some of the individuals. So this is a low hanging fruit. GLP-1 analog, this is the most promising class of drug for the weight loss. GLP-1 analog, they actually affect the set point for BMI by their effect on the hypothalamus. Additional effects are delaying of the gastric emptying and some effect on through the peripheral mechanisms like insulin sensitivity also goes up, insulin secretion also goes up, glucagon secretion goes down.
This drug is approved by both US FDA and European Medical Agency for the management of obesity in the doses of 3 milligram daily. Semaglutide approved by US FDA in the doses of 2.4 milligram.
Dr. Sanjeev will have 1 minute more. Yeah.
Okay, weekly injectable therapy. Latest drug is tirzepatide action on both GIP and GLP-1. Weight loss is up to 20% in the clinical trial, approved for the management of diabetes recently in US. This is the trial for the obesity management for semaglutide. This leads to up to 17 weight loss, and weight loss is sustained for a period of up to 68 weeks. In those people who were replaced with placebo, they gained weight in this step 4 trial for the semaglutide. So I will not go into detail of this drug. CagriSema is the latest drug in the pipeline. Novo Nordisk has recently concluded the phase 2 clinical trial for this drug. Significant A1C reduction 2.2% and weight loss up to 17% can be seen with this drug if at all this comes to the market. So this is the algorithm for the management of obesity. Those people BMI more than 30 and BMI more than 27 with comorbidities, they can be put on pharmacotherapy apart from the lifestyle measures. First drug of choice for those people who are having diabetes, pre-diabetes, hypertension, OSA is liraglutide. If they do not tolerate and if this fails, then naltrexone glucagon combination would be the second drug. For those people who are having food craving, depression, or excessive smoking, then naltrexone glucagon combination would be the first drug. But in our country, this could be liraglutide again, though it is not approved for the management of obesity. If this therapy fails in 3 months, then that means less than 5% weight loss, then you can add second drug or replace it by the another drug. So these are the take-home messages. Obesity is a chronic disease. Majority of the patient in intensive behavioral therapy regain pre-therapy weight because of the genetic set point for the obesity, leads to reduction in both resting and non-resting energy expenditure. Pharmacotherapy should be considered in all appropriate patients at early stage to achieve optimum result. Most drugs approved by US FDA are studied for a chronic use and are safe in rightly selected patients. GLP-1 analogs, they offer a new optimism for the management of obesity. Now a twin creatine also will be available in few years to come. Thank you very much for the patient listening.
Thank you, sir.
Thank you, Dr. Sanjeev Bulaki, sir, for this talk. So obesity is a lifestyle disease. Obesity management starts with lifestyle intervention in the form of exercise and diet, followed by pharmacotherapy. But what if you are hereditary predisposed to develop obesity and diabetes? So for the next talk on genetics of obesity, I would like to invite Dr. Virendra Singh, and I want Dr. Ajay Shukla, sir, to kindly introduce the speaker.
Thank you, Dr. Priyamvada. So Dr. Virendra Singh is very renowned physician, not only in Uttar Pradesh, is known all over India. He's MD Medicine, Chairman API UP Chapter, Director GSSM Cardiovascular Center in Ayodhya. He's Vice President UP Diabetes Association. He was in 2013 to 2015, and he has various fellowships in his account. So with this, I invite Dr. Virendra Singh, sir, to talk on eating, exercise, and 50 genes role of IF in management of diabetes.
So, friends, should I share my screen?
Yeah. Yes, sir, please.
Allow me to share the screen.
Tech team, please allow. So you can share, sir. It's allowed. Center of the screen, bottom share screen option. Yes, sir, it's coming.
Can you see my screen?
Yes, sir. Okay, sir. Perfect.
Okay, friends. Good evening. Thank you, Dr. Ajay Shukla, for nice introduction. So, friends, today we are going to discuss the genetic aspect of obesity and type 2 diabetes.
Sir, you're not audible.
So friends, with many diet and exercise programs failing to produce significant results, the question becomes, were we designed for obesity and diabetes? So friends, James Neal in 1962 put the thrifty gene hypothesis. He said that genes that predispose us to obesity were advantageous in early human history when starvation was an issue. Early humans went through cycles of feast and famine, and thus more efficient at food storage and utilization, were more likely to survive and reproduce during famine. So during this feast-famine cycle, during the period of feast, there was the successful hunt, and there was plenty of glucose and fat, and there was less inactivity. At that time, there was thrifty storage. They replenished skeletal muscle glucose and triglycerides, and there were more efficient storage of excess glucose and triglycerides in adipose tissues. And when in famine and activity phase, the hunters, they used to they had to travel long distances to find some hunt, and there was a lot of activity, and they had to fast for many days. So there was essentially decrease in glycogen and triglyceride stores, and so this was a cycle. In periods of feast, there was storage of food, and in periods of famine and inactivity, there was depleting these stores. So physical activity and food procurement, they were interrelated, and they used to give feast famine cycle and physical activity and rest cycle. So these two were cyclic of a metabolic process. There was fuel depots, metabolic proteins, blood insulins, insulin sensitivity. This all led to gene and genotype selection, leading to thrifty genes and genotype selected that used to conserve muscle glycogen and that used to replenish muscle glycogen. So that way they used to survive the famine period. But in modern days, what has happened? We have plenty of food and least physical activity. So we have the feast stage, and our genes, they have been tuned for storing these items. So that is why we have high storage of excess glucose and triglycerides in adipose tissues. Little goes to skeletal muscles, and there is no famine and inactivity cycle. So there is no cycling of metabolic process. Fuel gets shunted into an even greater and unhealthy storage, precipitating the metabolic syndromes, constantly low skeletal muscle beta oxidation enzymes, the relatively constant high insulin and insulin resistance. So fast famine cycle, famine and physical activity cycle used to evolutionary program biochemical cycles. There was food abundance and physical inactivity. This eliminated evolutionary programming, and metabolic deregulations, obesity and type 2 were the results. Friends, diabetes is not just one disease. There are many genes involved in this, and that is why it is the thrifty genes. What is the missing? In old theory, there have the genes or we don't have. The new theory is it is the function, the degree of expression of the gene matters. Epigenetics, this manipulates how the gene functions, whether it's turned on or off, and the degree of transcription. So genome is hardware and epigenome is a software. They are more susceptible to change while fetus is in development. Genetic imprinting can be passed on for a couple of generations and short-term adaptations to the environment. So epigenome adapts to the unpredicted environment when in utero. Mother experiences famine, epigenome overreacts and upregulates genes for food storage and utilization. So in nowadays, there is mismatch. When predicted environment does not equal actual environment, so obesity develops. So obesity is a polygenic problem. It is very complex, not a single gene issue. It is not only matters whether one has a combination of genes, but how they function. Eaton et al. In 1988 put it best when they said that we have Stone Age genes and Space Age circumstances. So physical activity and food were likely intricately linked from the start of mankind, and it's a mistake to consider one and not the other. So friends, eating a large amount of calories alone is not the cause of the current epidemic of obesity and type 2 diabetes. For that, lumberjacks who used manual tools and undertook rigorous physical labor, they ate 4,500 to 8,000 kilocalories per day and yet had a BMI of only 25.5. Both very low calorie diets and starvation combined with physical activity deficiency may also contribute to the induction of insulin resistance. So the developed world is in the midst of an obesity epidemic, implying a positive caloric imbalance due to insufficient physical activity. It has been seen that short-term fasting, just 15 to 40 hours, or a single exercise bout can initiate a common adaptive response in skeletal muscles to increase the expression of a subset of metabolic genes to minimize glucose utilization in a peripheral tissue. Reintroduction of physical activity can restore metabolic flexibility to keep the cycle moving, thereby potentially reversing insulin resistance. So changes that occur in body on fasting, they increase levels of growth hormones, which benefits fat loss and muscle gain. They improve insulin sensitivity. It initiates cellular repair processes like autophagy, that is to remove dysfunctional proteins inside cells. The gene expression, that is changes in the function of genes related to longevity, that again occurs with the fasting. Now, the recent concept, that is intermittent fasting or intermittent energy restriction, is a diet regimen that cycles between brief periods of fasting and periods of unrestricted eating. Its roots are derived from traditional fasting, a universal ritual used for health or spiritual benefit. We all know that we all follow many fastings, religious fastings. So intermittent fasting is an eating pattern that cycles between periods of fasting and eating. It does not specify which foods you should eat, but rather when should you eat. Common intermittent fasting methods, they involve daily 16-hour fast or fasting for 24 hours, twice per week. Other methods of intermittent fasting, they are 16/8 method, that is eating for 8 hours and fasting for 16, having an open eating window for 12 p.m. to 8 p.m. Another one is spontaneous meal skipping. The basic concept is to skip meals whenever convenient. Other one is the 5-2 method, that is our diet consists of regularly eating 5 days out of the week and fasting for 2 days. The other one is on and off is fasting. This schedule consists of eating normally one day and then eating very few calories or not at all the next day. OMAD diets consist of fasting largely for 23 hours of the day. So intermittent fasting is effective at reducing body weight, decreasing fasting glucose, decreasing fasting insulin, reducing insulin resistance, decreasing levels of leptin, and increasing levels of adiponectin. Some studies have found that patients were able to reverse their need for insulin therapy during therapeutic intermittent fasting protocols with supervision by their physician. So this was the first in-human study published in 1985, where the effects of intermittent fasting and refeeding on insulin action in healthy ones was studied. This was intermittent fasting every second day for 20 hours for 15 days. And it was found that insulin-mediated whole body glucose uptake rates increased. Insulin-induced inhibition of adipose tissue lipolysis was more prominent, and plasma adiponectin was increased compared with the basal levels. Again, this study was published in 2014, and this was religious fasting, that is Islamic fasting, Roja or Ramadan. And here it was a meta-analysis of 35 studies, which found that fasting during Ramadan resulted in significant weight loss. However, most of the weight loss was regained within a few weeks, and only a slight decrease in body weight was observed in the following weeks after Ramadan compared with that at the beginning of Ramadan. This again is a study for Ramadan fasting. And the primary finding of this meta-analysis was that after Ramadan fasting, low density lipoproteins and fasting blood glucose were decreased in both groups. Again, in 2015, the same Ramadan study, there was HbA1c improved significantly. Despite similar body weight, there was reduction in body fat mass. So in 2018, this study published in JAMA, effects of intermittent compared with continuous energy restricted diet on glycemic control in patients with type 2 diabetes. Friends, it is difficult to practice continuous energy restricted diet because if you advise, most of the patients, they are not going to follow it. Whereas intermittent fasting is easy to follow. And the results demonstrated that a 2-day intermittent energy restriction diet is comparable to a continuous energy restriction diet for improvements in glycemic control. Again, in 2018, the therapeutic use of intermittent fasting for people with type 2 diabetes was assessed on insulin. And this case, it was a scheduled 24-hour fast consuming only dinner 3 times a week. This case series documents 3 patients referred to the Intensive Dietary Management Clinic in Toronto, Canada, for insulin-dependent type 2 diabetes. Again, this very recent study published in 2020, this shows that biochemical changes during fasting are characterized by a glucose to ketone switch, leading to a rise of ketones, advantageous use for brain energy with consequent improving cognition. Ketone reduced appetite and help maintain effective fasting. Again, these 3 cases, as you can see here, the HbA1c reduction was very significant in all the three patients. This study published in 2020, again, intermittent fasting as part of the management for type 2 diabetes. Studies derived from murine models suggest that intermittent restricted fasting is associated with improvements in beta cell function and insulin resistance. 2 main mechanisms are the autophagy lysosome pathway and an increase in neurogenin 3. The more consistent results are reductions in body weight, visceral fat, and glucose and insulin levels. This where the therapeutic use of intermittent fasting and ketogenic diet as an alternative treatment for type 2 diabetes. In this, a 57-year-old woman with a 15-year history of type 2 diabetes with HbA1c of 9.3 was put under intermittent fasting and ketogenic diet. And you will see that in just 4 months, the HbA1c, within 4 months of transition to ketogenic diet with intermittent fasting, the patient could achieve HbA1c of 6.4 from 9.3. So this was very significant reduction in HbA1c.
Sir, we'll have last 2 minutes.
Okay. Intermittent fasting is their role in treatment of diabetes. A review of literature and guides for primary care. The majority of the available research demonstrates that intermittent fasting is effective at reducing body weight and decreasing fasting glucose. The cardiometabolic benefits, all forms of fasting reviewed here, alternate day fasting with 5-2 and time restricted eating produce mild to moderate weight loss and consistent reduction in energy intake. Again, this is a user-friendly method for type 2 diabetes. Studies on IF have demonstrated that efficacy in glycemic control, reducing visceral fat, controlling inflammatory mediators and markers such as CRP and IL-6. So to summarize, Intermittent energy restriction is efficacious in managing prediabetes and diabetes, with remarkable improvements in the metabolic and cardiovascular biomarkers. A lot more evidence is needed in order to incorporate intermittent fasting into established guidelines for the management of diabetes. Thank you, gentlemen.
Thank you, sir. So, Dr. Priyamvada. Okay, so with this, we are moving ahead with last talk. So we'd like to invite Dr. Raka Sehore to speak on metabolically healthy obesity. Dr. Raka Sehore is MBBS MD, is Director of Lifeline Madhumit Diabetes Hospital, Raipur, and is President Global Diabetic Forum. And with this, I'd like to invite you, sir, to enlighten us.
Can I have hearing rights, please? Okay, my slides are visible.
Yes.
Yes, sir.
Yeah. So without wasting time, we are in the last part of the session, and I know the pressure of that background green room that Mayur and team has so much pressure that they have to commit all the things with a well-planned manner. And at the outset, I'm thankful to Mayur and Hormone India team. My topic is very, sorry, it's not changing. Yes.
We are changing. We have now two poets in this room, Dr. Ajay and Dr. Raka.
So everybody has to leave. So some people are crowd gatherer and we are crowd disperser. Okay. Anyway, my topic is a very nice topic. I requested for this topic because there is many common things between obesity and everywhere this acronym obesity is in this conference, whether it's sarcopenic obesity, whether it's metabolic healthy obesity, unhealthy obesity, and whatever. So whether we are different, whether we are on the same boat, and why we need to talk so much on obesity. So how much we differ in this definition of metabolic healthy obesity? Yes. Introduction. That according to WHO, obesity is defined as abnormal or excessive fat accumulation that presents a risk to health. And obesity contributes to reducing life expectancy throughout the globe because of so many reasons. And I'll show you the reasons. And well enough, everybody knows that. So why slides are not changing smoothly? These are the reasons. And these slides have been repeatedly presented in this forum, and I'll not go, but I'll say that the adipose tissue is regarded as a big endocrine organ nowadays. And behind this hypothesis, there is so many things. We have given so much calories, so much things to this adipose tissue throughout the ages after being Adi Manav to now being robot Manav. We have done maximum benefit to these adipose tissues because of our lifestyle and everything. And that's why we are in the bombarded era of type 2 diabetes and FLD, hypertension, dyslipidemia, and CVD risk factors. But there is a big but, that whether our obesity can be healthy obesity or whether all obesity can be classified as the bad obesity. This heterogeneity character of obesity is very nice, and that will give insight to future endeavors of our research. When I was Googling and researching on the papers, there are metabolic healthy obesity. The recent papers for Gordon and Smith, which has fact and fantasy, is very wonderful defined, and everybody should read that publication in JCI. And it says that although obesity is typically associated with metabolic dysfunction and cardiometabolic diseases, some people with obesity are protected from many adverse metabolic effects of this excess body fat. And this is known as metabolic healthy obesity. And we need to change the concept that every obese patient is a potential candidate. But there are changes, and this phase of transition happens because of set point. And these set points need to be overwhelmed and properly physically, scientifically taken by all of us. Why my slides are not changing? It's taking a time. Concept of metabolic healthy obesity, it has been given in 1950, long way back, by Gene Beck in his observations that with obesity having different predisposition to diabetes, every obese patient is not going to be diabetic. Why? And this concept of MHO may serve as model to better understand the mechanisms linking to obesity and to cardiometabolic disorders. Metabolically healthy obesity has been frequently defined by absence of any metabolic disorder or CV disease, including type 2 diabetes, dyslipidemia, hypertension, and atherosclerotic cardiovascular disease in person with defined obesity by BMI index. And these are the different orchestra going inside the body in cardiorespiratory fitness, in cardiovascular function, in multi-organ insulin resistance, other features like metabolic syndrome components. And these orchestra is going on, and that decide whether a patient will remain MHO or MU. MU is metabolically unhealthy obesity, and MHO is metabolically healthy obesity. I am not going to waste too much time, but I'll say this is the definition and proposed criteria for defining metabolically healthy obesity. And this basic criteria is that absence of any of the diagnosis or therapy of cardiometabolic illness or disease, means absence of pre-diabetes, type 2 diabetes, hypertension, dyslipidemia, NFLD, CKD, or CVD, or treatment with blood pressure, lipid, or diabetes medication in presence of obesity. So healthy cardiometabolic profile, which is given here, including OGTT, blood pressure, HDLC, fasting triglyceride, every criteria. And with advanced criteria, you have intrahepatic lipid content less than 5% of liver volume. Already diagnosed with NFLD, then it's less than 5% of hepatocytes with intracellular TG by histology. Insulin sensitivity, if you go by euglycemic clamp studies, then these are the novel criteria. You can have a fancy criteria of these things if you have a lab augmented values for that, or patient is able to go for such kind of screening. Otherwise, the clinical criteria are well sufficing that. What is the prevalence of MHO? It has been shown to 4.2, 13.6, a large spectrum, a vague spectrum is have been studied in Chinese adult population. And recent meta-analysis of 12 cohort and 7 intervention studies have found that there is 35% prevalence, which is very high. That's why we say in our OPD also, many of the time when obese patients comes to us, we have a high index of suspicion. In spite of that, we are not getting every obese patient to be a diabetic patient. And this is the clue for our future. We need to justify our research work from this point of view, that every obese patient can't be a potential candidate for these kind of disease. And why? If they can do so with such obese backup, then why? What are the protective factors? So biological mechanisms. Stephen et al. Linked high liver fat content and predominantly abdominal, including visceral obesity, to metabolically unhealthy obesity, where there is greater insulin sensitivity, better insulin secretion, cardiorespiratory fitness remains good, and lower body subcutaneous fat mass was measured, which is associated with healthy type of obesity. And this slide has just shown there is a two sumos. One is metabolically unhealthy, and other is a metabolically healthy obese guy. So this slide have been repeatedly shown in many of the conferences, and I'll again say that BMI is not at all the criteria. Your lower liver fat content, your high amount of leg fat, your high cardiorespiratory fitness and reserve, insulin sensitivity, and normal inflammatory markers are the main criteria behind that. So transitions happen. Every of our patient, we are human beings. We have eating habits. We have sleeping habits. We are influenced by our social factors. We are influenced by our own factors, emotions and all. Sleep, everything is touching us in view of that. That's why we are changing. We are sometimes unhealthy obese, sometimes healthy obese, and these phases of transition have shown that meta-analysis of 12 studies, including 5,900 individuals with 3 to 10 year follow-up, demonstrated that almost half of the participants who have been classified as amateur developed at least one metabolic abnormality in their life. And these are the criteria where your adipose tissue can expand from a healthy adipose tissue to unhealthy adipose tissue, or to whether it can become adipose tissue hyperplasia, then normal angiogenesis, normal adipogenesis, small insulin sensitivity adipocytes, and this positive thing, सकारात्मक और नकारात्मक दो तरीके से इनमें चेंज हो सकते हैं. और आपने अपने एडिपोज टिश्यू को कैसे जगह पे रखा है, व्हाट इज द रियरिंग ऑफ योर एडिपोज टिश्यू, आपने सत्संग में रखा है कि कुसंग में रखा है, इसके साथ ही सब कुछ हो जाता है. वही मेटाबॉलिकली ओबीस पेशेंट, नाउ ही हैज डेवलप्ड बॉडी, well shaped body, and he has given a proper sanskar, and this sanskar and legacy effect happens and every time in our life. This legacy is continued. This is the legacy which is taken for generations to generations. That's why we behave like different. So recent meta-analysis from UK containing 2 lakh patients data has shown that our men population, physically, gender-wise, are more prone to transitions from MHO to MUO because of so many reasons, because of our smoking habits, because of our day-to-day alcohol and other things, stress level. So obesity significantly increases the risk of developing type 2 diabetes, and MHO should be considered as a benign condition because the meta-analysis of prospective studies have shown that MHO is associated with significantly lower incidence of type 2. And this benign subphenotype of obesity has been challenged by data from large epidemiological studies that even these MHO patients are at higher risk of ASCVD in future if not properly carried or taken care by their physicians, or if patient has not a proper submittance to regarding his or her conditions clinically. This has been shown in MHL, metabolically healthy lean, metabolically healthy obese, and metabolically unhealthy obese patients, that all CV and cardiac events rates are very high when we talk about unhealthy obese patients when compared to metabolically healthy lean patients. So Indian obesity paradox, we are talking in our Indian criteria. So many Indian patients fit into the category of metabolically obese, but maybe they are in normal weight individual, because we know that we are Indian thin fat obese Indians. Despite many having lean BMI, an adult Indian has more chances of having abdominal obesity. The body fat percentage of an Indian is significantly higher than a Western counterpart with similar BMI and blood glucose level. That's why in Indian text, we should be very cautious regarding our weight gain and visceral obesity. This is the intra-abdominal fat adipose tissue, and why these all cascade of events happens, because there is associated increase in inflammatory markers, C-reactive protein, free fatty acids. There's secretions of adipokine, and there is decrease in adiponectin. And our previous speakers have given well enough, so many speakers have shown adiponectin issues and leptin issues, and every correlation with dyslipidemia, insulin resistance, and inflammation, leading to high degree of increased cardiometabolic risk. So applying this concept of MHO in clinical practice, that obesity treatment is challenging. Conservative treatment strategy aiming behavioral changes have very little long-term success. Weight maintenance have a set point. We need to go with a categorically important specific clinical criteria rather than just be a BMI centric. So shift is obesity treatment target should shift from weight loss to health parameter goals. Maintaining favorable cardiomedical health parameter could be easier to achieve and may require only moderate weight loss in MHO.
Dr. Raka will be having his last minute here.
Yes, I am thorough. There's some stucking in my slide changes. These are the pharmacological regimes. This is not my topic, so I'll leave it. So currently approved drugs, we have already given by inputs from other speakers. So conclusion is that metabolic healthy obesity is a concept derived from clinical observation, and there is no standardized definition of MHO, but diagnosis of obesity is must. Fasting triglyceride should be less than 150, SDL more than 40 in men and 50 in women. Systolic blood pressure should be less than 130, diastolic blood pressure less than 85, and fasting blood sugar less than 100. So with this age and gender-dependent variation, 10 to 30% of MHO is not a rare condition, and it represents a transient phenotype, and we need to educate our population as better as we could. So about 50% of population with obesity are metabolically healthy, and absence of metabolic syndrome, whereas only 5% of metabolically healthy, when healthy is defined as the absence of any metabolic syndrome components and normal insulin sensitivity assessed by HOMA-IR. So these are eponyms, these are smart categorizations, but we need to be very specific. So that's why my last slide within poem, The Tree of Karma, is my own poem, just published. Life is destined to our deeds, we plant by genes, cherished at womb like seeds, play at lab, touched by many. Lives remains in cycle, till touched by any. Human without humanity is just a machine. Let's play our rules as we are destined. Thank you so much for your patient hearing.
Thank you, Dr. Raka, for such a wonderful talk and followed by such a beautiful poem. And this reminds me one of the stanza in Madhushala that थोड़ी पीकर प्यास बढ़ी तो शेष नहीं कुछ पीने को, प्यास बुझाने को बुलवाकर प्यास बढ़ाती मधुशाला. तो इस मधुमेह शाला में प्यास बढ़ती जा रही है, लेकिन टाइम कम है. So with this, I think we should move to the next session. That is the third session in this workshop. So I'd like to invite Dr. KP Chandra sir and Dr. Piyush Desai sir for the next talk. And I also want to invite Chairpersons, Dr. Sunil Verma and Dr. AI Hanfi sir. So
thank you very much.
Imran sir, are you there? Dr. Imran, Dr. Sunil Verma.
Hi, Dr. Praful.
Hi boss, how are you? All well?
Fine. बढ़िया.
Nice to see you. अभी सुन रहा था मैं आपका, बहुत अच्छा लगा. मुझे तो लग रहा है कि ओबेसिटी के वर्कशॉप में पिछले 2 सेशन में इतना कवर कर दिया गया है कि there is not much left for me. So many things would be overlap, but it would be interesting in the sense that we will try to focus the things in some different aspect. So there may be a couple of repeats in the slides, and we will that will save our time.
Sir, let me introduce you, though you don't need it. But Dr. KP Chandra sir is well known all over India, and he's a prolific speaker. He's MBBS, MD, and with special interest in diabetes, and he has several fellowships and research publication in his accounts. And we always love to hear more from you, sir. So with that, I invite you, Dr. KP Chandra sir, to talk about obesity impact beyond weight.
Thank you very much, Dr. Ajay Shukla. It is always a pleasure to share stage with you. Thank you, Dr. Mayur Agrawal, for giving me the kind invitation, and welcome Dr. Piyush, co-speaker of this session. And thank you, Raka boss, for your very, I would say, enthusiastic talk. So thank you very much, sir. So right away, I would begin with sharing my slides. So we have been talking. Okay, let me hide this. I hope my slides are visible.
Yes,
now
sir.
it's in slideshow mode. Okay, perfect. So thank you very much. The flow is that after an introduction, Dr. Piyush will be taking a session, then second session, third session will be taken by me, and then we will both of us will be presenting a case. So that is how it is going to go. So I would start. Hello.
Please, backend team, please mute every other person.
Okay, so what we are going to talk about, obesity impact beyond weight. So a lot of things have been discussed in past sessions, and we could understand how this obesity is doing bad. So these are my disclosures for this lecture. So this was the statistics in India, and as per World Obesity Atlas, it says that around 2 crore people are living with diabetes at this point of time in India, and it is going to be 6 crore in next 20 years. But let me tell you, there was a recent article published about the prevalence of obesity, and when they did take the BMI cutoffs of 25 against the 30 cutoff based on this, Obesity Federation has given the incidence prevalence, they said that around 30 to 40% of people living in India are already overweight or obese. So that is huge number. So if you convert it to 130 crores, then around 50 crore people living in India are already either overweight and obese. So that is the huge problem. And unfortunately, we are not prepared. So, you know, when pharmacotherapy in obesity was being talked in the previous session, I could listen that these drugs have not been allowed in India or permitted in India for obesity indication, shows that we are not yet prepared to take up obesity as a disease entity, and that is unfortunate part. We need to understand that obesity is beyond body weight, because obesity is a disease status. I'm just going to read few lines from different organizations who are working for obesity. So World Obesity says that obesity is a chronic, relapsing, progressive disease, need for immediate action for prevention and control of this global epidemic. Obesity Canada says obesity is a progressive chronic disease. European Association for Study of Obesity says it's a progressive disease which has got impact on many diseases. So these are different, that tries to emphasize upon the importance of obesity. Now, let me tell you, obesity is associated with a lot of complications, and overall more than 229 complications. Obesity is not just body weight. That is the message I want to give. It is associated with type 2 diabetes, hypertension, NAFLD, CAD, CHF, GERD, colorectal cancer, breast cancer, ovarian cancer. I mean, you start, it's difficult to read all 229 here. The message is this, that obesity is associated with multiple complications, which includes metabolic and mechanical complications. When we talk about metabolic complications, it includes asthma, NAFLD, gallstones, infertilities in women, then cardiometabolic diseases, we all know, stroke, dyslipidemia, hypertension, coronary artery disease, coronary heart disease, type 2 diabetes, thrombosis, and gout. Mechanical complications like sleep apnea, chronic back pain, incontinence, and knee osteoarthritis are also there. Obesity comes with depression and anxiety also. The unfortunate part is that almost out of 100 people who are having diabetes, less than 40% are diagnosed, and out of them, less than 20% are receiving any anti-obesity treatment. We need to understand that obesity is not just weight management. It is a holistic management. We need to treat food habits. We heard about medical nutrition therapy for obesity. We heard about exercise. We heard about energy balance, and then beautifully given the graphs about which modality has the best effect on long-term weight loss. So all these things have to come together. There are medical conditions associated with obesity. So when you plan treating obesity, it is not only body weight, but you need to treat those medical conditions also, pains also. Then apart from medication, you need to do food management, weight management. A lot has to be done with habits. Yesterday I was just reading that what is this habit? Habit is something which you keep on repeating and your brain gets adjusted to that. May it be bad habit, may it be good habit. So say if you are doing something wrong, you will keep on doing. So those habits have to be changed so that your lifestyle change and you start enjoying it. So inculcating a better lifestyle needs change in habit. Similarly, sleep cycle, all those components are there and they have to be management. So when we talk about clinical management of obesity, it starts from behavioral intervention, which essentially includes our diet, exercise, our sleep habits, and all those things, they are included. Then pharmacotherapy, and apart from that, surgery. So these are the things that we have to do when we think about managing obesity. Managing obesity needs an integrated approach, which includes nutritional support from dietitian, emotional and behavioral support from clinical psychologists, engaging family members for ongoing support, refer to specialist services if individual requires extra support for weight loss. There are patient support group. I believe I've heard that Dr. Ajay Shukla is have a dedicated team for that, and that patient group comes together and they interact with each other, and there is a marvelous response when these people come together and interact with that. So this support group also helps a lot. Diagnosis of obesity and assessment of risk, tailored physical activity program, all these things have to be inbuilt when you think about obesity management. Apart from that, practice nurses, medical therapies, and bariatric surgeons are there. With this, we would like to move to the next session, and I would request Dr. Piyush. Dr. Ajay, you can please introduce him, then Dr. Piyush will take up the next.
Can we have Dr. Piyush Desai's slide? Yeah. So Dr. Piyush Desai, sir, is MBBS, MD from Government Medical College, Surat. He's consultant diabetologist and endocrinologist, postgraduate diploma in endocrinology from University of South Wales, UK. And he's recipient of various awards, and he's having various papers. With that, I'd like to invite Dr. Piyush Desai to further talk about science behind obesity.
Yeah, thank you for inviting me. Thanks to Dr. Mayur and Dr. Ajay. And I think today we are talking about obesity. And the most important part for is my slides are visible?
I think it's coming.
Not yet.
Still to come.
Is it visible now?
No, sir. I think you can reshare. I think some.
Yeah.
It's visible now.
Yeah.
I think you can share the slide.
We are talking about obesity. But what is the exact science behind this obesity and why we are struggling to control obesity, to reduce obesity? These are my financial disclosure for today's talk. And as
the slides are not visible yet, sir.
Not yet visible.
Slides. I think you can close this window, Zoom window, and
have closed the window.
I think you need to reshare.
Yeah, just
close other open windows and.
Are they visible now?
Yeah, perfect.
Yeah. So definitely, Dr. K.P. Chandra has already talked about the physiology, the basic problem with obesity, and how obesity is still underrated. So I'm going to talk about physiology of weight regulation,
what are the etiopathogenesis and the benefit of weight loss, and what is the concept of weight regain. So it is very simple to talk that intake and expenditure. We have to balance intake and expenditure. But intake is mainly dependent on hunger, satiety, and what absorption of various nutrition is going on in that particular person's body. At the same time, on the expenditure side, patient's metabolic rate. I would not say patients always. You can say person also if person is metabolically healthy, obese. But it's elusive thing because obesity is obesity. So person's metabolic rate, his or her thermogenesis, how much exercise metabolism is going on, and need. So that is always we have to balance the food intake and the energy expenditure. And energy expenditure is mainly dependent on two parts, that is basal metabolic rate, resting metabolic rate, and that is another form which is added to that is exercise metabolic. So once on the other side, patient is taking food, where on the other side, patient is having resting metabolic rate. Now, what is RMR? It is human refers to the energy required to sustain all essential physiological functions, be it breathing, be it heart beating, be it just sitting and your brain is active, and every small or big, less important or more important organs all are working and they are consuming energy. Top of that, that is thermogenesis, that is diet-induced thermogenesis. Now, what is diet-induced thermogenesis? It's a heat production in response to food, that is amount of energy required to digest the particular thing. So, for example, if you are eating protein, then protein will take more energy consumption in comparison to simple carbohydrate, which requires least energy consumption. Over the top, that is energy due to non-exercise activity thermogenesis, that is need, that is for routine activity. Like just I am sitting in front of desktop, you all are sitting in front of desktop or your mobile, still our body is utilizing energy by thermogenesis. And plus when we are doing some structured exercise means repeated physical activity, commuting activity, some excessive household chores, that all includes exercise. But here, food is something which we are entering in our body in form of calorie. And here, that is divided by 4, and half of it is resting metabolic rate. So resting metabolic rate is very important. DIT is small part, NEAT is even smaller part, and exercise is another smaller part. So if person is doing exercise, but just other three things are not well taken care, then patient will not have that sufficient energy expenditure to lose weight. And that's why we need to deep down to see the various hormones, various signaling pathways which are orexigenic or anorexigenic. On the level of hypothalamus, neuropeptide Y, arginine RP receptor, orexins, MCH, that endocannabinoids and opioids are orexigenic. And from GIT, ghrelin is the orexigenic hormone. On the other side, leptin, insulin, amylin, polypeptide, and that is PP, and along with that CCK, GLP-1, PYY, oxyntomodulin, androstatin, bombesin, and urogranulin, all are peripheral anorexigenic signaling pathways. But in center, POMC, TRH, CRH, oxytocin, serotonin, and histamine are the important. So when patient is eating, patient is having some appetite, patient is having some peripheral signaling pathway to modulate appetite. And for that, hypothalamus is having arcuate nucleus, where POMC and NPY, these two are major part, where POMC give rise to appetogenic signal or anorexic signal given by this NPY arginine. Now, PYY, PP, GLP-1, oxyntomodulin, all are satiety peptide which will stimulate POMC, and that will give negative feedback to NPY. While ghrelin will stimulate the negative pathway or orexigenic pathway. And leptin and insulin are having adiposity signals. And but here I will say insulin and leptin are a bit different than simple orexigenic and anorexigenic pathway. That leptin as such is anorexigenic, but leptin resistance produces adiposity. Insulin is anorexigenic, but insulin again produces adiposity. So these two hormones are very vital from periphery, which also gives some central signals, and they are also stimulating this anorexigenic pathway and inhibiting orexigenic pathway to have satiety, to increase appetite, or to decrease appetite, or to hunger, to increase appetite. And along with that, there is one center in the brainstem, that is nucleus tractor solitarius and area prostrema, where the role of vagal efferents as well as amylin and GLP-1 is having some role. Recently, we have semaglutide, which is having action on this area prostrema, and amylin is also found to have action on area prostrema. So by now we were concentrating only more on this part, but now we also come to know that these are the another area of brainstem which is also contributing to this. And this all orexigenic and anorexigenic signaling pathways are also having some action on nucleus tractor solitarius and area postrema. So this is very important that by doing this, we have a change in the feeding pattern, gastric emptying, as well as metabolic rate, and both are interconnected with. So if brain has to control, it will control through homeostatic eating. So patient will eat for hunger. So if there is hunger, patient will eat. If patient is satiety, having satiety, patient will not eat. And for that, these are the basic signaling pathway. Hedonic eating means eating for pleasure. Just patient is eating because his brain or her brain is stimulating that it is something good which I like, eating, even if it is not required. And that is mainly controlled by dopamine and opioid and cannabinoid receptor. And you can remember the previous drug which is now off market because of some serious side effect. They were acting on this cannabinoid receptor like sibutramine and other drugs, and they were having control of this hedonic eating. And there is a role of behavioral science by executing function, deciding to eat. Though I am feeling that I am eating, I want to eat, but still brain is suggesting that this is not good for your body and I am not eating. That is called behavioral science, and that depends on thoughts, feelings, and the change in the behavior. And that is the role of behavioral interventions. And that's why not only diet, not only medicine, not only exercise works, but behavioral interventions are also very important. As far as overall etiopathogenesis is concerned, I know that it is very easy to speak that energy intake and energy expenditures are there, but there are role of multiple parts. Adipose tissue, pancreas, gut. There was one specific lecture on genetics, and sometimes it is co-prescription of other medication which are causing this problem, and along with that, environmental changes, which is also one of the most prevailing aggravating factor for obesity, along with hedonic input that we go on eating for our just pleasure. So genetics are high heritability for body weight. There are families who are having obesity as a part, and their genes are in hypothalamus, leptin, melanocortin pathway. I think genetics, there was one specific lecture, so I will not go down, but you can see there is CNS expression of hypothalamic control of energy intake. There are 97 loci which are regulating total BMI, and for genes for fat distribution, there are 49 loci which are controlling expression of adipose tissue, and these are associated with obesity. And you can see there are more than 100 genes and genetic loci are associated with obesity. But at the same time, much more important role is going on with our environment, where socio-cultural factors, traditions, beliefs, peer pressure. I will say peer pressure and socio-economic factors are one of the most important pathway driving this pandemic of obesity. And food environment, availability of inexpensive, highly palatable food is also one of the contributing factors. As far as complications are concerned, I think Dr. K.P. Chandra has already elucidated the metabolic problem, multiple cancers, diabetes, thrombosis, gout, and CVD risk factor increment, mechanical in form of incontinence, arthritis, sleep apnea, and chronic back pain, and mental, that is depression and anxiety, which are coding. So we need to control weight, we need to reduce obesity. Then what are the benefits of reducing weight? If person is losing weight by 5 to 10%, every time we are talking about drugs, just there was one lecture on medical nutrition therapy, there was one lecture on medications in obesity. Each and every medication were accepted for anti-obesity medicine only if they show reduction of weight by 5 to 10%. Why? Because if you reduce weight by 5 to 10%, there is reduction in risk of type 2 diabetes, reduction in CV mortality, there is improvement in lipid profile, reduction in blood pressure, especially systolic BP, reduction in OSA symptoms, and health-related change and improvement in quality of life. And you can see that if you, now there is a time we are talking about diabetes remission. Though it is wrongly called as reversal, it is nothing like reversal. It's more of a remission, that is pharmacological remission, which we can achieve if we achieve 10 to 15% of weight loss. And if we achieve more than 15% like bariatric surgery, you will get the maximum benefit. Dyslipidemia, hypertension, NFLD all needs around 10 to 15% of weight loss. So as arthritis, psoriasis, GERD, PCOS all require 8 to 10% of weight loss, including asthma also. So this suggests that the basic weight loss we should aiming is more than 5% and possibly more than 10%, then we can reduce weight related complications. But the other side of this truth is the fact that we can reduce this significantly. We can have patients achieving this magic figure of more than 10% of weight loss with either medication, with medical nutrition therapy, by bariatric surgery, many other options. But to sustain it, it's very difficult. You can see this number of studies. Every time when patient was in studies, they were losing. But as soon as study was over, actually they end up after 4 or 5 years to a higher level than what they started. And that is the problem with all these studies. So factor reducing, there are reducing energy expenditure, fat oxidation, thyroid hormone reduction, increase in cortisol, that all will cause increased energy storage. On the other side, there are factors which will have various signaling pathway, which will increase food intake. And that happens after diet-induced weight loss. So these are limiting the benefit of weight loss due to diet or even sometimes with structural exercise after some time. That is called metabolic adaptation. Adaptation that resists weight loss is due to hormonal changes, decrease in satiety hormone and increase in hunger hormone, because body wants to reach to that set point, and reduction in overall energy expenditure. This is one study done in 16 participants who had participated in the Biggest Loser reality show, where they have been there for 30 weeks and they were followed for next 6 years. And the inclusion criteria was they have significant weight loss during Biggest Loser study, and we were seeing for the primary objective of resting energy expenditure, metabolic adaptation calculated as per the difference between the measured RD. And what were the result? Body weight reduced by 58 kg during this biggest losing study, or maybe a show. They regained 41 kg in next 6 years. Resting metabolic rate, which was reduced by 610 kilocalorie per day, which was almost plateaued and reduced for longer period of time. And the metabolic adaptation was almost 499 kilocalorie per day. So exactly it is regaining to the primary level. So energy balance is regulated by the body and specifically brain through various sources of input that depends on energy intake, energy expenditure, including adipose tissue, pancreas, gut, genetics and medication, and environment. Brain is one of the vital organ to control all these things, and it controls homeostatic eating, hedonic eating, and execution of function, and that's why behavioral change is also very important part. And adaptation to the resistance to the weight loss are very important thing and a challenging thing during the journey of an obesity patient to losing weight and to reaching to a plateau and then maintaining rather than regaining them. So thank you, and over to you, Dr. Chandra.
So thank you, Dr. Piyush. I request Dr. Chandra to continue with the assessment of obesity grading versus staging. KP, sir? Dr. KP Chandra, sir?
I'm here. Thank you very much, Dr. Ajay. Once again, beautiful presentation. Now let me share my slides. It's assessment and diagnosis of obesity. So are my slides visible now?
Yes, sir.
Perfect. So after understanding the pathophysiology about obesity, how it is caused, why it is caused, and what are the way by which we can target obesity, let us simplify our approach to patients of obesity. When they come to us, how to identify that this patient is obese and needs some attention, and how do we grade or stage the obesity. So we all have understood by now that BMI approach to assessment of obesity is an old way, and at times we miss many of the cases. So whenever we initiate obesity management in our patient, we need to understand how to diagnose it. And the most important thing is that we need to discuss it with the patient, that why this obesity is a problem which should be considered. Most of the time, there is a lot of reluctance in the patient, and they say, "Ki haan, doctor sahab, main bahut acha hu, I don't have any problem." They don't take obesity as a disease. So probably we need to discuss with them and let them understand why this obesity should be treated, why obesity is mother of all those diseases that we are talking about, and then we need to go to treat them. So when you start about diagnosis, we often have, in most of the OPD management tools that we are using, we are measuring BMI in almost all of the patients who come. So measuring weight and height, weight by height meter square gives us the BMI, and this has been traditionally used. And I would say this is the first screening method of obesity when a patient comes to us, and that is BMI. This is an objective measure that can be used to diagnose obesity, and it is easy to measure at every clinic. Now we need to understand that BMI cutoff values for India is different. We all know that Indian phenotype is thin obese people, and the parameter for obesity in India is BMI more than 25 kg per meter square. Waist circumference more than 30 for men, more than 80 for women. Waist to hip ratio 0.9 for men, 0.8 for women. And body fat percentage, it's 25, more than 25 for men and more than 30% for women. Just a recap about how do we classify the weights as underweight, normal weight, overweight, and obesity. So BMI less than 5th percentile is considered as underweight. Now, for Indian population, the 5th percentile comes at 18.5, which usually is 20 when we talk about WHO standards. For normal weight for Indian population, it's 18.5 to 22.9 kg per meter square, which is 20 to 25 for WHO criteria. Overweight, it is 23 to 24.9. In WHO criteria, it is 25 to 30. I'm repeating these just to re-emphasize that the cutoff values that we are used to based on WHO criteria doesn't stand true for Indian population, because percentage of fat that we do have is higher irrespective or higher for whatever BMI that we do have. So when we think about grade 1 obesity, it is 25 to 29.9. Grade 2 obesity, 30 to 34.9. And grade 3 obesity is more than 35. So these are 5 units lesser than WHO standards for the same grading. But with only BMI, we may ignore many people who have got normal weight and they are obese, because in them percentage fat may be more. So this BMI usually under-recognizes the problem of obesity in South Asian population. And there is an emerging concept that patient of normal weight with obesity or normal BMI with obesity who have higher fat percentage. And thus, when you think about normal weight person, reasonable number of them may have obesity, and that is why we call obese people with normal BMI. Here we need to understand what is healthy obesity. In the previous session, it was being differentiated that metabolically healthy obese and metabolically non-healthy obese or unhealthy people. So if obesity leads to metabolic abnormalities, which includes insulin resistance, diabetes, sarcopenia, inflammation, higher cardiovascular risk or cancer risk, we call it metabolically unhealthy. So even in people with normal weight, they may have all these metabolic abnormalities, and then we will call them as metabolically unhealthy, although they have normal weight. Although we did expect that in a normal person, they should be metabolically healthy. Opposite may occur, though it's very less common, that a person may be obese, but he may be metabolically healthy, meaning thereby he may not have all those metabolic abnormalities which I stated right now. That is, he may, despite being obese, he may not have hyperinsulinemia, diabetes, and dyslipidemia. There are higher chances that all these obese people would have some metabolic abnormality. What we call it, obesity mortality paradox. So if a person is having normal BMI and is metabolically healthy, risk of mortality is lower, risk of cardiovascular risk is lower, and risk of disease associated with these disorders are less. When we call about metabolically healthy, we do expect that patient has less amount of fat. Fat is at appropriate position. I mean, that is not adipose tissue. That is not, deposited in your abdomen, but subcutaneous fat, healthy fat, metabolizing fat. So there is increased muscle mass, increased fitness, normal insulin sensitivity, normal blood glucose level, and thus they have lower cardiovascular risk. In normal BMI, metabolically unhealthy people, they will have less muscle mass. So their BMI might be normal, but they have higher percentage of body fat. Those body fat are metabolic load on them that leads, and these excessive visceral fat is usually associated with reduced fitness, insulin resistance, diabetes, inflammation, with higher cardiovascular risk and higher cancer risk. So they are metabolically unhealthy. The meaning thereby is that BMI or obesity may, and its mortality is more associated with the metabolic state of a person. There may be conditions where a patient is obese or a person is obese, but he may be metabolically healthy. And that is mostly because they have increased muscle mass. They have got increased fitness. They may have hyperinsulinemia, but they do have good or normal insulin sensitivity, and that's why they do not have diabetes. They have only milder cardiovascular risk. But most often, obese people have unhealthy metabolism, and they do have excessive visceral fat in comparison to subcutaneous fat, leading to all metabolic abnormalities that we are discussing. So let us understand what are the limitations of BMI assessment. This concept of BMI with metabolically healthy and unhealthy gives us a lot of confusion. And that's why we need to put it at one place, what are the limitations of BMI assessment? BMI does not measure the total body fat. So individual with same BMI value can have almost twofold difference in total body fat. It doesn't assess the presence of concomitant comorbid conditions or disease risk. BMI alone provides no measurement for functionality, quality of life, prognostic contextual factor, or many other factors which characterizes the clinical risk. Change in BMI or waist circumference do not necessarily reflect an improvement in overall health. Evidence suggesting that several factors, including cardiorespiratory fitness, may substantially modify the mortality risk associated with higher BMI. BMI alone is insufficient to guide the clinical decision. So these are limitations, and so we need, when we see a obese patient, we need to diagnose them properly, define them properly, and try to find out, are they at risk and what treatment do they need? Do they need a treatment or not treatment? So something beyond BMI has to be understood. So we need to move beyond BMI for right assessment of obesity, and this is what a proposed clinical staging system of obesity came in. This was complementing BMI with a simple disease-related and functional staging system, and this would provide additional clinical information to guide and evaluate the treatment. So this is called Piedmont Obesity Staging System. This is a clinical staging system of obesity. Here, apart from the BMI, what we are thinking about, three other factors: medical factor, mental factor, and functional factor. So if they do have concomitant medical illness, is it absent, or is it in the preclinical stage like pre-diabetes, or patient even with a normal BMI has diabetes, or patient has got end organ damage like involvement of kidney and heart, or patient is in end stage. So a patient of, say, similar BMI may be in either of these 5 conditions: medically, mentally, or functionally. Similarly, no functional compromise, mild functional compromise, moderate functional compromise, severe functional compromise, or end stage compromise. So for each BMI category, we need to put these 3 factors into it, and then stage the obesity. This staging system is called Piedmont Obesity Staging System. Why it is important? You see, the population-based study by National Health and Human Nutrition Examination Survey 1988 to 1994. Now, when you categorize population based on Piedmont Obesity Staging System, you can see these graphs differentiating, these graphs predicting the survival. People in stage 0 or 1 have got maximum survival, and people in stage 3, 4 have worse survival. When the same population is being characterized based on BMI only, we don't see these graphs separating, which means that classifying obesity based on BMI doesn't give the adequate information and does not identify the target population which needs aggressive treatment. This Piedmont Obesity Staging System independently predicts increased mortality even after adjustment for contemporary method for classifying adiposity. So EOSS method becomes important. Now, this is once again a beautiful depiction how this EOSS method had patients in different categories depending upon BMI. So you can see even those patients who were not obese, just overweight, had 10% in stage 3 and about 47% in stage 2. So more than 50% of the patients who were not obese but just overweight were under stage 2 or stage 3 of EOSS, which needed aggressive management of their obesity. This is how it differs. Yes, people in class 1, class 2, and class 3 obesity did have Majority of the patient who are in EOSS stage 2 or stage 3, but few of them still were not in EOSS stage 2 or stage 3, that is stage 0 and stage 1. They may not need aggressive management of obesity. So despite a lower BMI, if disease activity, if medical concomitant illness, if functional limitations are there, patient would need aggressive treatment, and that is why it becomes important to classify and diagnose obesity based on EOSS method. Person-centered intervention, EOS stage 1. Stage 0, there is no risk factor, only primordial prevention has to be done, lifestyle modification has to be done. Stage 1, risk factors are there, primary prevention, behavioral therapy is to be done. Stage 2, stage 3, and stage 4, there is disease, complications, and severe mental and functional limitations. These would require secondary and tertiary prevention, aggressive medical and surgical therapy wherever indicated. Let us make it simple by taking a few cases. Now, a 24-year-old physically active female, BMI is 32. She is obese, but as per the BMI criteria, but she doesn't have any demonstrable risk factor, no functional limitation, no mental health issues. She is in class 2, stage 0, obesity class 2 as per the original definition, but as per EOSS method, it is stage 0. She needs only behavioral therapy, just a prevention so that she doesn't gain weight further. Health benefits for more aggressive obesity treatment are likely to be marginal. This is where EOSS helps us. Let us think about second case, 32-year-old female, male with BMI 36. He has got hypertension, sleep apnea, and depression. So he is in stage 3, but stage 2 obesity as per EOSS. They have clear benefit from obesity treatment. Let us think about another case, 53-year-old male, BMI 54, disabling arthritis, severe hypoventilation, fibromyalgia. Now he is in stage 4 of the obesity, aggressive obesity management. When surgery is required in this patient. So when you put in medical, functional, and mental limitation into the weight criteria, you understand how to approach those patients. I would like to summarize. Assessment of obesity with BMI classification may not be sufficient to optimize the treatment. EOSS staging system is a simple disease-related functional staging system would provide additional clinical information to guide and evaluate the treatment. The treatment of obesity should be person-centric instead of algorithmic approach. That is what the message I wanted to give. Thank you very much for your patient hearing. Back to Dr. Ajay Shukla. Ajay bhai. Okay,
yes, sir.
Okay.
So with that, we'll be moving to the next part of this. So, sir, there will be last part of your discussion, sir, Dr. K.P. Chandra, sir, management of obesity.
After that, yeah, there is one session by Dr. Piyush, one case presentation. Then
so
I will.
Dr. Piyush, Dr. Piyush, I invite you to present with your case. Yeah.
Then I will give a short case, just some practical example. Yeah, please, Dr. Piyush, go ahead.
Yeah. Are my slides visible now?
Once again, that Zoom has come in.
Is it okay now?
Yeah.
Slides are visible.
Yes.
Yeah. So just to add what Dr. Chandra has talked about the various obesity things, another point which I would like to discuss, even in my first presentation, I also talked about that I lose weight, but it just seems to come back. I think this is one of the most common complaints. Each and every patient coming to your clinic for obesity management will tell you at certain point of time. I'm talking about Mr. Sunil, he's 63-year-old male with BMI of 42 with Asian Indian phenotype and HbA1c is 5.9. Medical history, osteoarthritis, right hip, lumbar spine, that is impeding mobility and disrupting sleep, plantar fasciitis, sleep apnea, peripheral edema, vitamin D deficiency, pre-glaucoma, and pre-diabetes. And weight was highest, that was 121 kg, but now constant effort has kept that weight to 111 kgs, almost 10 kg, what he has lost and maintaining. He is walking for 10 to 15 minutes only per day. That is for 3 to 5 days a week. He is a traveler, avid traveler with a self-described foodie, and obesity, cardiovascular disease, type 2 diabetes, osteoarthritis, thyroid, all are running in his family along with alcoholism. So he had tried some anti-obesity medicine also. He is using some off-label medicine also. He had taken orlistat, and we all know that orlistat is very mild in doing these things. So the most important triggers here is traveling. He is an avid traveler. He is foodie, and obviously this is controlled by the brain. So centrally acting signaling pathway is playing a role. But on the other side, as Dr. Chandra has elucidated, that BMI, whatever BMI, but how incapacitated that patient is, and his life is affected by this arthritis, sleep apnea, and spinal problems. So here the effort got so far is 8% weight loss, which was achieved with possible lifestyle and dietary interventions. And he has tried several anti-obesity medicines without success. Now, if you track down the story of this Mr. Sunil, that during his high school period to college to first job, he gained a lot. Then, with a conscious effort and a very low calorie diet, he reached and he dipped down to the level what he was aiming for. But again, it was gradually gaining. During that period, he has stopped smoking, which another contribution to his weight gain. Then he started anti-obesity medicine. Then he reduced again, but never reached to the initial level. Then he had his marriage. He consulted also, and he's still trying. But you can see that over the period of time, he has gained a lot, and he is having some plateau around 111 kg. Now, what are the factors impacting here? Age, sex, environmental factor, stress, and the disease state, as well as the medications. And weight is causing chronic pain, and now chronic pain is limiting his physical activity to 10 to 15 minutes a day, which ideally should be more than if he really wants to lose weight. So chronic pain is having negative self-efficacy, fear of movement, and the avoidance of sedentary behavior is the cause which leads to weight gain. But weight gain will have physical disability, mood, coping, sleep problem, neuroendocrine problem, which will lead to chronic pain. So now he is in this vicious cycle that weight is also high and he is suffering from chronic pain. Intervention should be, we should get himself operated as early as possible for knee surgery, so can we reduce this chronic pain part. At the same time, we have to address his weight by intervening with some medication. We have to make him lose weight so that he can have his knee surgery. So here, weight loss in people with obesity and osteoarthritis, you can see the result of 11% of weight loss. Stiffness, pain, and physical function, it improves almost by 25 to 30%, even 30-35% improvement is there. And the greater weight loss leads to improvement in physical functioning. And we have step 4 full population with the SF36 score available, validated score available with the step 4 population, where patient who lost 5 kg, who lost 5 to 15 kg, and who lost more than 15 kg, actually the score was increasing. So if patient is losing more, they will have more and better functioning. Now, as far as pharmacological management is concerned, I told that orlistat is tried by this particular patient. It that is lipase inhibitor medication lecture was already done just in a previous session, and this drug works through energy wastage. But then we have naltrexone, bupropion, phentermine, topiramide, semaglutide, and liraglutide, 4 another molecule approved for weight loss. Semaglutide 2.4 is not available in injectable form in India, though it is approved, but they are GLP-1 receptor agonists. Phentermine, topiramide are anorectic, and naltrexone, bupropion is antidepressant with opiate antagonists, and they all cause this appetite reaction. An indication is either BMI more than 30, or if patient is having BMI more than 27 with some comorbidities, like this particular patient is matching this indication. We enroll this patient in clinical. Now, patient primary goal to lose weight, who eligible for knee surgery. We started semaglutide in this particular study, and you can see that patient was able to lose 16% of baseline body weight, and he reached HbA1c from 5.9 to 4.9, and his BMI went down from 42 to 35. So it was an excellent result. We can be happy. Patient is also happy. Patient lost another 18 kg and become eligible for surgery. And patient is manageable for GI adverse side effects. So patient is okay with that because he is losing. And now patient is having different mindset about food, able to make different choice. But it was over and patient was off treatment. Now what happened? After stopping treatment, it started gaining again. So patient was 112 kg initially, went down to 95 kg. Again, now patient is 100.6. So in step 1 extension, where actually we followed patient for the post-treatment plan, you can see the 68 weeks of treatment phase and 52 weeks of off-treatment extension phase. Patient who were on placebo arm remained almost same, but the intervention arm has lost excellent, they have shown excellent result at the end of study, but they go on gaining. Definitely, it was still 5 kg or 6 kg lesser than their previous weight, but still the problem is they are gaining. So the question to audience is, what do you think in the next clinical step? Should we restart anti-obesity medicine until patient falls under 25 kg per meter square and then should stop this? Or we should restart and we should continue weight management without A1? So all three are good, but the most important thing is that obesity treatment is not a short-term treatment. Patient has to continue for a longer period of time, and along with that, dietary restriction, exercise change, behavioral change are very important. So here, patient has stopped treatment and patient came. Now what happened? That patient restarted on anti-obesity medicine. Patient was able to lose weight again. So patient lost few kgs. Knee replacement was done. And here patient able to achieve this. Now, when patient is having this plateau, continuous of treatment is also important. At the same time, the behavioral change and after knee replacement, change in exercise regimen, diet regimen, everything will be very important to maintain this weight for a long time. So, just to summarize this case, I would like to say one important thing, that losing weight is difficult, but maintaining weight loss is even more difficult, and that is a challenge we have to accept, and we have to motivate people, motivate our patient to achieve and can maintain it for long time. Thank you. So just over to you.
Thank you, Dr. Piyush. So we are coming to the last leg of this session in just 3-4 minutes left. Dr. KP Chandra sir will discuss the case 2. Dr. KP Chandra sir, please. Yeah.
Okay, am I audible and visible? Perfect.
Yes, sir.
Sorry. Okay. So we are going to talk about management of obesity and its complication. So Ajay has rightly told that I have to finish it up in a couple of minutes. I would do that. So see, let's think about a patient came with chest pain and he thinks that probably obesity is the problem that I am having. So let us see in this perspective that when a patient comes with some complications and he is obese, he is the right frame of mind, and we have to find out what is the relevance of treating obesity in such patients. So patient has got pre-diabetes, hypertension, ischemic heart disease, and osteoarthritis. 2 previous attempts to decrease weight loss. At best, he was able to achieve weight loss by 5%. Weight loss was not sustained. And then he has not previously been interested in other forms of treatment of diabetes. His BMI is 40, weight is 130 kg. He recently was suffering from angina, and that's why he has come to you. And now he is motivated to lose weight with lifestyle intervention. He has managed 4% body weight loss. He wants to explore further options. So, which obesity-related complications do we really encounter in our clinics? Let us think about it. So this was a study, a Finnish study, which told us about the relative. 1 minute. Okay. So which told us about the relative risk of developing type 2 diabetes patient based on obesity and pre-diabetes. So in absence of diabetes, if a patient is obese, there is around 5% higher risk of developing type 2 diabetes. If patient has pre-diabetes, around 7% increase. And if patient has both, obese patient having pre-diabetes, 18 times higher risk of developing diabetes. It's just telling you that all those risks of developing diabetes, MI, CVA in patients with diabetes or pre-diabetes, they are increasing. If patient has pre-diabetes, there is increased risk of CVA and MI, which is more in comparison to pre-diabetes, which is yet more than those who are normal. And over the time, these have been increasing gradually. The study says that what benefits I do get if I lose weight. So with 0 to 5, up to 5% of body weight loss, there is significant improvement in hypertension and hyperglycemia. 5 to 10% body weight loss, improvement in NFLD dyslipidemias, 10 to 15% cardiovascular disease, obstructive sleep apnea, osteoarthritis of disease. And when you talk about type 2 diabetes or remission, CV, mortality, and heart failure with preserved ejection fraction, body weight has to decrease by more than 15%. These are the results from a STEP 3 trial, which shows the beneficial effect of using semaglutide in terms of waist circumference, systolic blood pressure, C-reactive protein, and triglyceride level. Look Ahead trial also suggested that there are benefit in terms of 4-point major adverse cardiovascular event and secondary outcomes also when there is weight loss of more than 10%. So these points are favoring. If there is more than 10% of body weight loss, you can see all these benefits being proven. There are results from different studies which has shown that with the use of different GLP-1 receptor agonists, except lexagenatide in ELIXIR trial, all those GLP-1 receptor agonists did show beneficial effect on cardiovascular outcome in patients living with type 2 diabetes. I would here refer to LEADER trial, SUSTAIN 6 trial, and PIONEER 6 trial. You can see the impact. Similarly, SELECT trial is being designed where the semaglutide in the dose of 2.4 milligram once daily is being given to non-diabetic people, HbA1c less than 6.5, but those who are obese and overweight, and it is being evaluated to measure the effect of this drug on major adverse cardiovascular event and cardiovascular death. So to say that these patients will get hugely benefited in terms of their cardiovascular outcome if we are able to manage weight adequately. And now the patient, index patient that I was talking about, obese patient with osteoarthritis, came with angina. Now he has become serious for losing weight. Let us use this opportunity and let us use the evidence that we do have in improving their obesity and improving the overall outcome of the patient. Thank you very much for your patient hearing. Thank you, hosts, for giving us the opportunity. Dr. Ajay Shukla, back to you.
Thank you, KP Chandra sir. So with this, we are moving to the section 4, changing the tide. Can we have Dr. Sushil Gupta sir slide for introduction? So Dr. Sushil Gupta sir is well-known professor of endocrinology from Sanjay Gandhi PGI. He was my mentor during my TM training, and he not requiring an introduction from our side, is well-known, and he is vice president of ISBMR, member of Apex Committee DBT, vice president of Education Foundation, and sir is already recorded session. So can we have that?
Thanks the chairpersons for the kind introduction. I'm thankful to Hormone India for giving me this opportunity to speak on oral semaglutide. Diabetes treatment has undergone a sea change in the last 2 decades. From, if you look back at origin of oral drugs way back in 1945-48, when we had first sulfonylureas, we had first bigonides in 1960. Thereafter, lot of other sulfonylureas came, like glipizide, gliclazide, glimepiride. Then we had Pd5 inhibitors. Then there was an explosion of more pathways of glycemic control, and one of these key elements has been GLP-1 receptor analogs. In fact, we are bombarding with many medications for glycemic control. And the most recent one has been semaglutide. We had been practically craving for a drug which is oral, effective in reducing the HbA1c to as much as possible to normoglycemic, to avoid hypoglycemia. But in addition, this is not sufficient. We want to have weight loss because majority of the patients with type 2 diabetes are overweight or obese. In addition, we want to have drugs which are cardiac safe. We crave for a drug which is beneficial to the heart, kidney, and for other micro and macrovascular disorders coming out of diabetes. Oral semaglutide has a recent wonderful addition to our armamentarium to achieve majority of these goals. And I would go through the place of oral semaglutide into this journey of deliberation. This is a financial disclosure for this lecture. I shall go through this agenda of role of GLP-1 receptor analogs in the management of type 2 diabetes, pioneering a new era, competing targets with oral semaglutide, and pioneering management in routine clinical practice. What's the place of oral semaglutide in our clinical practice? We have been craving for an ideal anti-diabetic drugs. Majority of our patients with type 2 diabetes, they do have HbA1c between 8 to 9. We want to control the glycemia, but we don't want hypoglycemia. So it's a balance we want to strike to have reduce the blood glucose levels to desirable level of, as recommended by various societies like 6.5% or 7%. But we want to avoid the hypoglycemia. We want to have a beneficial effect on the weight. We don't want to gain weight. We want to weight remain stable, and more importantly, we want to reduce the weight. We need to have off-target effects like beneficial cardiac effects and renal effects. So this is what we want in any ideal anti-diabetic drugs. What we expect from a newer drug, we should bring the HbA1c to 7%. They should be cardiac safe. They should be able to give us good glycemic control with the low risk of hypoglycemia. There should be no weight gain, or significantly, if you're going to weight loss, it's a real big bonus for us. We want to have minimum side effects and beneficial effects on kidney and the heart. GLP-1 has got a myriad role in the human body. As we know that there are 13 or 14 mechanisms of causing hyperglycemia in human body, in which almost 6 mechanisms are dealt by GLP-1. In pancreas, it reduces glucagon, increase insulin by increasing the beta cell function, and it increases the insulin biosynthesis. It is the GI emptying in the GIT tract. GLP-1 increases natriuresis in the kidneys and is nephroprotective. It increases insulin sensitivity. Just hold on for a while. GLP-1 increases insulin sensitivity. In the liver, it reduces hepatic glucose production, increases hepatic insulin sensitivity, decreases de novo ribogenesis, and reduces steatosis. In heart, it is cardioprotective and provides vascular protection. In the brain, it reduces the food intake, increases satiety, and reduces the body weight. So this is how GLP-1 has got multifaceted action in reducing the hypoglycemia, but in addition, GLP-1 reduces hypoglycemia as well as it induces the weight loss. There's a lot of experience with GLP-1 receptor analogs now. If the person is on 2 oral drugs and we compare the effect of adding GLP-1 receptor analogs versus adding more oral anti-diabetic drugs or insulin in type 2 diabetes, when we compare these two, when we compare addition of GLP-1 receptor analogs to addition of oral anti-diabetic drugs or insulin type 2 diabetes, so already on 2 oral drugs are not well controlled. And when we look at how GLP-1 favors our diabetes management, we look at HbA1c target less than 7%. We look at weight outcomes. We look at change in the oral anti-diabetic drugs consumption, like a pill load, whether we can discontinue or not. And then we look at a composite outcome of all those 3 points: HbA1c target, weight outcome, and change in oral anti-diabetic drugs. When we look at the beneficial effect of GLP-1 other drugs like oral anti-diabetic or insulin, we realize that in all the patients, the A1C target is better, less than 7% is better attained in people who have got who are on GLP receptor analogs. It is much better in the people who are adherent to the diet and exercise and the drug therapy. The weight outcome is significantly better with GLP-1 receptor analogs as compared to other oral anti-diabetic drugs. More weight gain in more patients, almost twice the number of patients. No weight gain in the adherent patients, much more than that, 2.7. The odd ratio is 2.7, and more than 3% of weight reduction in GLP-1 receptor analogs, almost 72%, odd ratio of 1.72. There is a reduction in the oral anti-diabetic drugs. And in fact, one or more than anti-diabetic drugs can be discontinued more in the people who are receiving oral, who are receiving GLP-1 receptor analogs. When we talk of composite outcome, that's a combination of HbA1c less than 7%, no weight gain, happening in more people GLP-1 receptor analogs, A1c less than 7%, and discontinuation of one or more anti-diabetic drugs happening in more, or ratio of 2. A1c less than 7%, no weight gain, and discontinuation of one or more anti-diabetic drugs discontinuation, more patients, odd ratio of 1.87. GLP-1 receptor analogs goes over all other anti-diabetic drugs or insulin in type 2 diabetes who are already on oral drugs. So, the overall this slide tells us that GLP-1 receptor analogs have got beneficial impact on the treatment targets we really aim for in the clinical practice. Now, the challenge is that GLP-1 receptor analogs are basically injectable because they're a large molecule, they are the protein molecules, and this is really discomforting for both the patients and the doctor actually. And there is a global internet survey of around 1,200 physicians, and they said if you're giving too many injections, it leads to poor adherence to the treatment in patients. And almost 26% of these physicians agree that injectable therapy leads to the poor adherence to the treatment in diabetic subjects. So what do the patient prefer actually? This is extremely important to maintain the compliance and adherence on a long-term basis. We need to increase the patient convenience. We have been doing with the vials and syringes for injectables. They are engineered pen injectors. We have got a very good pen, but still it's not preferred by this. And what the most important people want to take as far as possible to have an oral medication form. Now, when we talk of changing paradigms of treatment of type 2 diabetes, we have got oral semaglutide, which has really pioneered a new era in the treatment of type 2 diabetes. We need to give it orally because what we have been desiring so far in the last 7 or 8 decades to have an oral medication, which is convenient to take, they are safe and non-invasive, which can improve the patient's compliance so that we can start this treatment in the early course of type 2 diabetes, and we can address the barrier associated subcutaneous medicine administration. The oral administration of peptide is really challenging because they undergo once they take once they're in the stomach, they undergo enzymatic degradation because of low pH in the stomach fluids, and there are a lot of fluoritic enzymes. There's a limited permeability through the GI epithelium. There's a low oral viability. In fact, GLP-1 analogs are observed only less than 0.01%. So this leads to the limited absorption. Semaglutide is basically a peptide which has got a 94% homology to the human GLP-1 with a half-life of 1 week. Is a large molecule with the displacement of, with the genetic engineering, there is a change of the amino acids at position 8, 26, and 34. At 26, there is a spacer and C18 fatty diacid chain to the lysine to provide the strong binding to the albumin. Sorry. The amino acid substitution at position 8 is important because it protects against the DP4 degradation. amino acid substitution at position 34 is preventing the C18 fatty diacid binding at the wrong site. And therefore, oral semaglutide is a major discovery because this can be given in a pill actually. Sorry. Semaglutide comes in an oral formulation. It is actually co-formulated with the absorption enhancer as SNAC. This is semaglutide, which is a GLP-1 analog, and it is the most effective one tested till date, with a long half-life of 1 week. It is combined with a SNAC, which is a large name actually, which is sodium 8-2-hydroxybenzoyl amino caprylate. It is an absorption enhancer. When this is combined, basically this SNAC promotes the absorption of semaglutide across the gastric epithelium and therefore improves the oral viability. And when we combine it together in a pill, it can be used in management of hypoglycemia. So this is the first in the class oral GLP-1 receptor analog, which is a new way of management of type 2 diabetes. It is possible because of this absorption enhancer at SNAC, because its viability is still 1%, but this is mitigated by 1 week half-life and once daily dosing. There are several treatment doses and there is a patient compliance with the dosing conditions. Oral semaglutide has undergone a large pre-marketing studies, which involves 24 clinical pharmacology trials, 1 phase 2 trial, and 10 phase 3A trials, in which almost 9,543 patients has been enrolled, and almost 5,700 patients has been exposed to oral semaglutide. These are the Pioneer Phase 3A clinical program, which involves Pioneer 1 trial, in which oral semaglutide has been compared to the placebo. It has been used in the studies comparing with the oral anti-diabetic drugs. In Pioneer 2 is the comparison with SGLT2 inhibitors. Pioneer 3 is comparison with the DP4 inhibitors. Pioneer 4 is comparison with GLP-1 receptor analog or placebo. Pioneer 7 is flexible dose adjustment versus DP4 inhibitor with extension phase. That Pioneer 8 is basically add-on to insulin in 51 Indian subjects. Pioneer 5 is in the subjects who have a renal impairment. Pioneer 6 is basically a cardiovascular outcome trial in which 201 Indian subjects were included. Now the Japanese trial, Pioneer 9 trial, which is comparing oral semaglutide with liraglutide and placebo. Pioneer 10 trial is basically comparison of oral semaglutide with GLP-1 analogs, liraglutide. And there's an ongoing trial, which is known as SOUT or superiority CO2 trial. Is a CO2 trial in which 788 Indian subjects are enrolled. So overall, oral semaglutide has undergone extensive clinical studies in the 3A clinical program. When we are looking at efficacy of any anti-diabetic drug, we are looking at HbA1c. We are looking at proportion of the patients who achieve A1c less than 7%. We look at the weight loss of certain degree, like less than 5%. We look at a composite of weight loss with HbA1c reduction. And so these are the parameters we study, and I shall go through all these slides one by one. When we look at a change in the A1c at the end of treatment, and in this we have got a Pioneer 1 trial, Pioneer 2, 3, 4, 5, 7, 8 trial. All of these trials are long-term trials of extending from 26 weeks to 78 weeks. All these trials had HbA1c, baseline A1c of 8 to 8.3%. And when you look at a change in the HbA1c, when we compare in Pioneer 1 trial, compare the placebo with 3 milligram, 7 milligram, and 14 milligram oral semaglutide. As compared to the placebo, the reduction in HbA1c is 0.8% with 3 milligram, 1.3% with 7 milligram, and 1.5% with 40 milligram. When we compare the empagliflozin gives a reduction in HbA1c of 0.8%, while 40 milligram semaglutide gives a reduction of 1.3%. As compared to the sitagliptin, semaglutide has got much better reduction of HbA1c as compared to sitagliptin. With 40 milligram, it is reducing by 1.1% as compared to sitagliptin, 0.4%. As compared to liraglutide reduces HbA1c of 0.9%, while 40 milligram semaglutide reduces HbA1c by 1.2%. In renal trial, semaglutide reducing by 1.1%, while placebo only 0.1%. In the FLEX trial, again, 40 milligram of semaglutide reducing by 1.1% against sitagliptin 0.7%. The most important here is insulin. When you compare with the insulin, actually, it gives a reduction of, when we add insulin, placebo or semaglutide, the semaglutide gives a reduction of 1.2%, pretty huge. So, across all these pioneer trials, oral semaglutide achieved HbA1c reduction up to 1.5%. Now, when we look at a proportion of subjects achieving HbA1c less than 7% at the end of treatment, in all these studies from Pioneer 1, 2, 3, 4, 5, 7, 8, there is a significant larger number of people achieving less than 7% with a dose of either 3 milligrams, 7 milligrams, or 40 milligrams as compared to placebo. 72% of subjects achieved, when we are comparing with empagliflozin Pioneer 2 trial, only 47% achieved HbA1c less than 7%, while 72% achieved HbA1c with semaglutide 14 milligrams. Similarly, as compared to sitagliptin, more number of patients achieved like 50% and 52% with semaglutide 1740 milligram as compared to only 39% with sitagliptin. The important thing is, if you look at liraglutide, it is better with semaglutide as compared to liraglutide, 69% versus 63%. When we, again, the renal subjects, when we compare to the placebo therapy, it is 64% with semaglutide 40 milligrams. In the FLEX trial, 63% semaglutide versus sitagliptin 28%. Now, when we look at with insulin, actually, 64% achieved A1C less than 7% when we are comparing with the insulin, actually. Now, if the HbA1c is, baseline A1C is more than 9%, so this is a post-hoc analysis of 14 milligram semaglutide. In these post-hoc analysis of Pioneer 1, 2, 3, 4, 5, 7, 8 trials, all these trials, it gives you a reduction of more than 2% in all the studies, actually. 2.6%, 2%, 2.2%, 2.2%, 2.1%. So all these studies gives, if the HbA1c is more than 9%, gives an A1C reduction of more than 2% actually. And in fact, it goes up to 2.6%. Maximum is 2.6% when we compare it to the placebo. Now, another important aspect of diabetes treatment is change in the body weight at the end of the treatment actually. And one can realize from this graph that all these studies, there's a lot of weight loss as compared to the comparator molecule. 4.1 kilograms reduction with semaglutide as compared to 1.5 kilograms in Pioneer 1 trial, where the semaglutide was compared to the placebo actually. Much more effective than empagliflozin, 4.7 kilograms with semaglutide 14 milligrams, as compared to empagliflozin 25 milligram, 3.8 kilograms. Similarly with sitagliptin, much better weight loss with all the doses of semaglutide, better than liraglutide in causing weight loss, 5 kilograms versus 3.1 kilograms with liraglutide. In renal studies, more weight loss here. In FLAX trial, compared to sitagliptin, better weight loss, 2.9 kilograms, and with insulin, 4.3 kilograms. So there's significant reduction of weight loss, almost close to the 5 kilograms when you're using, say, oral semaglutide. Now, when we look at proportion of patients achieving body weight loss of 5 kilograms or more, in all these trials, more proportion of subjects achieved weight loss of more than 5% as compared to the comparative molecule. Now, when we combine these two, the HbA1c reduction of more than 1% and body weight loss of more than 5%, again, semaglutide, oral semaglutide scores better than the comparative molecule in all these trials like Pioneer 1, 2, 3, 4, 5, and 8 trials. Now, what is the odds of achieving HbA1c reduction of 1% or more and body weight loss of 5% or more? When we compare the placebo, the odd ratio is 9.5. That's huge actually. As compared to empagliflozin, 2.5, sitagliptin 4, liraglutide 3, placebo 19, again Pioneer 5 trial placebo 16, and in Pioneer 8 trial 15.5. So you have got a better odds of achieving this kind of HbA1c reduction and weight loss of more than 5%. Now, another question comes that, is this drug is cardiac safe? And Pioneer 6 actually is a large cardiovascular event-driven trial in which population of 50, the subjects who were included were the age of 50 years or more with established cardiovascular disease, or subjects who were age was 60 years or more with at least one CV risk factors. The primary outcome was cardiovascular death, non-fatal MI, or non-fatal stroke. This study had a high retention and follow-up rate to the tune of 99.7% completing the study, and the vital status was known in the 100% of the subjects. It established cardiac safety actually. There was a 21% reduction, non-significant risk reduction versus a placebo. The HbA1c in body weight were significantly reduced as compared to the placebo. And when we look at this Kaplan-Meier graph, if you look at time since randomization, oral the patients with the events was significantly lower with the oral semaglutide as compared to the placebo, and therefore as compared to placebo for cardiac safety, it is though cardiac safe, though it is not superior to placebo, but this is not significantly for non-inferiority. Pioneer 6 trial is another it shows that it is mean A1C reduction is significantly more with the oral semaglutide as compared to the placebo. The weight reduction was significantly more, mean body weight was significantly lower with oral semaglutide as compared to the placebo. Now, we had injectable semaglutide in which there was a Sustain 6 trial, and Sustain 6 trial which showed the first MACE happening in there's a hazard ratio of 0.74, means reduction of almost 26% of primary outcome. In Pioneer 6, it was a 21% reduction in the primary outcome. But when we combine both these two trials, Pioneer 6 trial and Sustain 6 trial, there was a significant cardiac beneficial effect to the tune of 24% or hazard ratio of 0.76%. So pooled cardiovascular outcome data says that when we combine the results of oral and subcutaneous semaglutide, it fares better in the terms of cardiovascular, almost 24% risk reduction versus comparator molecule. Just a few words about Sustain 6 trial and Pioneer 6 trial. Sustain 6 trial was both event and time driven, while Pioneer 6 trial was only event driven. There were more events in the Sustain 6 trial, 254 CV events, while Pioneer 6 had 137 events. Mean observation period was 2.1 years in Sustain 6, while it was 16 months with Pioneer 6. And hazard ratio of MACE reduction of 0.74% versus 0.79% with Pioneer 6 trials. So Sustain 6 trial was superior for MACE reduction, while Pioneer 6 trial was non-inferior for cardiovascular safety. But when we combine it together, the results are is having significant reduction in the cardiovascular outcome. So when we summarize oral semaglutide, it is bad in the terms of H1C reduction. It is superior to empagliflozin, sitagliptin, and liraglutide. The weight loss property is better as compared to sitagliptin, liraglutide, and empagliflozin. And end of all these trials, oral semaglutide demonstrated significant greater reduction in the HbA1c and weight reduction versus as compared to sitagliptin, empagliflozin, and liraglutide. It is cardiovascular safe and it was well tolerated, and all the side effect profile was as good as or as consistent as GLP-1, the other GLP-1 receptor analog. So the important thing is this: it's efficacious even when it is given early in the therapy, late in the therapy, or regardless of renal or hepatic impairment. So how do we place the oral semaglutide in clinical practice? Oral semaglutide has a particular way of taking it in the morning. It should be taken up when you wake up in the morning. There should be no food intake for about 6 to 8 hours before taking this tablet. It should be taken with empty stomach, with water, which should be less than 120 ml while you're taking this tablet. It can be lower, but should not be higher, because if the amount of water you are taking with the tablet is more than 120 ml, then it is going to compromise the efficacy because of poor absorption. Just to remember, only less than 1% of these oral drugs is absorbed in stomach, even when you're taking it properly. You have to wait for 30 minutes, should not take any other food or beverages or even water, and one should not take any other oral medications. So it is a graded doses actually because of the potential side effects of nausea, vomiting. So one starts with a 3 milligram as a starting dose given for 1 month, which can increase to the 7 milligrams, which is actually treatment dose actually for 2 months. And if the glycemic control is not desirable, then one can increase to 14 milligrams. This is important that if you are missing a dose, do not take the dose in that day. You can just take the regular dose next day morning. So how do the major side effect of GLP-1 analogs are basically nausea, and how to manage the nausea. In fact, only 80 to 90% people don't experience any significant nausea actually. It happens in 10 to 20%. So discontinuation of oral semaglutide is really uncommon, and it happens only during the early stages of dose escalation. But if it's needed, if the nausea is very, very significant, then treatment can be stopped until the adverse events are resolved. They should encourage to resume once adverse events have ceased. One can just stop it for 21 days and then re-escalate from the lower dose. So a little amount of bit of counseling is required to these patients, and they need to be in the constant touch because every patient is scared of a lot of nausea actually. So they should be reassured, and one can manage with the very simple measures. So who is the ideal patient for initiation oral semaglutide? The patients who are taking one or more anti-hypoglycemic agents, including metformin, with adequate glycemic control, and this can be added as the appropriate second-line setting after the failure of metformin. The patients for whom the weight loss is really beneficial because it gives a superior weight reduction as compared to comparators, and there is a reasonable to consider for patients who benefit from the weight loss. Patient in whom hypoglycemia is concerned, the chance of hypoglycemia is as good as a placebo. So, and it is similar, the risk of hypoglycemia is similar to empagliflozin, sitagliptin, or other GLP-1 receptor analogs. Patients who are already taking injectable GLP-1 receptor analogs and not reaching glycemic targets, they can be initiated on oral semaglutide. So, the most important thing is that this is really, in our clinical practice, I found oral semaglutide much more acceptable as compared to any other GLP-1 receptor analogs, despite its cost actually. So the people tend to avoid the injectables. So this is a very good option when you think of GLP-1 receptor analogs in your treatment actually. Patients who have an established cardiovascular disease or at a high risk of CV risk, they can be given this oral semaglutide. The subjects who have got a renal or hepatic impairment, they can be given oral semaglutide because there is no dose adjustment required in this situation. In older patients also, this can be used because age does not appear to affect the efficacy or safety of oral semaglutide. Now, what is the potential role of oral semaglutide and international treatment guidelines? We know that metformin is a very standard first-line therapy for this. If the patient has high CV risk, one can initiate very specific drugs depending on whether they have got CV risk or risk of heart failure or CKD. If the CV risk is there, then one should check the renal functions, and here one should use the agents which has got a proven cardiovascular benefit like GLP-1 receptor analogs and SGLT2 inhibitors, provided if EGFR is adequate and GLP-1 receptor analogs are inappropriate. If one has got a heart failure CKD, one should check the renal functions and one should initiate the which has a proven cardiovascular benefit like SGLT2 inhibitors if the EGFR is adequate, or GLP receptor analogs if SGLT inhibitors are inappropriate. Patients who are at low risk of CV, low risk of cardiovascular events, the main concern is control HbA1c and control weight, and again the recommended is GLP receptor analogs or SGLT inhibitors or DPP4 inhibitors or thiazolidine or sulfonylurea if cost an issue. And when you're thinking of weight, GLP receptor analogs, SGLT inhibitors with proven efficacy loss programs. So oral semaglutide is reducing your A1C and body weight, and it is much better than sitagliptin, empagliflozin, and liraglutide. Now again, when we talk of the subjects who have got a high CV risk, in fact, it is cardiovascular safe when it is under standard care. There is no restriction of oral semaglutide regardless of renal functions, but however it is not recommended for end-stage renal disease. So so oral semaglutide reduces A1C or body weight, and it reduces insulin dose when we are using the insulin for glycemic control. So I summarize here is that GLP receptor analogs are among the most effective medications for type 2 diabetes, which have been shown to reduce HbA1c, body weight, composite outcome, and even pill burden. This is extremely important. It is basically a scientific breakthrough in innovation to bring efficacious GLP receptor analogs in convenient oral formulation. Across globe, pioneer trials has shown the efficacy of oral semaglutide in reducing the A1C of up to 1.5% and weight reduction of up to 5 kilograms. Oral semaglutide has been found to reduce A1C more than an SGLT inhibitors, DP4 inhibitors, when added to 1 to 2 oral drugs, and reduces HbA1c when added to insulin therapy. In patients with baseline A1C more than 9%, oral semaglutide results in A1C reduction up to 2.6%. Oral semaglutide has got a proven cardiovascular safety in the Pioneer 6 trials with strong potential for cardiovascular death and other cause death reduction, and a larger also as SOUL trial to evaluate the long-term cardiovascular benefit of oral semaglutide is ongoing. Efficacy of oral semaglutide is effective whether it is given early in the treatment or late in the treatment, and it can be given regardless of renal and hepatic impairment. Thank you very much for patient hearing. I'm sorry that I could not contact you physically because of my some prior commitments, visiting some conference in Bombay. We're gonna have a lecture actually. I would be happy to take the comments and questions, but unfortunately this is a recorded lecture, so I cannot answer, and my colleagues and moderators would be ready to answer your questions and really learn from your comments. Thank you very much for patient hearing. Thank you very much and have a good evening. Thank you very much.
So thank you, Dr. Sushil, sir. With this, we'll be coming to the end of session, like last lecture of session 4 by Dr. Shakib Khan. Can we have slide of Dr. Shakib Khan?
I'll be sharing from my side.
Okay. So I know Dr. Shakib is a little late, and so Dr. Shakib Khan is a well-known endocrinologist in Lucknow. He's a very good friend of mine, and he's MBBS, MD, DM Oncology, MR, CPSC, and he has participated in various academic activities and has many publications in his records. So with this, I request Dr. Shakib to go ahead with his talk on overcoming the burden of hyperglycemia with new generation basal insulin.
So good evening. First of all, I would be thankful to Hormone India, and it is a wonderful organization. It is a huge organization of a beautiful conference. So I'll be delivering and discussing about the new generation basal insulin, that is degludec. So how we can overcome the burden of hypoglycemia. We know that we are talking about a disease where we have seen the benefit of having a good and intensive glycemic control from the very onset, but the limiting factor is hypoglycemia. Like insulin is having an enormous potential of decreasing any hyperglycemia to euglycemia, but the deterrent is hypoglycemia. So we'll be seeing that how we can help this problem with this new generation, this second generation basal insulin. So this is the agenda: the emergence of next generation basal insulin, the next generation basal insulin, the safety.
Dr. Shakib's slides are not moving. So slides are not moving. So I think you can
just
reshare.
Just. So is it visible to you?
Still not in presentation mode. So
just wait.
I think you can put in presentation mode and then share. Backend team, do you have slides? I don't think they have.
So is it visible to you?
It's not coming full screen. Okay, you do one thing, Dr. Shakib, you just by the left slides, no, left corner, you can click on them and it will move, I think. It is not coming in full screen.
It is moving and it is full screen mode in my screen.
But it's not visible in Zoom to all as moving slides.
Okay.
So I think you can just cancel that presentation mode and just
If this slide is visible to you?
no, it's coming Zoom. So you can close this window.
Now?
Yeah, perfect. So
Okay.
you can go back. Yeah. Okay.
So we'll be discussing the emergence of next generation basal insulin. So our journey of insulin has been there for last 100 years. So first we have been able to got an insulin to be developed, and then came we have got insulin from animal sources which were close to human insulin, but they were not exactly human insulin. So then came the recombinant insulin, and for that we were in search for a basal insulin and bolus insulin. For basal insulin, that should be a peakless insulin which should act for more than 24 hours. We were not having such kind of option. What we were having was NPH insulin, which was first to be developed as an intermediate acting insulin. Then came the Detamir and Glargine U100, but they were still short of being acting for 24 hours. In some of them, especially in those patients who were requiring larger dosages, they were short of this 24 hours and they were actually not truly peakless. Then came the Glargine U300 or 2GO, and then this Degludec or Tresiba. So this has been an achievement because now we are having an option when we talk about the basal insulin option, which is once a day insulin, which is lasting for more than 24 hours and which is having a very low variability. These options were having a medium variability, while this was having a high variability. It was having a peak after 6 to 8 hours, and that is why it was not a very good option even when the patient was taking in the form of premixes or bit below or before dinner. He was having a peak at 3 to 5 a.m. and that was the reason of having more chance of having nocturnal hypoglycemia. So then came this newer generation Degludec insulin, which is having a unique mode of action. So it provides longer duration of action and a better predictability when it is injected in the form of a dihexamer. It forms a dihexamer formation, and when phenol dissolves, it ultimately results in formation of multi-hexamer chain formation, and then slowly zinc diffuses, and this diffusion leads to release of dimers, which then ultimately becomes monomers, and they get absorbed into the capillaries, and then they act. So this is the mechanism of action of this second generation insulin. So Glargine 300, which is another second generation or new generation basal insulin, is also having a duration of action of more than 24 hours, but it reaches to its action late as compared to this Degludec. So it is having a comparatively delayed action, and particularly which is not suiting to to the need of inpatients or those patients, glargine 100 or Lantus and other analog which we are having, they have an onset of action at 2 to 4 hours. They have minimal peak, but they are short of 24 hours in some of those patients. So degludec has a faster onset of action and prolonged duration of action as compared to glargine U100 as well as glargine U300. So not only this PD is different, it is having lesser risk of hypoglycemia with equivalent glycemic control. When we talk about this new switch study versus glargine U100, you can see that there is a 30% lower risk of hypoglycemia with degludec as compared to U100, and it was significant. And this we are talking about the overall symptomatic hypoglycemia, as well as when we talk about nocturnal symptomatic hypoglycemia. So when the patient is not able to check, and the patient initially would be very, very anxious, that some of them would be arguing that if they would be going to sleep after taking an injection, what will be the chances of having hypoglycemia, which can have dreaded consequences. So you can see that there is a very good profile with this degludec, when the chances of having nocturnal symptomatic hypoglycemia is significantly less, and the risk is actually 42% lower with degludec. When we talk about this DEVOTE study versus glargine U100, it has also shown that the relative risk was 0.6. It means that there was 40% risk reduction of severe hypoglycemia with degludec as compared to U100, and the risk of nocturnal severe hypoglycemia was also reduced significantly by a figure of 53%, and there was non-inferiority HbA1c over time with degludec. So we can achieve our target blood glucose levels with lesser risk of overall hypoglycemia, as well as lesser risk of nocturnal symptomatic hypoglycemia. So when it is another study which is EU treat real world evidence. Now we not talk about only those studies which are done in strict and stringent conditions, but we also talk about the real world evidences with all the constraints of following those patients with compliance and all such issues. If the drug is still showing good result, it means that it is a practical attestation that the drug is doing good. So when we compare this degludec in type 1 diabetic and type 2 diabetic population in 6 months and 12 months, so it shows that it favors degludec as compared to previous treatments, and it was significant in this forest graph in all the parameters, whether it is overall hypoglycemic episode, non-severe overall hypoglycemic episode, non-severe nocturnal hypoglycemic episode, as well as severe hypoglycemic episode, which were drastically reduced, whether we talk about the initial 6 months period or even 1 year period as compared to previous treatment. And same was the case with type 2 diabetes. When we talk about the achievement of target safely, we see this graph, so which shows that this parabolic graph is suggesting that when we target very low HbA1c in our patients, we tend to have more risk of hypoglycemia, especially with the previous generation insulin like glargine U100 in this graph. And the risk of hypoglycemia again increases when the HbA1c is very high. So then there would be more fluctuation. And this can even be improved with the help of degludec. Even when we try to have a more intensive glycemic control, the risk of hypoglycemia is less, and this graph is more smooth with the help of this degludec as compared to glargine U100. So A1C reduction and incidence of hypoglycemia. So we can have the similar achievement of HbA1c with lesser risk of hypoglycemia. So patients could achieve a mean HbA1c reduction of 0.7% of HbA1c reduction more with degludec as compared to glargine U100 with with the equivalent risk of hypoglycemia. So with similar risk of hypoglycemia, if we want to put our patient in, we would be having 0.7% more reduction of HbA1c in our patients with degludec as compared to glargine U100. So what is the clinical interpretation of hypoglycemia evidence in degludec versus glargine 100? So when we talk about the numbers needed to treat, so how much is the option, how much the option is cost effective? So this switch 2 and switch 1 effect study has shown that if we are treating one patient for 1 year for type 2 diabetes, will be decreasing one event of oral hypoglycemia. And in type 1 diabetes, one patient for 4 months, if it is treated, we can decrease one such event. When we talk about nocturnal hypoglycemia, 3 patients for 1 year and 1 patient for 1 year in type 2 and type 1 diabetes respectively would reduce one event. And when we talk about severe hypoglycemia, which is a very treated complication for a lot of our patients, and some of them would be very less interested in taking insulin again after having hypoglycemia, especially in type 2 diabetic patients who are not driven enough. So, and we can reduce this when we are treating 3 patients for 1 year inside switch 1 for type 1 diabetes, and for type 2 diabetes if we are treating 21 patients for 1 year. So this leaps of innovation, like NPH insulin was having a half-life of just 5 to 10 hours, while insulin glargine was having a half-life of 12.5 hours, and this has resulted in reduction of hypoglycemia. So non-severe hypoglycemia reduced by 11%, nocturnal hypoglycemia reduced by 26%, and severe hypoglycemia reduced by 46%. And with the half-life of more than 25 hours in case of degludec, it has resulted in the similar kind of improvement, like non-severe hypoglycemia is reduced by 17%, nocturnal hypoglycemia reduced by 36%, and severe hypoglycemia reduced by 86%. So this level of innovation in insulin degludec as compared to glargine U100 has resulted in almost as much improvement as we have got from NPH to glargine conversion. Conclude study was done in those patients who were already taking insulin. So in those, you can see that degludec versus glargine 300 were compared, though this comparison was done with degludec U200, which is not available in our country. And ultimately, the primary endpoints were not able to be achieved, because of the faulty glucometer, unfortunately. But you can see, if we talk about the numerical values, in the maintenance period, the oral symptomatic hypoglycemia were numerically favoring this degludec, while nocturnal symptomatic and severe hypoglycemia were significantly better in degludec arm as compared to glargine 300, while in the total treatment period and total treatment period also all these parameters were better. So not only the rate of hypoglycemia, but also the proportion of participants with hypoglycemia. So this is the total number of events, and then the people who were having these events. So both these parameters were better with degludec as compared to glargine 300. But unfortunately, their primary endpoint were not met because of those faulty glucometers. So, and lower hypoglycemia with better glycemic control versus glargine 300 in the confirmed study, it was real world evidence, and it has shown that change in rate of hypoglycemia was reduced by 30%. It was significant, and change in proportion with hypoglycemia was reduced by 36%. It was also significant with degludec as compared to glargine 300, that is 2G. So what is the additional benefit of embracing these insulin? So degludec, because it binds to fatty acid in the blood, and it has a different mechanism of action as compared to glargine 300 and U100. So especially glargine U300. So you can see that the insulin required when we talk about the number of units per kg body weight is also less with degludec as compared to glargine U300 and glargine U100, and same has been confirmed with some of these studies. And also the within day variability with degludec is less. So we talk about the glycemic variability, which itself is an independent cardiovascular risk factor, and it is less when we see these quartiles across the day. You can see that it is not as variable as the glargine U100's effect is. So the variability increases across the changes across the day, while it is almost similar across the day with degludec. And lower within day variability with degludec is also has also been seen as compared to glargine U300, not only U100. So with the same amount of insulin being given, you can see that there is a lot more uniformity with degludec as compared to glargine U300. So this is another slide which is showing that when we give insulin at different point of time, what will be the chances of having fluctuation. So whether this degludec is being given at any point of time, it is not having much difference, while the glargine U100 as well as 300, it is having lesser day-to-day variability when it is being given in the morning or evening time, while it is having a much variable profile when it is given in the daytime. So there has been lower glycemic variability with degludec versus glargine 100, and significantly better time in range and lower time below range. So this has been there has been some recent studies like Switch Pro RCT, which this randomized control trial has compared different studies, and it has shown that the nocturnal level 2 and level 1 hypoglycemia, which corresponds to 70 to 55, this 70 to 55 and this less than 55 milligram per deciliter of blood glucose level. So both the levels were less with degludec as compared to glargine U100, and the nocturnal level 1 plus 2 combined, they were also less. They were 12% less as compared to the comparator. And the estimated treatment difference is a significant 1.53% or 20 minutes per day. So the person will be having more time in the euglycemic range, the time in range, without having more risk of time below range as well as lesser time in time above range. So this hypodec trial in type 1 diabetes has also shown that there was significantly lower coefficient of variation with degludec, and the diurnal variation was comparable. While when we talk about the nocturnal risk, nocturnal hypoglycemia, there was significantly lower coefficient of variation, the less variable blood glucose profile with degludec as compared to glargine U100 in type 1 diabetic population. So different parameters like coefficient of variation, the mean amplitude of glycemic excursion, the mean of daily difference, they all were better with degludec as compared to other options when the persons were shifted to degludec. So you can see they have improved in those indices when we talk about the glycemic variability. So there has been lower glycemic variability with degludec versus glargine 300 also. So you can see that time in range is comparable. It is actually significantly better with glargine U300. HbA1c was also comparable. The time in range, time above range was more with Geo, while this adverse index was less in degludec U100, and it was numerically better. And these all benefits we can have with lower dose, with better fasting plasma glucose reduction with degludec with similar dose. And it has been seen in the BRIGHT study also. So you can see that the better fasting plasma glucose reduction was there with similar dosage, though they have started differently as per the recommendation. The degludec was started with 10 unit per 10 unit per day, and then it was subsequently up titrated, while glargine 300 was initiated with 0.2 unit per kg body weight, which has resulted in actually higher dosage, but still the results were good with degludec U100 with similar kind of fasting plasma glucose achievement with lesser units of insulin required. So fasting plasma glucose reduction versus baseline was better with degludec as compared to 300 in that BRIGHT study with similar insulin usage. Or when we talk about the similar kind of blood glucose reduction, the dosage required was less. So degludec offers unparalleled flexibility versus glargine U100 as well as glargine 300. And when we talk about the theoretical possibility, the patient can take from 8 hours to 40 hours after taking the first injection. So even if the patient skips in the morning, he can take in the evening or at the lunchtime. While we have almost no flexibility, we usually advise that the patient should not take 30 minutes before or after when we talk about the glargine U100, while with glargine 300, 3 hours plus minus is usually the prescribed timing when we talk about the inter-day variability about injection, about insulin injection at different days. So there has been observation that the adherence with degludec is better, and it has been confirmed with confirmed study. The likelihood of discontinuation of basal insulin treatment in patients who initiated treatment with degludec or glargine 300, you can see that the proportion of patients discontinuing were higher with glargine U300 as compared to degludec after a similar observation period. And as I was explaining, there was requirement of lower dosage. There was 10% lower dose with degludec as compared to glargine U100, and almost 23% lower dose with degludec versus glargine U300, which we have seen in our clinical practice also. A lesser monitoring which might be required because of the lesser risk of nocturnal hypoglycemia as well as overall lesser risk of hypoglycemia. So the 2 strips less per week with degludec versus glargine U100 in that study shows that it might be even more cost effective also. So just to conclude my talk, this second generation basal insulin, which is having a lesser peak and lesser risk of hypoglycemia, especially the nocturnal hypoglycemia and as well as overall hypoglycemia, has faster onset of action and a prolonged duration of action, is truly long acting or basal insulin as compared to its preceders. It has lower within day and day-to-day variability as demonstrated by PK/PD studies. It has proven hypoglycemia benefit as compared to glargine in randomized controlled trials as well as in the real world evidences. It offers an unparalleled 8 to 40 hour flexibility in day-to-day administration. The patient should be counseled that they don't have to bother about the timing with meal or with even with the timing across the day. They can take it according to their schedule, or even if they skip, they can compensate. They can take it after some point of time, like if they're taking in the morning, they can again take it at lunch or at the time of dinner. So they have more flexibility, and it provides a better sense of well-being as well as increased chances of adherence when we are advising basal insulin to our patients. So with this, I would stop here and would encourage you to ask any of your queries if you have.
Thank you, Dr. Shakib. Very wonderfully explained. So, like, can you share that, like, we have 2 new generation basal insulin? So what are the practical advantage and disadvantage you feel when you prescribe for a patient? Or they are very compatible?
So they both are good, but when we talk about the advantage, so if the patient is already taking, suppose, Glargine U100 and you shift them to Glargine U300, we have seen and now it has been confirmed that you would be requiring more number of units, and that is one of the psychological deterrent to the patient, that you will be explaining to your patient that it is a better insulin, but he will be requiring more number of units. So it is one of the con with 2Geo. Otherwise, we don't have actually Bright and Conclude has been done for a direct comparison, and Conclude was not able to have its primary targets met because of the faulty glucometer. So they both are good, but yes, I personally feel and the data also supports this fact that actually this degludec is having some edge as compared to Glargine 300, as well as because like Glargine U100 is available in an acidic form. So when this degludec has been available, now it can be combined with ultra short acting insulin also. So it has cleared the way for co-formulation, which is available these days. So we can give basal plus, which is available in the form of degludec plus aspart combination. So we can give in a prick a basal plus, so we can cover the job of basal insulin requirement, as well as we can cover the largest meal also. So this development has made our life a bit better when we are talking about insulinization, and suggesting our patient that now we'll have to start with insulin. So we can use all the insulin in different patients, but when the patient can afford, yes, it can offer some more advantages as compared to their previous insulins.
Okay, thank you, Dr. Shakib. So with this, we are ending this session, and I welcome Dr. Imran Hanfi, who has just joined. So session Hall B lectures are over now, but there are a few recorded sessions left from Hall A, which we will be playing here. So Dr. Imran, you please stay with us. So I invite Dr. Imran, sir. Can we have a slide of Dr. Ahmad Imran?
Thank you. Good night.
Thank you, Dr. Shakib.
Good night.
Backend team, can we have a slide of Dr. Ahmad Imran?
So just give me 1 second.
He was chairperson in session 3, Hall B, AI Hanfi. Dr. AI Hanfi. Dr. Imran, are you there? Okay, so I invite our chairperson, Dr. Ahmad Imran Hanfi, and Dr. Sunil Verma, Senior Consultant Internal Medicine in Sara Hospital, and Dr. Rajiv Madan, sir. So now we will proceed with the recorded session. Backend team, can we have session of Dr. Matthew John from Trivandrum on newer molecules in diabetes kidney disease?
Thanks for inviting me for this conference. So I'll be speaking on newer molecules in diabetic kidney disease, and I'll be concentrating on finerenone. So as you are aware, diabetic kidney disease is one of the major causes of mortality and morbidity in people with type 2 diabetes. And if you look at the two of the main drivers of or markers of diabetic kidney disease, one is the UACR and other is the eGFR. And you can see from this large database of more than 10 lakh patients that both these parameters, as they increase, are independently associated with increased risk of cardiovascular events, a reduction in eGFR or an increase in UACR. And historically, we never really had good molecules for controlling diabetic kidney disease, and for that matter, CKD. Years from that, we first had both ACE inhibitors, and later we had the ARBs, which could reduce hard renal endpoints, or rather prevent the progression of diabetic kidney disease to end-stage renal disease and requirement of renal replacement therapy. And over a period of many years hence, after that, by 2017-18, we started having SGLT2 inhibitors, which was found in various trials, CVOT trials, and also in a committed trial of Credence to improve renal outcomes in people with diabetic kidney disease. And now we have finerenone in the Fidelio DKD study to prove that it can also reduce the risk of renal disease progression. If you look at the previous data from trials like the renal, which looked at losartan, you see that there is always a residual risk of renal disease, even in when people are optimally blocked with a ARB. And when it came to studies like Credence and DAPA-CKD, despite using a renin-angiotensin-aldosterone inhibitor like ARB and an SGLT2 inhibitor like canagliflozin or dapagliflozin, we still continue to have a residual risk of disease progression in these people. And we need to look at why that is happening. So till now, we have been looking at, or we have been targeting the hemodynamic aspects by reducing the blood pressure or by reducing the intraglomerular pressure with the use of ACE inhibitors, with the use of antihypertensives, or with the use of SGLT2 inhibitors. We also have worked on the metabolic part in terms of good glycemic control with the use of various molecules like various anti-hyperglycemic agents, SGLT2 inhibitors, and GLP-1 RAs. But one area which was left untouched was the final common pathway of inflammation and fibrosis, for which no particular therapy was available till now. But we know that inflammation and fibrosis is primarily driven by the mineralocorticoid receptor activation, which leads on to kidney diseases and heart diseases. In both the kidney and the heart, there is an increased expression of pro-inflammatory and pro-fibrotic factors, which can lead on to inflammation and fibrosis. And when you block the mineralocorticoid receptor overactivation by the use of drugs which can block it, you in fact lead on to prevention of these complications. Now, finerenone is a novel non-steroidal selective mineralocorticoid receptor antagonist. It's a bulky non-steroidal molecule which basically gets attached to the mineralocorticoid receptor. And what it does is that it modifies the specific gene expression. So instead of molecules like steroidal drugs like aldosterone inhibitors like spironolactone, this results in a very different selective and a potent change in terms of gene expression, primarily affecting the anti-fibrotic and anti-inflammatory effects, unlike spironolactone, which generally affects the hemodynamic effects. Now, this is a new chapter in the management of CKD in people with type 2 diabetes. Now, let us look at the studies where finerenone has been used. So these are data from preclinical studies of finerenone in preclinical models of disease. So the first slide is trying to look at how the drug has been effective in terms of reducing inflammation and fibrosis in kidney disease in preclinical models. And the second slide is primarily to look at how a potent inhibition of mineralocorticoid receptor action can inhibit inflammation and fibrosis in cardiac tissue. So both these places, finerenone has been found to be beneficial. Now, there has been a phase 2 programs, multiple phase 2 programs, but I'm not going into the details of these phase 2 programs named as ARTS. But basically what it has shown is that it has shown a reduction in UACR at around 38%, around 5 millimeter drop in systolic blood pressure. And in comparison to spironolactone, a smaller increase in potassium. And in people with CKD stage 3 at baseline, you could see that the potassium increase was there even with finerenone, but approximately 0.1 to 0.3 millimole. And the EGFR decline, which you would see in patients when they get started on SGLT2 inhibitors or ARBs, does happen on people who are on finerenone also. And that is in the magnitude of 3 to 4 ml per minute. So these are the sort of basic coverage of the entire phase 2 programs, which led on to the drug development. Now, coming to the phase 3 program. So phase 3 programs are Fidelio DKD, Figaro DKD, and Fidelity DKD. Fidelity DKD is in fact a compilation of all this data together. So I won't be touching that. I'll be looking at Fidelio DKD and Figaro DKD. Now, if you look at the drugs which are currently available to treat chronic kidney disease progression in people with diabetes or without diabetes, you can see that as a combined group, Figaro and Fidelio, in fact, easily has a higher number of patients enrolled, more than 13,000 patients enrolled in this group of trials in comparison to other data. You can see the renal, the INDT, the credence, which had around 4,400 patients, in comparison to DAPA CKD, which has around 4,300, and EMPA kidney, which has got around 6,000 patients. So the Figaro-Fidelio combination data, in fact, has produced very robust outcomes in terms of how finerenone can reduce the risk of kidney disease progression. Now, just to look through the summary of these two clinical trials, basically both these clinical trials are phase 3 trials, and they are done in a very similar pattern. The type of patients who are enrolled into these trials are also very similar. These are patients with diabetic kidney disease. I'll come to that definition for later. But basically, the Fidelio DKD study looked at a composite renal outcome, whereas the Figaro DKD study, the primary outcome was primarily cardiovascular. So this is the essential difference between a Fidelio CKD study and Fidelio DKD study, although the inclusion criteria has got minor differences, which again does reflect in the sort of outcomes that you have. Now, a bit more depth into the Fidelio DKD study. So basically, the key inclusion criteria include people with type 2 diabetes and chronic kidney disease defined as a UACR between 30 to 300 and EGFR between 25 to 60 with a history of diabetic retinopathy. Or if you had more severe proteinuria like 300 to 5,000 milligram per gram and your EGFR is 25 to 75, then you don't need a diabetic retinopathy for inclusion in the study. These studies were done on people with optimal ACE inhibitor or ARA inhibition already and potassium less than 4.8 millimole at baseline and screening visits. So this is a time, you should realize that this study started off at a time when SGLT2 inhibitors were not in regular use for diabetic kidney disease. And in these trials, less than 10% of patients were exposed to SGLT2 inhibitors. So these are only a very small subgroup of SGLT2 inhibitors patients are there in this trial. The primary outcome in this trial is time to onset of kidney failure, sustained decrease of EGFR more than 40%, that is the time to onset of kidney failure from baseline, or death due to kidney disease. So sustained reduction of EGFR, requirement of reaching end-stage renal disease or death due to kidney disease was the primary outcome. Now coming to the Figaro DKD study, again a very similar inclusion criteria. Patients should be again be on optimal ACE inhibitors or ARB dosage, and potassium should be less than 4.8 to be included into the trial. But here, the outcome is a bit different. The outcome is a time to CV death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. And we know that in people with chronic kidney disease and diabetes, cardiac events are possibly one of the most important outcomes that we need to look at. Now coming to the efficacy and safety outcomes. So on top of maximum, this is data from the Fidelio DKD study to show that on top of maximum tolerated RAS therapy, finerenone significantly reduced the primary kidney outcomes by 18%. So end-stage renal disease defined as EGFR less than 15 ml or requirement of renal replacement therapy or transplantation. Sustained EGFR reduction of more than 40% from baseline or renal death. This is the outcome, which was reduced by 18% in the Fidelio DKD study. Now coming to the Figaro DKD study, the primary composite outcome was time to CV death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure, which was again reduced by 13% in people who were randomized to finerenone in comparison to the placebo. That is, this primary cardiovascular outcome was reduced in these patients. And this was primarily driven by a reduction in hospitalization for heart failure. Now, when it comes to any mineralocorticoid receptor antagonist, the major concern is in terms of risk of hyperkalemia. And there are very clear data in the phase 2 trials to show that this risk is substantially lower than that of spironolactone. And if you can see this, both the trials, the Fidelio DKD study and the Figaro DKD study, any hyperkalemia was reported in people up to 18%, which was around 11% attributed to the study drug. And drug discontinuation was in around 2.3%. In comparison to placebo is around 0.9%. Similarly, in the Figaro DKD, any hyperkalemia was around 10.8%. And hyperkalemia leading on to discontinuation was around 1.2%. So there is definitely hyperkalemia. There were no serious events, severe events or deaths due to hyperkalemia. And around 1 to 2% of patients had to be discontinued because of the hyperkalemia in the study. There was a modest effect on blood pressure. I showed you in the phase 2 data around up to 5 millimeter drop in blood pressure with 20 milligram. A1C levels were not affected. Weight was not affected. There was no increase in kidney injury between the groups, and sexual side effects like gynecomastia and irregular periods were balanced between the groups. So this is a summary of both these trials, the Fidelio DKD and the Figaro DKD studies. Both the CKD progression and CV mortality and morbidity were reduced. Now let us come to the last 3 slides in terms of key guideline recommendations for the use of finerenone. In July 2021, FDA approval of finerenone was there, and February 2022, the EU approval is there. So basically, it is used to reduce the risk of kidney disease progression, cardiovascular death, non-fatal MI, or hospitalization for heart failure in people with kidney disease and type 2 diabetes. And similar indication in the EU, but only for the chronic kidney disease part. Now, when it comes to EGFR-based dosing, if the EGFR is less than 25, it is not recommended. 25 to 60 ml, 10 milligram per day, and more than 60 ml, 20 milligram per day. The 2022 ADA guidelines also have updated the use of finerenone. For chronic kidney disease, it is in the use for people with increased risk of kidney disease progression or cardiovascular events, and or who are unable to use SGLT inhibitor, a non-steroidal mineralocorticoid receptor antagonist finerenone is recommended to reduce both CKD progression and cardiovascular events. And for cardiovascular risk management, again, finerenone is used to improve cardiovascular outcomes in people with type 2 diabetes and CKD. And finally, the KDIGO 2022 guidelines also have given a very similar suggestion, but with an add-on that SGLT inhibitor should be the first add-on before adding a non-steroidal MRA for type 2 diabetes and CKD. And when you use an MRA, you should be using an MRA with documented kidney or cardiovascular benefits like finerenone. To summarize, finerenone is a mineralocorticoid receptor antagonist. It acts primarily by blocking the mineralocorticoid receptor-associated fibrosis and inflammatory pathways. It produces less hyperkalemia and no gonadotropin-related adverse effects, reduces progression of diabetic kidney disease, reduces CV mortality and morbidity, and approved for the use in people with diabetic kidney disease with eGFR more than 25 ml per minute without hyperkalemia. Thank you very much.
Dr. Sushil Jindal sir's introduction slide. Thank you. Can we have Dr. Sushil Jindal sir, Hall A? So just now we had very good lecture by Dr. Matthew John. It was a recorded lecture on newer molecules in diabetes kidney disease, finerenone, and we have learned from that. Now coming to the last recorded lecture from Hall A, Dr. Sushil Jindal sir. Can we have a slide of his introduction and followed by his recorded lecture?
Dear friends, good morning. I am Dr. Sushil.
So can we play the recording?
Yeah, you can play the recording.
Sushil Jindal, and I am highly thankful to Hormone India for giving me the opportunity to talk about this very relevant topic, that is pitfalls in the SMBG procedures we do and our patients do very regularly. Let us see what are the problems with this procedure. And this SMGG is usually done by glucometers, and the errors usually arise because of the wrong use of glucometers.
Can we play it again?
Also in the SMBG procedures we do and our patients do very regularly. Let us see what are the problems with this procedure. And this SMGG is usually done by glucometers, and the errors usually arise because of the wrong use of glucometers. And then there are some inherent problems with the technologies which are used in measuring the glucose in glucometers. Now, this is a very good, I'll say, the a way to find out patients' glucose, and it is very helpful in deciding day-to-day treatment and also the diet of the patient. So it's a point of care, and real-time glucose can be estimated. It's very handy, portable, and easy to use, can be used by the patient and can also be used by nursing staff. And results are immediately available, and very small amount of blood is needed. Patient can use it at home, at work, or while he's traveling at any point of time, right in the morning or in the night or in the day. And these readings are usually stored in the glucometers with time, with date, and also with relation to meal, and they can be rechecked by the patient as well as by the doctor, so that the treatment can be better tailored for that particular patient. It's very useful in timely diagnosis of hypoglycemia and also for the hyperglycemic emergencies. It's a screening tool for epidemiological studies. Remember that glucometers are not recommended to make the diagnosis of diabetes because of the inherent problems of having some variation in the glucose results, and it has acceptable accuracy. I'll again repeat, it's acceptable. They are not absolutely accurate, but they have an acceptable accuracy and good correlation with venous plasma glucose, which is estimated in lab. Remember that the lab reports are supposed to be the gold standard. There, we want the procedure to be done under very, very controlled way, and also we let the reaction go to the end point, and we have incubation period, and so we actually are measuring glucose level in a given sample much more accurately in the laboratory as compared to point of care measurement done by the glucometers in home or even in the hospitals. Now we know that manufacturers of glucometers, they claim that there is a very good accuracy of their products, but the clinical experience we see day in and day out is very different. I'll just elaborate it by a case. This is a case of a 16-year-old girl who was a known type 1 diabetic for the last 4 years and brought to our OPD with complaints of abdominal pain, vomiting, and not feeling well. And she was highly stressed because of ongoing class 10th examination, and on glucometer, the parents told that they have recently checked the glucose level. It was 256. And patients say that this is very usual for having glucose levels of around 200 many times in last few days, and there is not a worrisome level for them. The parents also insist that patient be treated for abdominal pain and vomiting, and so she can be brought home and can appear in the ongoing examination and will not miss the examination paper. But we insisted for lab glucose, and we found that the lab glucose was 428 and urine acetone was strongly present. Patient was to be hospitalized and treated for the decay, and she definitely missed her examination. Now, let us see what is the accuracy level recommended for glucometer readings by FDA. We know that glucometers which are used in hospital, they have some different levels of accuracy which should be followed, and they are slightly stricter. But in personal use glucometers, which we are more concerned, which are used for SMBG examination, FDA says that 95% of readings done by glucometer should fall in plus to minus 1500 from the reference or the lab glucose values. So that means there is a good variation of 30% which can happen in the readings between the lab reading and the glucometer reading. And FDA also says that 99% values should be within 20% up or down from the reference value. Now, FDA says that stricter criteria would increase the cost of the test, will also need more amount of blood, and will also take more time for reporting. And so these are the slightly liberal type of parameters which have been fixed for the glucometer manufacturers that they should follow. And the fallacy is that if you have a reference value of 60 milligram, a FDA approved glucometer can read it from 45 to 75 milligram per deciliter. And if the reference value is 200 milligram per deciliter in the laboratory, then FDA approved glucometer can read it from 160 to 240. And remember that these criteria will fit on 95% times. And so there are at least 5% results which will be worse than these criteria. And we do not know what happens to these 5% because they are very, very erroneous, maybe very high, maybe very low than the reference value. Now, hospital patients' story is entirely different. They are sick patients, many times dehydrated, maybe in shock, maybe on hypoxic. We have seen many patients during the COVID era who were hospitalized with hypoxic conditions. They were also on oxygen. They have different hematocrits, and we'll see in the next slides how hematocrit produces a difference in the readings, and not known at the time of testing. We do not know the hematocrit many times, and take multiple drugs also. Now we know many drugs can interfere with the glucometer readings, and they may be having glucose values which are very rapidly changing. And they may be tested by different people on different meters, and so these readings may be unreliable many times. Now let us see what are the methodologies used in the glucometers. The glucometer cannot measure the glucose directly, but we need some enzyme which reacts with the glucose and then can produce a change in the color of an indicator, or can produce a small amount of voltage which can be measured by the glucometer. Now, these enzymes provide specificity for the glucose, but remember, in spite of having very, very specific reaction with the glucose, they may also have interference with certain other substances. Now, two different enzymes are used for glucometer strips. One is glucose oxidase and second is glucose dehydrogenase. And glucose in the blood reacts with the enzyme, glucose oxidase or glucose dehydrogenase on the strip of the pad. The reaction produces an electrical current, which are the glucometers. Most modern glucometers are now electrochemistry based. So they are producing a small amount of current when the reaction between the enzyme and the glucose takes place, or changes the color of an indicator proportionate to the glucose concentration in the blood. Now, these enzymatic reactions, like all enzymatic reactions, are very susceptible to oxygen concentration, the temperature, the drugs, the pH, and also the interfering chemicals present in the blood. The enzymes and the reagents on the strip pad may deteriorate with the exposure to humidity, heat, dust with time. So it's very, very important that the strips should be properly stored. Expiry date of open bottle may be different from the unopened one. Now you can see many manufacturers clearly mention that once the bottle is opened, the strip should be consumed within 1 month. And so what happens is patients keep using those strips and they may give erroneous results. Many glucometers require calibration chip or the code with each new bottle. Non-adherence to this code and the calibration can produce fallacious report. Now, what happens is that you have every time a new bottle of strips, there is a calibrator coming with it, which should be inserted in the glucometer. Now we have many glucometer manufacturers which are also having non-coding glucometers. Now, this is how you apply blood on the strip and it changes color of the indicator, and light is thrown from the source and it is read on the signal detector. And this is the colorimeter or the reflectance meter photometers, which are still now prevalent, but we are very frequently used few years back. And this is the electrochemistry based meters. The blood is supplied on the strip, and then strip produces some degree of electrical current, which actually makes the glucometer to read the amount of current which is proportionate to the amount of glucose present in the sample. Now, these are the differences. The electrochemistry meters, they are smaller and they can give result very fast. Now we have glucometers which can give results in 5 seconds, 10 seconds, 15 seconds. And test strips are more complex in design, and they are also more costly, but require very small amount of blood. Now glucometers will require just 5 to 15 microliters of the blood, which is a very small, tiny drop. And so it's easier for the patient to prick himself. And these glucometers are perceived newer, and they are definitely newer than the electrophotochemistry, but they are definitely not as accurate as the photometry glucometers were. The photometry glucometer, the reflectance photometry glucometers, they require a larger instrument. They are slower. Usually the readings come in 30 seconds, 45 seconds, and in the older ones, it used to be 60 seconds also. The step strips are very simple, but require larger. Now here you require something like 50 to 100 microliter of blood. It's sort of a hanging drop of the blood is required. And so the patient had to make a more painful prick to get that much of blood. And time also required was very high. That is, usually glucometer will take some time, like 45 seconds to give you the report. But they are time tested and proven quality glucometers. Now the glucometers, now we should remember that the glucometers, they use whole blood. And then this value is extrapolated to serum plasma glucose, the plasma glucose value, assuming the hematocrit is normal. Now blood has a liquid component which contains glucose, and blood has a cellular component, predominantly RBC. And the RBC fluid contains much less glucose as compared to the fluid part of the plasma part of the blood. And so the whole blood values are usually 10% lower than the serum or the glucose seen in the plasma. But the modern glucometers, what they do, they use a mathematical algorithm to increase the glucose value to the plasma glucose value, but they assume that the hematocrit is normal. Now, a person who has a low hematocrit may have more plasma and so may have a higher glucose value, and so we should remember that this makes an erroneous report. Glucometers use capillary whole blood. Values are different from the venous, especially in the postprandial. Now we know that the blood, when it starts in the arterial compartment from the heart, carries much higher level of glucose. In capillaries, some amount of glucose is extracted, and veins, they still less amount of glucose reaches because most of it has been extracted in the capillaries. So what happens is that the glucose values in capillary is definitely higher than the values seen in the venous side of the blood. And this variation is much higher in the postprandial state. In fasting state, it's a negligible difference, but in postprandial state, the difference is much, much higher. And so we should remember that the capillary glucose values will be slightly higher than the venous glucose values, particularly in the postprandial state. Lab is usually using an endpoint reaction, while the glucometer read ongoing reaction at a pre-prescribed time. Now, it's very important that when you are using the reflectance meter, the reaction is going on, the color is changing to darker and darker, but you have pre-specified that after 30 seconds, you will read the reading. But what happens is that in laboratory, you allow the incubation period of say 30 minutes, 40 minutes. And so the fastest color has already developed. And so chances of error are much less. Now, contaminated skin site puncture or dilution of blood sample by the antiseptic solution can also lead to paralysis. Very small amount of blood is needed. And if you have applied some antiseptic solution, and you not allowed it to dry up and then puncture it, it may get diluted by that solution. And similarly, if the skin contains some contaminations like glucose, some fruit juices, or even fruits, or even milk which contains galactose, can produce large differences because very tiny amount of blood is needed for the glucometer. Now, GDH-based glucometers, that is glucose dehydrogenase-based glucometer, measure glucose more accurately, but simultaneously they have more interference with the drugs and chemicals. Now, we have already discussed that the capillary glucose values in fasting are nearly equal or slightly less than the venous glucose, but the postprandial values, there is a higher difference. It may be 20 to 70 milligram. depending on the patient's response to endogenous or exogenous insulin, how much glucose is extracted in the capillaries before it goes to the venous side. And should remember that this plasma glucose values are 10% higher than the blood glucose values on the in the whole blood. And then modern glucometer extrapolate the capillary whole blood glucose values to venous glucose values by a mathematical algorithm, but it assumes that the hematocrit is normal. Again, going to a case, Mr. DS, known case of type 2 diabetes for 10 years, was recently prescribed insulin. One day early morning, he felt uneasy, nervous, and sweaty. He immediately recognized he's going into hypoglycemia, checked glucose by glucometer, it was 55. He immediately took out glucose tablets from the strip and chewed them. After 15 minutes, he rechecked blood glucose and it was found that glucose value is 302, but he just forgot to wash his hand. His hand was already contaminated by the glucose tablets. And so what happened was that the glucose levels came very high. Assuming that patient has recovered, he is recovered and there is no need to take further meal. He did not take a meal of further glucose, and then within half an hour, he slipped into hypoglycemia. Now, see that 302 was an erroneous report because of contamination of glucose, which he took out from the strip and was still adhering to his fingers. Now, these are very important slides. You can see that exposure of strips to a higher degree of temperature decreases the glucose values both in GO and GDH glucometers. Exposure of strips to decreased temperature will increase. And so we keep seeing patients who say that, doctor, in summers, I don't know why my glucose levels are well controlled, but in winters, they are not well controlled. You can immediately find out that what is the reason. Exposure of strips to humidity, vibration, dirt can also deteriorate the results. Outdated strips, again, failure of to calibrate can also, but here see, failure to dry hands, this can increase or decrease. Failure to adequately put a drop on the, that the whole strip pad is not covered by the blood, again will produce reduced readings. And anemia, all anemic patients will have a higher plasma compartment as compared to cellular compartment. And so in anemia, the glucometer readings will be higher, and the polycythemia, they will be lower. High altitude, there is some degree of hypoxia. The glucose oxidase meter may show higher readings. Ambient temperature, if it is very high, suppose in summers when temperature is nearing 40 degrees, the glucometers will show a decreased reading both in glucose oxidase and dehydrogenase glucometers. Ambient temperature, if it is less than 10 degrees, it will show a higher value. Postprandial state, we already said that capillary glucose values are higher than the venous glucose values. And you can also see the diabetic ketoacidosis and severe acidosis will give rise to lower glucose values, both in glucose oxidase and dehydrogenase. And this is what we discussed in our first case, that the values seen in the glucometer was much lower as compared to the values which were found on the lab readings. And there are many compounds like maltose, xylose, galactose, which again is a part of milk. They can also produce changes to higher glucose values in glucose dehydrogenase. Ascorbic acid can also produce increase in the glucose value in dehydrogenase method. Glucose dehydrogenase. Now, the paracetamol, acetaminophen, can produce a decreased value in glucose oxidase glucometers and can produce an increased value in dehydrogenase glucometer. Dopamine, patients hospitalized maybe on dopamine can produce reduced value, and mannitol can produce glucose oxidase meter will produce higher readings. So these are many, many things which can interfere and produce a reading which may not concurrent with the lab readings. And when you combine all of them, you can see that many patients may have many co-founders may produce much varied results. Now, how can we avoid these fallacies? It's only by training the patient and the staff. Use only the strips listed in the manufacturer for your device. Now, this is very important. Every manufacturer has 2-3 models of the glucometer, and every model has a different strip. Many patients, they keep using strips from other model to the other glucometer and can get erroneous reports.
every time you start to use a new box of strip, make sure that you calibrate the glucometer. Now we know that non-coding glucometers are available. Check the strips for the expiry date also. Make sure that the lid of the glucometer strip bottle is tightly closed immediately after you take out the strip. Don't store the strips in fridge. Now, many patients keep assuming that this expiry date will be extended by keeping them in there, but this will produce erroneous result. Make sure to wash and dry your hands before you test. That's very important. There are so many contaminations present in the household utensils and other things which can produce higher result. Do not squeeze the finger when you are taking blood, because if you squeeze, you are taking out the tissue fluid more than the blood, and this will definitely produce a reduced reading. Don't ignore any symptom, even if you obtain a normal glucose reading. Now, this again is very important. If you have symptoms, your reading still do not show that hypoglycemia, that doesn't mean you do not have hypoglycemia. Immediately do some corrective measure and also send the sample to the lab. Train the patient not to avoid glucometer checking after dietary indiscriminate. This is very, very common in self-glucose monitoring. Patients try to avoid whenever they have taken some sweets, and this will produce a very erroneous, or it will be, my doctor will be scolding me why you have got this thing done. So they avoid when they know that the glucose is likely to come more. Rather, they should learn that what they have done wrong can produce high glucose values, and they should avoid this thing. So take-home message, SMBG measurement by glucometer has become an integral part of diabetes management, and it's very, very useful. Modern glucometers are accurate to a large extent, but the fallacies are also very common. Fallacies may be due to faulty use of device, or maybe because, and may be avoided by patient and staff training and education. Fallacies are also due to limitations in the technologies used in the glucometer, and this cannot be helped by us. And the FDA also allows some 10 to 15% error up or down from the reference, and so the glucometer readings may be up and down by 15%, even in FDA-approved glucometer. In critically ill patients, or whenever in doubt, you should always cross-check the glucometer readings with the lab readings. So thank you very much. I think I made things easier for you to understand. Thank you. And thank you again, Hormone India, for giving me this opportunity. Thank you.
So thank you, sir. With this, we are calling it a day and closing hall 2. So we'll be back tomorrow with the full day on adult endocrinology. So thank you for joining Hormone India conference. So, okay, so we can close this now. Thank you.